Good morning and welcome. Thank you for joining us for our 9th annual Child Abuse Conference. My name is Belinda Waters. I'm the Trauma Program Manager here at Covenant Children's Hospital. We wish we could see your smiling faces right now, hopefully next year, although I remember us saying that last year too. Thank you for spending the day with us and for your interest and passion in caring for children that have either been abused or neglected. This conference is presented in collaboration between Covenant Children's Hospital and the South Plains Coalition on Child Abuse Prevention. So for your welcome this morning, please welcome Dr. Amy Thompson. Dr. Thompson is the CEO of Covenant Children's Hospital here in Lubbock, Texas. She has championed major initiatives as the CEO, such as the creation of Covenant Children's as a freestanding children's hospital, obtaining a level 4 neonatal intensive care designation, obtaining a level 4 maternal care designation, and then continuing our re-verification as an ACS level 2 pediatric trauma center. She's also supported the elevation of surgical care through participation in the pediatric NSQIP. Dr. Thompson is also a board certified pediatrician, and in her spare time, she also continues to practice as a hospitalist at Covenant Children's Hospital. So please welcome Dr. Thompson.
All right, good morning. So I echo Belinda. I wish we were all here in person. I think we're closer than we were maybe last year. Maybe last year I was just overly optimistic. So but thank you guys so much for joining us. Like Belinda said, I'm Dr. Amy Thompson, and I'm a pediatric hospitalist by training, and now am privileged to be the CEO at Covenant Children's. I will tell you, this is the event. I'm so happy we have it. I'm so happy we put it on. And it is my one event that I wish we could get out of. And what I mean is, I wish that we could make such a difference and such a decrease in child abuse, especially in our region. I always say that this is the one conference that I'll be super happy if someday we have to stop having because we don't have this issue anymore. But those of you who are on the call today and on the video understand that that's not what is true in our region, in our state, in our country, but specifically today, we want to have a focus on some things that are happening in Lubbock County and surrounding counties, and just want to continue to come together so that we can make a big difference for child abuse. I'm so happy for the South Plains Coalition for Child Abuse Prevention. Thank you guys for partnering with us and putting this on. This is the 9th year that we've had the Child Abuse Conference. I think you're going to find it a very good day of learning and many things that are going to come from today. So Belinda talked a little bit about what it is that we do as a hospital, and I will tell you my experience as a pediatric hospitalist is, sadly, I think when I got into pediatric hospital medicine, I don't know that I was prepared for the amount of child abuse victims that we were going to see on our service. Sadly, I've had to testify at many court cases and things, and this has really been, as a physician, something that's kind of right in my backyard of things that I've had to deal with. But what we want to partner with, and I always say our goal, I always say my goal is that we don't have to have this conference, but it's also true that what I wish as a children's hospital is that we didn't have to see victims of abuse. And one of the things that we're really going to highlight today is all of the work that so many of you do to try to prevent child abuse. The very best outcomes that we have for child abuse is if we stop it before it ever gets to the hospital. So that's the thing we really want to focus on today, and how it is that we can partner together so that those kids never actually show up at hospitals like Covenant Children's to get care. I talked about my greatest hope. My greatest hope from this is exactly what I said. Let's cut the numbers so much. Let's prevent so many things that we don't have to do this kind of work. So I'm very excited for the day ahead of you. You've got some fantastic speakers. I do want to thank you so much for all the speakers that have come and are going to share with us. We do have some friends from Cook Children's who have also made their expertise available to us. And there's so many great things that you guys are going to learn today. I hope next year I get to see you in person. Next year will be the 10th year that we've had this, and I hope my greatest hope is that what we can talk about is how those numbers are continuing to go down. So thank you guys. Thanks for joining us today, and I hope you have a blessed day.
Thank you so much, Dr. Thompson. So as a member of the South Plains Coalition for Child Abuse Prevention, which from now on, I'm going to say Child Abuse Coalition instead of the whole name. I'm afraid I'm going to get tongue-tied. So I've been a member of it for about 8 years. And so we wanted to talk about that a little bit because they do work with us, or we do, the coalition works with us at Covenant Children's for this conference. So the coalition is comprised of more than 30 community entities who serve children and families in our region. Its mission is to provide advocacy, education, and to build collaborations within communities that improve the safety and well-being of children and youth. One of its major initiatives is this conference. So when the Go Blue Lubbock efforts in Lubbock were started in 2013 by the Child Abuse Coalition, it was important for the coalition to honor the work and effort of individuals that are striving to improve issues around child safety, and the Cherish the Children Award began. So since that time, we've been able to honor with that award some outstanding individuals for their work in our community around the issues of child safety. Some of our previous award recipients were former state senator and Texas Tech Chancellor Robert Duncan, State Representative John Frullo, Senator Charles Perry, Criminal District Attorney Matt Powell, Child Abuse Pediatrician Dr. Patty Patterson, the Honorable Judge Kevin Hart in Lubbock, Lubbock Police Department Detective Kyle Perdue, and child psychologist Dr. Michael Gomez. This year, for the first time, we could not overlook the work of two outstanding individuals, so the coalition decided to honor two individuals this year that will be receiving our Cherish the Children Award. Carla Olson, who is the Executive Director of the Parenting Cottage, and Lubbock Mayor Dan Pope. So I'd like to share a few highlights from the nomination forms that were submitted for these two individuals. So our first one, Carla Olson, was nominated by members of the Trauma Services Program at Covenant Children's Hospital. Again, Carla is the Executive Director of the Parenting Cottage and previously served as the chairperson of the South Plains Coalition for Child Abuse Prevention. Carla's passion, desire, and motivation to advocate for the prevention of harm and neglect to the vulnerable children in this community just blows us away. Her knowledge of legislative issues and processes, how decisions are made in Austin, how those will affect the families is very impressive. She has been one of the driving forces behind the coalition. Her efforts have been and continue to be instrumental in bringing child abuse prevention efforts and funding to Lubbock County. She understands how collaboration with other entities can improve outcomes for children. Carla truly has a servant's heart and wants to make Lubbock County a better place to live by assuring that the families in our area have the resources that they need to be able to thrive. We do feel like Carla Olson is the face of child abuse prevention in Lubbock area and is most deserving to be honored with the Cherish the Children Award. Our next recipient is Mayor Dan Pope. He was nominated by the Advocacy Committee from the South Plains Child Abuse Coalition. Dan Pope has been mayor of Lubbock since May of 2016. He did miss the first 2 years of Go Blue Lubbock, but since becoming mayor, he's participated and been involved in the Go Blue Lubbock efforts every year. With his leadership, both the city and county of Lubbock have become more involved in Lubbock Go Blue initiatives. That is the formula that's needed when you work in communities that we've seen have been successful in reducing child abuse and neglect. It always has to be a priority for the leaders and the stakeholders within the city or county to really be involved. When you listen to the comments that that Mayor Pope has delivered at the kickoff events and at our child abuse conference in the past, he's participated in these, and it's obvious to those watching that those comments were not just words. It really does mean a lot to him. He speaks from his heart about the tragedy of abuse and neglect, and he sees with clarity the faces of the smallest children in our community that have been affected by this. Especially when we have our children who have become fatalities due to abuse and neglect. Child abuse is a difficult issue to turn around. Without a doubt, we still have work to do, but for sure, Mayor Pope's efforts and participation have been a tremendous kickstart. And we feel like that Mayor Pope is definitely deserving of this award. So congratulations to our two award recipients this year. So we're going to kind of kick off, get ready to get started with this conference. These are disclosure slides for our continuing education. We are providing continuing education for the following, and people can read these: 4 hours of CME for the physicians, 4 hours of CNE for nurses, 7 hours for licensed professional social workers, 7 hours for emergency medical technicians, then hours for law enforcement, and that's something that they apply for through TCOLE. This gives the information on how to do that. And then 6 hours for licensed professional counselors. The speakers and the planners of this activity have no relevant disclosures or financial interest. This activity, again, is being provided by Covenant Health, collaboratively with Covenant Children's and then the Child Abuse Coalition. There's no commercial support has been received, no products will be endorsed, and no off-label drug use is going to be discussed. To receive contact hours, you need to view the presentation in its entirety, complete the evaluation, and then claim the credit that's associated with the extent of participation, the number of hours that you participated in the activity. At the end of the conference, you will be asked to complete surveys to obtain continuing education or the attendance certificates. These surveys are very important to us for the outcomes, being able to analyze the outcomes of our conference. And so we do want to ensure everyone, specifically this year, we really took to heart our evaluations last year and recommendations. So many of our speakers and topics we chose because that reflect the recommendations in the conference surveys from last year. So our first presenter today is Dr. Nancy Trevino. Dr. Trevino is director of the Texas Tech University Health Science Center Mental Health Initiative, which works to establish clinical, educational, and research opportunities. She is a certified instructor for mental health first aid and youth mental health first aid with designations in emergency medical services, higher education, and rural communities. As a researcher, her interest includes adolescent development, teen pregnancy prevention, and trauma-informed practices. She has spent much of her career working with youth in the foster care system. Dr. Trevino will be presenting a discussion on mental health challenges and solutions. Please welcome Dr. Nancy Trevino.
Can you hear me okay? Okay. So first off, I'd like to thank you guys for having us here, for offering the opportunity for me to come and talk about mental health challenges and some of the solutions that our community have been working together to come up with to address not only mental health challenges, but through addressing mental health challenges, we will be able to also reach a lot of other factors that contribute to child abuse, including mental health and aggression and things of that nature. So just a little bit about what we're doing. So today's talk, I will share important information about mental health. So I'll talk about some statistics and I'll try not to bore you or put you to sleep with those. We'll talk about a brief overview of what the Texas Tech Mental Health Initiative is, how we came into being, and some of our current work. We'll talk about some collaborations and the impact of those collaborations, and then we'll have a couple of minutes for some questions if any of those come through. So why is mental health important? With COVID and with so many of the things happening in our society, we know that mental health challenges impact millions of people each year. And that's not something that is just here in our local community or in our region. This is something that's happening across the world. And so we know, looking back at our own community, that only about half of Americans with some sort of mental health disorder receive the treatment they need. And when we're looking at half Americans, that's not just the adult population, that's also children. So we know that people that need mental health services, there is a lag in some of them receiving the care that they need. Part of that, especially something that impacts our West Texas region, is that 134 million people live in what is designated a mental health professional shortage area. And those shortage areas just mean that there are counties where there are not enough mental health providers to provide care for the people that need that care. In West Texas, we have our Texas Tech Health Sciences Center and our Texas Tech University that are working to train and educate people to become mental health providers. And part of the work of the Texas Tech Mental Health Initiative is supporting site-based training opportunities and developing those relationships so that mental health providers that are in training and completing their training hopefully stay within our community. We know another reason that mental health is important and seeking those services is because suicide is the second leading cause of death for people that are ages 10 to 34. So we're looking at a 10-year-old, that's going to be our 4th or 5th grader. And then our 34-year-olds, that's going all the way through our teenagers, all the way to our young adults that are in our college population. And then if you think about what is a 34-year-old, where are they in life? We know that they're young professionals. Many of them have started families. So suicide is something that is impacting a lot of people across the lifespan, especially those that are a huge chunk of our young people. We also know that mental health challenges impact not only somebody's mental health, but also their physical health. And we know that it has far-reaching implications, not only for the individual, but also for their family, their community, and society at large in the world. And there are a lot more statistics if you're interested in knowing more of the details through the World Health Organization. NAMI has some really great one-pagers if you're looking to share that information. And they have great things that you can share on your social media as well to help bring awareness, especially you'll see a lot more of the awareness components for mental health that will be linked to Mental Health Awareness Month, which is coming up in May. So these statistics are pretty alarming. Some of them are looking at not just what's happening in our community, but just in our nation at large. But our local community really started having these conversations about mental health and the importance of services long before any of the Texas Tech Mental Health Initiative was even something that we were able to come and work to develop. So through a lot of those conversations across the Texas Tech system and with our community stakeholders, Texas Tech identified that they wanted to work on an initiative to address mental health challenges. So Texas Tech Health Sciences Center, in partnership with Texas Tech University, developed the Texas Tech Mental Health Initiative. And our vision is to do what we can to reduce the impact of mental health distress, neurotransmitter-related illness, and addiction in our community. But we also understand that there are social determinants of health, including several factors that contribute to poverty. We know education, access to care, all of those things also impact our mental health. So this was all even before the pandemic that Texas Tech system wanted to be a leader and work toward helping reduce those impacts of mental health challenges. So some of how we plan to do that and our vision is through collaborative activities. So we're happy to be invited to this child abuse conference because this is part of what we plan to do for collaboration with education, research, and through service. So our mission, you can see here, has many components to it. We want to be sure that we start with promotion, so that awareness, making people aware of the challenges, how many people are impacted by mental health challenges. A recent statistic I read earlier this week was 1 in 5 and 1 in 6, 1 in 5 adults and 1 in 6 children are impacted by mental health challenges right now. We expect that was based on 2020 numbers. Once COVID was really ingrained in our society and our communities. We expect to see that number increases with the 2021 data. We also want to work in prevention. So what can we do to support families and children and adolescents as they are just dealing with normal distress in life and those stress factors? So what are some healthy strategies that people can implement into their daily life to prevent the crisis situations? We want to have, we actually do play a role in treatment at all levels, especially as we talk about training and producing more mental health providers for our community and our region. And then support people in recovery. So once you have had a mental health challenge, recovery is possible. And there are some strategies that you can implement to help prevent yourself from escalating into another crisis situation. We also want to improve access to integrated care. We want to help support knowledge and skills of those individuals working in mental health services. So that's part of our mission with presenting here today. We want to enhance public's understanding of mental health, what it is, and reduce that stigma. And then we want to be sure that as public policy is developed and programs are funded and supported, that they're based on our statistics and our needs and evidence-based practices. So all of that is just to say we're really willing to partner with the community. We want to make sure that we are doing our part to be good stewards and to be helpful in addressing mental health challenges. I talked a little bit about this being a partnership of Texas Tech University and Texas Tech Health Sciences Center. We have a lot of internal collaborators from across the schools that are working in a lot of different areas to address mental health. We were working with the School of Medicine, the Department of Psychiatry, Pediatric Department, Family Medicine. We have the School of Health Professions where we are working to train LPCs and LCDCs. We also have a School of Pharmacy looking at substance use, School of Nursing that is playing a role in this as well. And we have several people at TTU that we're partnering with, Psychological Sciences, Social Work, Political Sciences, School of Law, College of Human Science, and the Community, Family, and Addiction Sciences program. College of Media and Communication. We have several partners that we're working with that we're excited about some of the new initiatives that are currently being developed, and we're excited to share those with you when we have the opportunity to. But our work doesn't just stop with Texas Tech. We work with external collaborators as well. So we have several partners here in our community. You can see that you see the Covenant Health. We have the Star Care Specialty Health System, so our local mental health authority. We have City of Lubbock, County of Lubbock, UMC, and these are just a small list of some of our partners working with us, from veterans mental health to family services, all the way up to education and prevention, and then some St. Francis is working with our youth and foster care as well. So we're really excited to have a lot of these collaborators that are partnering with us to address mental health and substance use disorder across our community and across our region. Again, this is just a small list of some of our partners. We have several other partnerships and collaborations that are currently in development and that have been very strong partnerships for us in helping move this work along. Part of what our community has done is very early on, probably 2018, a group of community parties came together and commissioned a needs assessment. That needs assessment was conducted by the Meadows Mental Health Policy Institute, and they spoke with over 200 stakeholders in our community. They asked about strengths for addressing mental health challenges. They asked about some of the challenges. What are we lacking? What are some of our gaps? And they were able to identify some areas of improvement for us and make some recommendations on next steps that we could take to improve and further develop our mental health care system. That full report is available on the Texas Tech Mental Health Initiative website, and we can share that link in the chat later today. But part of what they found in our in our report was that Texas and Lubbock, Texas specifically, our region, had very strong partnerships and a great spirit of collaboration. So we had a lot of partnerships going on, a lot of collaborative projects, but what we could improve was our coordination of those collaborations. So that's part of what the Texas Tech Mental Health Initiative has done. We've been working with our community stakeholders to really streamline what is occurring so that we reduce that duplication and really fill those gaps that we had. And so with that, one of the recommendations was to have a group of stakeholders who could really give the green light for us to move forward on initiatives. And that group is now the West Texas Mental Health Collaborative. And the community parties that I just talked about commissioning that report, they are what we now term the founding parties of the West Texas Mental Health Collaborative. And you'll see some of the logos that I showed earlier for external collaborators. Those are some of our founding parties. So the City of Lubbock, Lubbock County, Starkhurst Specialty Health System, UMC, Covenant Health, Texas Tech and Texas Tech Health Sciences Center. And then we also have a clinical consultant who is Dr. Wakefield from the chair of the Department of Psychiatry. And then we also have the Community Foundation of West Texas that participate in this collaborative. The collaborative has really worked toward improving mental health care based on the recommendations of the Meadows. So there are several projects that are underway. Not only is the collaborative continuing to meet on a monthly basis to discuss progress, but the Meadows have come back. Meadows Mental Health Policy Institute came back into our community, did some additional focus groups, and we are working on developing our strategic plan for addressing some of the work that still needs to be done in our community for mental health services. Texas Tech has also been invited to participate in the Texas Child Mental Health Care Consortium. So this is something that's really exciting. It's a statewide initiative that is working in 5 main projects. One of the initiatives is the Child Psychiatry Access Network, or CPAN, and that provides telehealth-based consultation for our primary care providers. So if they have a child or an adolescent in their clinic that they believe is experiencing mental health challenges, they can call the CPAN line and have access to a board-certified child or adolescent psychiatrist within 30 minutes. So the goal of that project is to make sure that a kiddo can leave clinic with a treatment plan. And that can include several different components. They can also be referred back to our team for additional screening and assessment related to mental health. We also have the Texas Child Health Access through Telemedicine, or the TCHAT program. That is an initiative that Texas Tech has what they call legacy program for. And so we have our CATER program, which was rolled out through as the TCHAT model. So there were some slight modifications because we know every region is a little bit different, but this is a program that provides telehealth to children and adolescents through school-based partnerships. And you can see that Texas Tech Health Sciences Center here in Lubbock has the largest geographic coverage area of any medical school within the Texas Child Mental Health Care Consortium. So that is the dark burgundy area that includes the Panhandle, West Texas, and parts of the Permian Basin that we are working in those areas to roll out all of these projects. Again, I don't think I'll take a step back. The consortium is a collaboration of all of the Texas public medical schools. So we're really excited to be a part of that. So these TCHAT initiatives are not just something that's happening here in West Texas, but that's something that's happening across the state. We have a research project within this that's looking at depression and suicide, and then also childhood trauma. And so we're really excited about what will be the findings from the Childhood Trauma Research Network, because that will be related directly to the work with child abuse. But we also are looking at COVID and the impacts of COVID, looking at even other natural disasters like floods and tornadoes that have occurred in our state. We're also looking at workforce expansion through the CPW project. So that is really partnering with our local communities across the state of Texas to provide additional mental health services. And then we have the Child and Adolescent Psychiatry, or CAP fellowships, and that is really to grow the workforce at that highest level. So individuals are able to come in and specialize in child and adolescent psychiatry once they finish their psychiatry residency. So this is a really great opportunity. In the first biennium, or the first 2 years of the project, we were able to offer 9 additional slots across the state of Texas. So we're excited to see how many more providers are trained through this project across the state of Texas. So that's just kind of an overview of the consortium's main initiatives. Recently, they're going through the finalization of the award process for additional ARPA dollars. So there's an American Rescue Plan Act funds that are available to states. The state of Texas has prioritized mental health, and so the consortium will be receiving additional funds to support projects in the CPAN, TCHAT, and workforce expansion initiatives. And so some of that will include trauma-informed additional services that are bilingual services. And it will also include growth for adolescent substance use project, and also very similar to the model that's used for the CPAN line, we'll have a professional consult for pregnant and postpartum moms. So we're really excited about the growth and development that we're going to be able to continue to see with the consortium, not just in our local community, but also across Texas. Working together, we're growing those partnerships with HHSC, so Health and Human Services Commission, and some of our other partners across the state, so that we can build sustainable projects that are really able to support families and children and adolescents where they are, with the services that they need in the time that they need them. So that's kind of an overview. It's a little bit interesting. At most conferences, I'm used to having an audience, and here I'm talking to the camera in a room. So that's, please excuse what seems like maybe a little bit of uncomfortableness. So there's a lady now across from me looking up at me. So thanks for your patience with this. So looking at the impacts and benefits of the Texas Tech Mental Health Initiative, you see here there's linkages, and there's a lot of different people that are making up those links. That's really what the Texas Tech Mental Health Initiative is here to do. We're here to build those connections across our local community and across our region to make sure that the right people are at the table, so that they can be sure that whatever we develop related to mental health services is really what our families and our communities need. So it's not something that is just what we think will work in our academic institutions, but something that will help all families and individuals within our community. And this is something that's not just a Texas Tech initiative. Or a Texas Tech Health Sciences Center initiative. This is something that each community organization can play a part in. So with some of our external collaborators, you saw that we had our United Way. They are partnering with us for some education across the community. So we're offering mental health first aid with the United Way. They've also partnered with us for our West Texas Regional Mental Health Conference that we hosted last year, and we're gearing up to host again this year. That'll be an annual educational event related specifically to mental health in a lot of different areas. Last year, our conference talked about how to track for child and adolescent mental health. We had a crisis response track. And we also had a track for looking at special populations, so the LGBT population, our veterans, a lot of different groups that we know have unique needs when we're addressing their mental health services. But we also are working with some of our other partners, like our partners at Family Counseling Services and some of our other organizations across the community, and our private practitioners, to make sure that as they are providing services to family, that they are best practices, that they're the most recent developments in what we know can address the mental health challenge specifically that families are facing. So if it's anxiety, we want to make sure that the treatment can help develop skills so that you can reduce your levels of anxiety. And those strategies can be implemented on a daily basis to help improve your mental health and your ability to function in your daily life. We also know that trauma impacts our lives a lot of different ways. And so we want to make sure that as we provide services, that they're trauma-informed services, that those unique factors that we know are can be long-term implications of experiencing trauma are addressed. So those are some things that we're working to help with training of our providers on, in addition to implementing that into our own curriculum at the Texas Tech Health Sciences Center and Texas Tech University. So we're working on that. As we partner with some of our community agencies, we're giving students the opportunity to see firsthand how their work improves the community through those site-based training opportunities. And so those site-based training opportunities we have a student that's completed all of their coursework, and then the last part of their training is usually what we call a practicum or an internship. And so you may have had interns in your organizations. They go in and they use the training that they've had to gain experience in the field. And once they have some experience in the field, we're really hoping that they fall in love with what they're doing and with your organizations, and that maybe you can have the opportunity to hire them on to stay in our community. And we have projects like that across all of our Texas Tech Health Sciences Center sites. So we have a site in Amarillo, in Lubbock, in the Permian Basin, and in Abilene. So that's across all of our initiatives and all of our programs. We have that component with our partners in those communities. So if you're interested in a partnership in one of those areas, please feel free to reach out and we'll see what we can do to get you connected with the appropriate program. And see what we can do to recruit some individuals. So that may be another part that you can play within your organization. As we look at some of the other impacts and benefits of the Texas Tech Mental Health Initiative working with our community, we're also working with getting the right statistics to individuals so that they are sure to support the programs that will most benefit our community. And so some of that is through research, and a lot of our research is working within our community organizations. And then working with our policy makers to make sure that the services that are supported in our community really are the needs of our community. So just talking a little bit more about our community work, the Texas Tech Mental Health Initiative has been working to engage new collaborators and then also work to maintain the current collaborations that we have. So we talked about the West Texas Mental Health Collaborative and working with the founding parties of that organization. We've also developed 2 work groups within that group to look at substance use disorder and then to look at crisis response. And so we have some really exciting projects coming up. One of them is the Hope Center for Health and Wellbeing, and that is going to be a mental health crisis center here in our Lubbock community. And at that crisis center, we will be able to screen individuals. The community will be able to come to that center and say, hey, I'm experiencing some mental health challenges, and I need some help. And when they ask for that help, some of what we'll be able to do is have them sit down with an individual that will do a screening with them and determine what their needs are. And one of the things that we're trying to do in our community is make sure that once people are screened and that they need mental health services, we connect them with the appropriate services at the appropriate time. If we can work on improving that, we will be able to hopefully reduce the number of people that end up in a crisis situation. So that Hope Center for Health and Wellbeing will be a place where you can go if you are in crisis. If you have a family member who is experiencing suicidal ideation, or what you generally hear of is they're suicidal at this point. We can help them get to the appropriate services, but we'll also be able to help families that say, I think my kid is using substances, but I'm not 100% sure. Can you help me find out? If somebody goes in there and says, I'm having trouble, my kid's having a lot of referrals from school, what can we do? We'll be able to assess them or connect them with another program. With our school districts, we have over 175 schools, over 175 school districts that we're working with, which we're working with middle school, high schools, and some elementary schools. So that is really exciting to be able to refer people back so that their school can be involved in some of their treatment, make sure that those kiddos are supported in ways that will help them be successful in the classroom, and their families will be less stressed and also be healthier. With those healthier relationships, healthier communication, and a lot of those services within our community are not just something that we provide clinical services, but we also support and make referrals to other supports, such as housing and job career placement opportunities. So we have a large network of partners for that. We also are working to identify new partners and invite them into the infrastructure that we're developing. And then we are working using this collective impact model. So you can see that we all are working toward a common agenda. And a lot of what we have identified is based on that Meadows report. Some of our partners will focus on one area. Some of our partners focus on multiple areas within the Meadows recommendations. And so we all work toward a common goal, and we're always welcoming and inviting new partners to join us in this work. Part of what we're doing, we talked a little bit about research. And so looking at shared measurement for data and results. We want to make sure that we're doing things that are actually improving the community. So talking about research with community partners. I don't want you to think that that's something boring or something, why do I have to do that? We really try to make sure that our partners are able to use the information that we're collecting to be able to be accountable to their funders and partners. We also want to make sure that we can measure how we're improving the community. So we are happy to partner for those kinds of opportunities. We have reinforcing activities, so definitely things, educational opportunities, awareness events, to make sure that people know the progress that we've made. And we'll be sharing more of our updates as time goes on, because now we've been doing our work for a couple of years. And so we're really excited. COVID was the focus for a little while, but now all of our partners are working on mental health specific initiatives. We are making sure that we offer technical assistance and capacity building. So that's part of why we're talking about mental health at a child abuse conference, is to make sure that individuals understand how mental health and trauma are all connected. We also, like I talked a little bit about, those research collaborations to make sure that we are all accountable and moving toward the actual target that we're moving toward. And then we work to convene, and that's really getting the right people at the right table at the right time with education and training. So I have the opportunity to take questions. I can also talk a lot more about any of these initiatives, but I wanted to give some opportunity to answer the questions that you have. Bear with us. It's the first Q&A of the morning.
Thank you so much, Dr. Trevino. I'm so excited that we're going to be able to get improved mental care for our patients here, especially our pediatric and adolescents. And I'd kind of discussed it with you some, and we've definitely seen that uptick. And we have not had the facilities or the ability to take care of them like we used to. So we're so thankful that y'all are getting this started.
Yeah, we're definitely working, but we're not working alone. We have a lot of our partners that are working with us. And as we work on making improvements, we're really trying to make sure that they meet the needs of our community. So working with Covenant Health, we're hearing about what's happening in the ERs,
Yes.
what's happening in the family clinics, and we're able to make sure that we support individuals in the ways that they need. So as they are getting stabilized after a crisis situation where they might end up in the children's hospital or at the ER, what can we do to support them as they leave that so that they don't end up back in the ER?
Right.
But it takes a little bit of time to get all of those projects developed and to get them implemented. And then once they're implemented, they may need a little bit of tweaking because what we see and what we try to implement may not be 100% on target for what we need for our community. We may need additional services or additional supports or additional partners. And so we're really working to develop those. So as we work to improve it, we can see steps and phases of improvement, but please be aware that we really need patience and support and feedback as we continue to develop all of these projects.
I know it'll be baby steps each time, but just looking forward to the non-necessity of having to have inpatient and all of those kind of things and help preventing those serious incidents. So yes, thank you very much.
Yeah, definitely.
So I think we do have some questions.
Okay.
There seems to be a gap in services for mothers. Medicare ends shortly after birth, before postpartum depression may be recognized. Are there resources or changes in Medicaid? I'm sorry, I think I said Medicare first, but it's Medicaid.
So there are, I told you that we are working with policy with the Texas Tech Mental Health Initiative. This last legislative session, there were some changes in the 1115 waiver, which supports some of those services. And with that, we were able to, we had a lot of individuals that were weighing in on that. There are some new funding streams, and so there will be some policies. I'm not exactly 100% sure about all of the details of that, but I do know that pregnant and postpartum moms, there were some changes to their insurance coverage, but I can't speak to exactly what those were. But I can say that one of the continued projects that we're working on is that new professional consult line, which will be the Perinatal Psychiatry Access Network. And that'll roll out across Texas, and Texas Tech Health Sciences Center and Dr. Wakefield from Texas Tech Health Sciences Center will be serving as the statewide medical director for that project. So we're really excited to have our expertise and our programs here that are informing what's happening across the state. So we expect that that model for the Child Psychiatry Access Network, that's not something that we developed here. That's something that's been showing promise across the nation in lots of different states. And so we implemented a model that was very similar to the one happening in Massachusetts. And in Massachusetts, when they implemented that line, they saw a significant reduction in the time it took to actually see a child and adolescent psychiatrist. It went down from something like almost a year to within a couple of months. So we know that's really vital. And within our own programs here at the Texas Tech Health Sciences Center, if we have a kiddo that really has that need to see a child and adolescent psychiatrist, that's something that because we have several on our team, we are able to facilitate that process happening even quicker. So we know that access to psychiatrists, we have a lot of individuals, especially our primary care providers, that will make a referral to a psychiatrist, but we know that that's not always the appropriate level of care. So getting the person to the level of care that is appropriate for them at the time that they need it is our goal. And so we have not only our child and adolescent psychiatrists at the table, we have our psychologists, we have our LPCs, we have our PCPs that we're working on doing additional training and having them have access through that CPAN line. But we're also working with our schools because there are several things that our school districts have been also mandated to do recently related to mental health. So we're helping support those projects so that wherever a kiddo needs help and wherever they are identified, we have some level of service or some referral process to get them to the appropriate services at the appropriate time.
And one of the questions in the chat is, could you talk more about connections with CPS and foster care?
Yes. So in the state of Texas, we've gone to community-based care and the community-based care model. And so I know at the consortium level, we are working to bring in related projects from the Department of Health and Human Services at the statewide level. So we have some of those individuals at the table as we develop these initiatives. But I know locally, working with St. Francis, we're looking at what we can do to help mental health services being more accessible for those youth in foster care. I know with some of our other projects, we have juvenile justice. And so those individuals, those kiddos that are what we call multi-system youth, so they're involved in both the justice system and the foster care system, are also being connected with services. So we're really trying to work with the stakeholders that are doing work in those areas so that we're not reinventing the wheel and we're not having duplicative efforts. We're really having synergistic efforts across the systems that are already in place to help get kiddos to the right services. So as we develop our programs on our initiative and our workforce, we want to make sure that they are accessible and that the protocols for whatever's working within those systems, we have a way to feed them into the appropriate services.
Is there an estimated opening date for the Hope Center?
We are really excited about the Hope Center. It can't open soon enough, really and truly. But we are working on a timeline for that with COVID and getting to be able to actually build the facility. We're working on that process. It's just taking a little bit longer than we want or than the community wants. StarCare Specialty Health System is working as the leader in that project. It will be, I can tell you that the Hope Center will be out at the Sunrise Canyon Hospital campus. So beautiful area in Lubbock, and we're really excited for that to occur. It will be very close to the inpatient facility that we have out at Sunrise Canyon Hospital. But our goal is really our intensive outpatient services and connecting people to those prior to needing inpatient care. So I don't have an exact date for you, but you will be hearing more about that very, very soon.
Is there a list of referrals or resources that has been put together to help facilities look at or go into a fast case need for clients to get help?
One of the things that we really encourage individuals to do is plug into the network of referrals that we already have in place. And so if it's a kiddo in one of our TCHAT schools, we would encourage you to send them to their school counselor or their school nurse to ask for services and to let them know that they are having mental health challenges. The funding through the Texas legislature is specifically for, at least with the TCHAT project, for school-based initiatives. So that's the referral process for that. You can also go back to your physician, so your primary care provider, and ask them about, disclose to them that you're having some mental health challenges. They're your medical home. They can be able to help you address some of those early concerns. But if they can't, they can also call that CPAN line to get additional support and to really consult on what could be done in an individual's case. With the CATER website, there had been referral lists on that. But we have to update those frequently, and so I believe they are not available at this time. But there are tons of referrals, and we really want to make sure that the right referral is made. So please use the programs that are in place. And as we have more infrastructure developed, we will hopefully be able to have a comprehensive list. But that's changing as we have additional providers that are being trained, additional partners, and additional sites. So we want to make sure that we give you the most current information, and that's the best way to get it, at least at this time.
Dr. Trevino, law enforcement spends a lot of time addressing behavioral issues in the homeless and that have mental health issues. Is there a chance of integrating services to keep the homeless who have mental health issues out of jail?
So just to give you a little bit of background, the Hope Center is actually part of our conversations for crisis response. And so the police, the sheriff's office, all of those individuals are stakeholders that are at the table as we discuss the Hope Center and what that can be, because we know that there's a lot of people that end up in not only in jail, but also in our ERs that have mental health challenges and need those services rather than being put in jail. So as we look at what we can do for our kiddos through the consortium and those projects here locally, we're also looking at what we can do for adults. And so the Hope Center, I think, will be a great starting point for a lot of those services. Some of our partnerships are the city, so not just the police, but also the LBK community, the Lubbock Health Department, all of those in, and the Lubbock City Health Department. All of those guys are working with us so that we don't duplicate efforts, and so that we can really make sure that those referrals are done to the appropriate resource. And part of those are making sure that people don't end up in places that they don't need to be, or in services that they don't need. So we're really trying to improve that, but that's one of the areas that we're looking at is that crisis response and making sure that people with mental health services get the appropriate services. Some of our other partners work in different areas related to mental health. So we're not just looking at people that provide therapeutic services or inpatient care. We're also looking at getting people with co-occurring disorders some additional services that they need to be healthy. So with substance use, we're looking at substance use treatment for those individuals with co-occurring mental health challenges and substance use disorder. We're also looking at those complex cases. So individuals that have mental health challenges and physical health concerns like diabetes or high blood pressure. So we're looking at improving all of those, but we can't do it alone. So we're working with our partners. And there's exciting things in the works for our kids and for our adults through specifically the Hope Center, and then our children's initiative with Covenant as well. So lots of exciting things.
Yes, thank you.
Kind of touching on what you just said about the children, we know that children's mental health services are almost non-existent currently. And those without insurance are the ones who are affected the most, I feel like. What are some resources that we currently have? And like you just said, you kind of mentioned some of those we're working on long-term, but what do they currently have for those?
So our network includes a lot of providers, and there's a lot of, there are several clinics. We are in a shortage area, so there's never enough providers, right? But with our services that we have in our community currently, through a partnership with the United Way, we have family counseling services, which is a clinic in our community that provides services to the population that you were just talking about that do not have insurance. So that's one of our local resources. But we also have our Texas Tech clinics. We have our Texas Tech Psychological Sciences. They have a clinic. We have our LMFT clinic on Texas Tech campus, and we have our psychiatry department over at Texas Tech Health Sciences Center. All of those individuals take Medicaid, and so if you are uninsured or underinsured, many times we can help navigate that process to help you get insured. We have several partners that are some of the insurance plans for Medicaid or CHIP that are happy to partner with us to see what we can do, see if somebody's eligible and help with that application process. So there are opportunities for people to get insured under those programs so that they can access services. But we also have some of our community providers, and then we also have telehealth services. So a lot of our regions, maybe insurance or funding is not a challenge for those individuals. They have insurance, they just don't have a service provider. We're able to provide telehealth services. So it seems like, oh my goodness, we don't have any services, but we really have more services than probably we realize, just because of accessing services. And if you recall, one of the things that I told you the Texas Tech Mental Health Initiative is working toward is making those services more accessible. So part of that is better education on the services that are available. So we're happy to, somebody asked about a referral list. You can always email me and I'll share my email here. I'll do that now, so that you can email me if you have questions, and I'll do my best to be like the traffic controller at the airport and send you to the right program, or get you the right referral. But we do have a lot of services at different levels. And now that COVID has impacted all of our communities, there's some additional funding for mental health services, because we know that not only was the economy impacted, but individuals, as they lost jobs or as they had their kiddos at home for an extended period of time, we had those factors that contributed to more mental health challenges, or greater need for services for those mental health supports. Maybe you don't need medication, but you just need to talk to somebody for a short amount of time. And so we are working to develop and train more providers, and then also to make sure that those services are available in our community. I know that the city also, the city of Lubbock, for people that live in the city, can access the mental health voucher program. So if they don't have funding, they can access a provider through that. And I believe that program is facilitated through Catholic Charities here locally. So there's some resources depending on what your situation is. Like I said, there are some that are funded through the state, some that are funded through the city, some locally. And then if you have a risk for substance use disorder or substance abuse, the City of Lubbock Health Department also has the Susan program. And so with Susan, they do a screening and assessment for your risk of substance use or substance use disorders, and then they can make a referral to the appropriate services. And I know they fund detox all the way through therapeutic services, and they have another network, the LBK community, that is a referral source that's done online. And so they have several organizations that are a part of that. And I know they are also extending additional invitations to organizations that want to participate in that, so that we can have that referral process be smooth and seamless, but not just for mental health services, but some of those other social supports and even physical needs, such as transportation and housing. So that goes back to what's happening with our homeless population. They can seek services through some of these other ways, or even if you need rent assistance. Sometimes some of the other programs that provide mental health can refer you or partner with another organization to have a more comprehensive approach to addressing your needs, not just your mental health needs. Sure.
Is there focus on bringing providers to the community that provide trauma-informed therapy services for children and youth?
Yes. So we are working on trauma-informed bilingual services. That's one of the expansion projects related to the consortium. So that will be funded through ARPA. So we'll have an initial support for that project for 2 years. So as we work with those individuals, we want to make sure that if there's a way that we can make those permanent in our community, that we work toward that. So as I talk about partnerships, we definitely are looking not only to have partners that we can refer to, but also as we look at sustainability, we want to make sure that those partners that can help us make these projects sustainable, that we build them in a way that they can stay. So trauma-informed services are one area we're looking at. We're also looking, as we train our new providers and our new providers at all levels, that they're using trauma-informed practices. Because we know with our ACEs study that was done over 30 years ago, when the CDC did a replication study, they found the same findings. We have a high number of people or high percentage of people that are impacted by some sort of adverse childhood experience that can have long-term factors, long-term implications for their health, their physical health. We know that they have higher rates of heart disease and obesity and things of that nature. So we want to make sure that as we provide services that they are trauma informed, so that we can reduce the risk of some of those long-term complications.
When is it expected to have the perinatal line?
I cannot give you the exact timeline on that specific initiative because we are still working to find the system for that funding will come to us to be able to support that line. So I'd like to say very, very soon, and I'm sure we will have additional press releases, not just in our local region, but also across Texas when we get that program up and going. So there will be more on that. That is something that is still in the works. When we started rolling out the consortium projects from the Texas Child Mental Health Care Consortium, we got funding for 2 years. And I know the first year was really developing those protocols and working on implementation and hiring staff. Now we have that infrastructure, so once we are ready to go live with that project, it should happen really quickly, and it won't take us a year for that. We will be hitting the ground running. We already have some of the infrastructure developed, and we already have some conversations for planning on that project. And like I said, Texas Tech Health Sciences Center here in Lubbock was selected as the leader for that project because of our expertise and our infrastructure, our current infrastructure. So hopefully very soon. And again, just like with the Hope Center, it's not soon enough, but it'll be very soon.
Is there an estimated date rollout for the professional consult line for the child adolescent group? And will this be pushed out by TDSHS?
So the line for the professional consult for child and adolescent, so the CPAN line, that is already live across Texas. If you go to the CATR website, and that's CATR at Texas Tech University Health Sciences Center here in Lubbock, you can get more information on that. There's a flow chart of what that referral process looks like and what additional services there are for both that telemedicine with the schools and the CPAN line. So one of the things that is occurring really is that we're working to enroll more of the providers so that they are more aware. We've sent out faxes, they've done emails, they've done packets, they've done visits, and so we're still working to get the word out for that as we've been developing our infrastructure and our team to be able to communicate about that. But if you have a provider that you work with and you're interested in enrolling your clinic and your providers in that, I know that our CPAN team at Texas Tech Health Sciences Center will be more than happy to help you walk through that process. And we do have partners at Texas Department of Health Services, or that TD, the group that they asked specifically about. So we're working on making sure that they get the right information to be able to push that out as well. But that consult line is specifically for providers. So that's not something that the community can call into. That is for our providers to have that professional consult. So it works in a way that is HIPAA compliant. So that's not something that we can provide services to community organizations or community individuals. It is strictly for providers.
One of our attendees has actually used the program, that CATR program, and they said it was a saving grace for their family, but they felt like maybe the 4 sessions that they're provided is not enough sometimes, and it could be due to the therapist being in short supply. Are they looking at extending these services?
So the 4 sessions, that's not something that was in our heart, that we're just going to give you 4 sessions. It is actually how the program is set up and supported and written by Texas legislature. So that's not something that we have a lot of wiggle room with. But with the ARPA expansion dollars, one of the projects that was put in was additional sessions. So that is something that we are working on, is having, and the TCHAT project, that school-based services, is time limited. So the goal of that project is to get individuals the services they need, screened and assessed, and then refer them to follow-up care in their own community. But we know with the shortage that we have, especially in our region, we need telehealth services. So we often continue using our own providers and make the referral to our clinics. But we also, with those ARPA dollars, are looking at expansion so that it's beyond those 4 sessions. And the screening and assessment that's done is not a session. So we're really excited to be able to offer additional services, but we also are aware of what we can do and how we can provide long-term services through referrals.
I believe that's all of our questions. So again, we want to thank you so much. Again, personally, for us that have worked with our children with mental health challenges, then we really appreciate all that y'all are doing and excited to look forward to what's coming. Thank you again.
Thank you for having me.
So our next speaker is Lilia Castillo. Lilia Castillo is a graduate of Texas Tech University. She has worked for Texas Department of Family and Protective Services, or DFPS, Child Protective Services since 2007 in several capacities, including working as a CPS investigator, instructor, and supervisor. Lilia currently serves as the program director for CPI investigation for Texas Region 1. This includes the Lubbock and Amarillo area, so it's a large region. Ms. Castillo will be discussing child abuse investigations and outcomes. And thank you for coming to speak with us.
Good morning, and thank you everyone for attending today's conference and for your role in protecting children. Today we will be covering child protective investigations. We're a branch of the Department of Family and Protective Services. My focus today will be on investigations. Some of the items that we will cover will include reporting, definitions of abuse and neglect, investigation priority, a brief overview of the investigation process and the outcomes of investigations, and community-based care. So ways to report are the statewide abuse hotline. That would be the 1-800-252-5400. You can also report online, which is the www.dfps.texas.gov. We do recommend that if it's an urgent situation and an immediate response is needed, that the hotline be used rather than the online reporting. There is sometimes a delay with online reporting. That could take sometimes 24 to 48 hours before the statewide intake worker is reviewing those. So if it's an urgent matter, we do recommend using the 1-800 line. Who must report? Any person who suspects that a child has been abused or neglected by any person must report the suspected abuse or neglect. So there has to be a situation when reporting, when statewide intake takes the call, they will ask specific questions to an incident. It can't just be a gut feeling. There's got to be an actual situation that's occurred. Are there injuries on the child? Are there statements made by the child that indicate that there might be abuse or neglect occurring in the home? Information that's needed when reporting. The more information you have, the more helpful it is for the department. If there's a lack of information and we're not able to locate the family, then that case can get screened out or closed out based on the lack of information. So information that's needed when reporting is child's name, date of birth, ways to locate the child, specific nature of harm or risk to the child, the parent's name, any locating information for the parents, name and address of the person alleged to have harmed the child, names of any other family members that may be able to care for the child or children. The more information you have, the better it is for us to make contact. So some of the legal matters regarding reporting and reporters. Reports of child abuse or neglect made in good faith and without malice are deemed confidential and protected under the Texas Family Code. The law provides for immunity from civil or criminal liability for persons who report even unfounded suspicions as long as a report is made in good faith. Professional reporters are required to report within 48 hours of first suspecting abuse or neglect. So the reporter remains confidential. After we make contact with the parents sometimes will try to put two and two together and try to figure that out. So if the reporter is from the school and the report reads in a certain way, the parents will try to figure that out, but that information remains confidential and protected. I believe in my experience in investigations, I've only been asked about the reporter's information in a courtroom one time. And the judge immediately did not allow for me to answer, and I did not disclose it. So it remains protected. So we try to use as much discretion as possible to keep that confidential, even when talking about the allegations with the parent. Failure to report suspected abuse or neglect is a Class A misdemeanor punishable by imprisonment of up to 1 year and or a fine up to $4,000. So it is, if you suspect it and you guys are also mandated reporters, you should be reporting any suspected abuse or neglect. So we'll go through the statutory definitions of abuse and neglect here briefly, and then we'll cover what is deemed who is responsible for the child's care, custody, or welfare. That can be a parent, a guardian, a managing possessory conservator, a foster parent. It could also be a member of the child's family or in the household, a person with whom the child's parents cohabits with, school personnel or volunteers, personnel or volunteers at a public or private child care facility that includes services for the child. We also do school investigations. Those really get assigned to our special investigators, but any abuse or neglect that occurs in a school setting and the educator is an alleged perpetrator gets investigated by our department as well. Investigation priorities. So when you contact statewide intake or that hotline number, or when you make an online report, each report is prioritized. There's priority ones and priority twos, and then priority nones, which we'll talk about priority nones. Priority one is that there's an immediate risk of abuse or neglect. There's, either current danger or imminent danger is possible, and contact is needed. The department is required to make contact within 24 hours of a P1 being received. These can require joint investigation with law enforcement, and there's immediacy behind it. Priority two, these tend to be lower risk, and there's not an immediate threat of serious harm or death. We have 72 hours to make contact on a priority two case. On no priorities, these cases may come in and maybe they've been investigated. When you guys contact the hotline doesn't research the prior history for the family. And so once it comes to the local office, we will look at that. If it's been investigated before, then that case will likely not be opened back up for an investigation. Alternative response is a stage of service within investigations, and it's a different way of how we respond to abuse and neglect reports. It allows for a more flexible family engaging approach. It's less adversarial and more collaborative with the family. In traditional investigations, we go to the schools, we'll go see, if the children are in daycare and we know what daycare, we can go see them without prior notification to the parents. We are required to notify parents within 24 hours after making contact with the children. AR is a little bit different. AR starts with a phone call. So our first contact with the family is a telephone call, letting them know that we received a concern regarding their household, and we visit with the family, try to make an appointment with them. We have 5 days to make contact and schedule that meeting. They're allowed to bring, their supports, and it's really a family collaborative effort with the department. Response to the reports initially appear to be low and moderate risk. There's not, imminent danger that exists. Those cases would not qualify for alternative response. There's no case disposition or designation of an alleged perpetrator of abuse and neglect in an AR case. No one is added to the central registry as a result of this intervention, and the family engagement, again, is more collaborative. If there's safety concerns that are identified throughout the alternative response case, such as, let's say in our meeting, one of the children makes an outcry of sexual abuse, that case no longer qualifies to go the AR route and would be progressed to a traditional investigation, where a joint investigation would take place with law enforcement. So we'll start with physical abuse. As we go through statutory definitions, I'll spend more time on some of the ones that we see more often, and less time on the ones that we don't really see. There are, I think, about 2 of them that we haven't seen recently or we don't investigate enough of. But I'm happy to answer any questions you guys may have at the end. Physical abuse. A child suffers physical injury that results in substantial harm to the child, or there is a genuine threat of substantial harm from physical injury to the child. Both include an injury that does not logically match the history or explanation given. It excludes an accident or reasonable discipline by a parent, guardian, or managing possessory conservator. That does not expose the child to a substantial risk of harm. There's no laws against spanking. Parents are allowed to spank. Our recommendation is no spanking. But if you are going to spank, that it be with the hand on the bottom with clothing on. There's been many situations, many examples where a parent did spank and used a lot of force, resulting in a physical injury to that child. So if that child sustained any bruising, any kind of marks, and the child makes an outcry or whoever reported it, that leads to a joint investigation with law enforcement to see if physical abuse has occurred. One of the cases that I had many years ago, the child who was 6 years old couldn't sit down in class. Like, she would put her hands under her bottom and, would say her bottom hurt. The report came in, and it came in as a priority 2 because there was no identified injury. The only reason I made contact was because it was a Friday and I didn't want to wait until, the weekend to go make contact. So I went and saw the child at school and she wouldn't sit down. So I took her to the nurse's office. Once we got to the nurse's office, she was solid purple. So what was just kind of a standard, like she said she got spanked, turned into a very serious case of physical abuse that resulted in the removal of her and her siblings from the home. A person fails to make reasonable effort to prevent an action by another person that results in physical injury causing substantial harm. So the case example that I just used, the stepmother was also present when that child was spanked. So she's just as culpable as the parent who did the discipline in this situation. A person or persons currently using a controlled substance. We see this a lot with prenatal exposure. It would fall under physical abuse. So a mom who's pregnant is using any kind of controlled substance, methamphetamines, cocaine, would fall under physical abuse. A person or persons cause, express, permit, or encourage a child to use a controlled substance. We see these a lot with parents who give, sometimes they're teenagers, drugs and alcohol, and that's where this would qualify. Examples of physical abuse are pushing, shoving, slapping, punching, choking, kicking, hair pulling, beating, burning, biting, prenatal use of alcohol, drugs, causing harm to the infant upon birth, failure to stop the abusive actions by another, and excessive physical discipline causing substantial harm or genuine threat of harm. What CPI uses to determine physical abuse is age, the vulnerability of the child, location of injury, pattern of injury, injuries in various stages of healing. The explanation provided, is it consistent with the child's developmental capabilities? The example that I gave you guys of the case that I had, the child was spanked with what was a paddle. When the detective and I got to the home and we asked the father who did the spanking to present the paddle, it was actually a 2x4. So based on the child's statements, what was a paddle, what she described as a paddle was a 2x4. It had drilled holes in it. And so when she was interviewed, she got in trouble for not putting away her socks correctly. And so this was all parts of this, the age of the child at the time, the location of the injury, and then the explanation provided with her developmental. She was a 6-year-old who got in trouble for not putting away her laundry. The next slides will be injuries on some children. So I want to give anyone a fair warning that they are somewhat disturbing. So if you need to look away, I wanted to prepare you for that. So this is just an example of physical abuse. This was not my case, but as you can see here, this child was spanked, suffered, lots of bruising on her bottom, thighs, and lower back. This child was slapped. And so usually if there's injuries on the ears, that's indicative of abuse. I mean, anytime I see that, that's a huge red flag for me if I see that. This one, I believe the child was spanked with some kind of cord or hanger, if I recall. And I say spanked, all his injuries are in his back, so he was hit. This is an example of extension cord injuries to a child. And so all of these would fall under the category of physical abuse. Moving into emotional abuse. Emotional abuse occurs when one or more of the following is true. A child suffers a mental or emotional injury that results in an observable impairment in the child's growth, development, or psychological functioning. These are very difficult to validate. We require mental health experts to provide us with their expertise on whether if a child is self-harming, if a child is developed an eating disorder based on statements that the parent has made. One example that I had, the dad was constantly putting one of the children down and she ended up developing an eating disorder. Every day he would, tell her, how fat she was, how overweight she was, and it resulted in her being hospitalized and losing too much weight. And so the mental health expert was able to articulate that she developed this disorder by dad's emotional abuse. A person or person cause or permit a child to be in a situation in which the child suffers a mental or emotional injury that results in observable impairment in the child's growth, development, or psychological function. So, in the case that I just gave you the example, there wasn't a mom, but if there had been a mom in the home and hadn't intervened, then she also could be validated for emotional abuse for allowing it to happen and not intervening. A person or persons currently using a controlled substance in a manner or to the extent that results in mental or emotional injury to the child. Sexual abuse occurs when one or more of the following is true. A child experiences sexual conduct harmful to the child's mental, emotional, or physical welfare, including conduct that is an offense under the Penal Code of sexual abuse of a child, indecency with the child, sexual assault, or aggravated sexual assault. A person or person fails to make reasonable effort to prevent the sexual conduct, or a person or persons compel or encourage a child to engage in sexual conduct. A person or persons cause, permit, encourage, engage in, or allowing photographing, filming, or depicting of a child, or if the persons knew or should have known the resulting photograph, film, or depiction of the child is obscene or pornographic. A person or persons cause, permit, encourage, engage in, or allow sexual performances by a child. All of these would fall under sexual abuse. Our sexual abuse definitions come from the Penal Code. So we do work jointly with law enforcement in these cases. Dynamics of sexual abuse include grooming behaviors, elements of secrecy, threats implied or explicit, a wide range of sexual behaviors. We include the child's development when we're talking about sexual abuse. Some of the reports that we get is when a child, 3 or 4 years old is masturbating. Now, are they masturbating or are they exploring themselves? There's differences in what we're looking for. Now, is the child making certain statements, sexualized statements, that would indicate that there is sexual abuse going on? So there's a lot that comes to that when we're assessing for sexual abuse. We team up with the Children's Advocacy Center to schedule forensic interviews. And so that's where a lot of the screenings come from. Signs and indicators of sexual abuse could include physical symptoms such as STDs, early or unexpected pregnancy, signs of trauma to genital areas such as bruising or bleeding, behavior indicators, age inappropriate sexualized behavior or knowledge, and the victim's outcry or disclosure. So the first person to hear outcry is termed as the outcry witness. And so that could be anyone here, it could be an educator, it could be a relative, or who the child discloses to becomes the outcry witness. Sex trafficking occurs when a person or persons do one or more of the following: knowingly cause, permit, encourage, engage in, or allow a child to be trafficked in a manner punishable under an offense of the penal code. So that, again, this goes back to that sexual abuse, but this is where the parent or caregiver knowingly allows or causes or encourages the child to engage in this. Failure to make a reasonable effort to prevent the child from being trafficked, compelling or encouraging a child to engage in sexual conduct under the penal code statutes of sexual abuse. This can include prostitution, solicitation of prostitution, and compelling prostitution. At-risk youth that afford sex trafficking that we have seen are children that have unstable living situations, previously experienced a form of violence such as sexual abuse or domestic violence in their homes, runaways or are involved in the juvenile justice system or child welfare system. A lot of our foster care children who run away from their foster homes are at high risk of being victims of sex trafficking. Undocumented immigrants facing poverty or economic need, have a caregiver or family member who has a substance use issue, and if the youth is addicted to drugs or alcohol, these youth are at risk of being victims of sex trafficking. Labor trafficking, this is one we don't really see. In my time, I don't think I've seen one of these, at least in our area. But labor trafficking occurs when a person or persons do one or both of the following: knowingly cause, permit, encourage, engage in, or allow a child to be trafficked in a manner punishable by an offense under the penal code. Some of the examples that I've heard in those larger areas is children working in sweatshops for an extended period of time, 12-hour days, with limited breaks, limited lunch, like no lunch. The working conditions are hazardous, and the parent basically is allowing their child to work in this condition. That would be labor trafficking. Again, I haven't seen that in our area, but I do know that it has happened in some of the larger areas. Forced or coerced marriage. Forced or coerced marriage abuse occurs when a person or persons force or coerce a child to get married or to marry a specific person. Again, haven't seen this very often. In 2008, we had the FLDS investigation that happened in El Dorado, and it was the minor children that were married to adult men. And the department investigated, and several, I think over 50 children were removed at that time. So I don't know if you guys recall that, but that's where this would fall. I was a part of that investigation. I went to interview a lot of those children. And so, getting even those outcries from them was difficult and challenging, but that would fall under this statute. Neglect. Neglect is an act or failure to act by a person responsible for the child's care, custody, or welfare, evidencing the person's blatant disregard for the consequences of the act or failure to act that results in harm to the child or that creates an immediate danger to the child's physical health or safety. Most recently, the legislative meetings, all those came out in September. And so we had some changes on the terms of blatant disregard. Blatant disregard is the real significant harm to the child as a result of the person's act or omissions that meet the following criteria. Would have been obvious to a reasonable person in the same situation. The reasonable person would have known to take precautionary measures to protect the child from the impending harm. Physical neglect is the failure to provide a child with food, clothing, or shelter necessary to sustain the life or health of the child. This excludes failure caused primarily by financial inability unless relief services have been offered and refused. So those families that are impoverished, low income, struggling and trying to make the means to provide their financial stability. If they're without utilities or, their plumbing doesn't work, they don't have water due to some issue in the home, or they don't have the income to pay for that, that does not necessarily mean it would fall under physical neglect. Now, if they've been offered resources and declined it, then it would fall under physical neglect, because now they're refusing the relief services to ensure that their children have food, clothing, or shelter. Physical neglect also covers unsanitary environments or hazardous conditions, and those would fall under physical neglect. So here you'll see an example of a home that we've been in. Depending on the age of the child would determine what the outcome of this case would be. If we have a 1 or 2-year-old, that would be a serious concern for the department, and our intervention would be needed. If we had a 17-year-old in this home, that intervention might look different. If we have a wide range of a baby to 17 years old, then there would be intervention because we do have younger children in this home. And I believe this is all the same house. This is kind of the kitchen area leading into kind of the washroom. And that was their restroom. Okay, moving into abandonment. Abandonment refers to a parent, guardian, or possessory conservator of a child leaving the child in a situation where the child would be exposed to an immediate danger of physical or mental harm. In such cases, the caregiver leaves without arranging the necessary care for the child with no intent to return. When we get our Baby Moses cases, it falls under abandonment. Baby Moses has very strict laws and criteria regarding when it would be Baby Moses. Abandoning a child, after you've had a baby about 8 months and dropping them off on someone's porch would fall under abandonment, and we would have to make the efforts to locate that parent, validate them. There could be criminal prosecution against that parent for abandonment. Medical neglect is the failure to seek, obtain, or follow through with medical care for a child resulting in or presenting an immediate danger of death, disfigurement, or bodily injury. The failure could result in an observable and material impairment to growth, development, and functioning to the child. Refusal to assume parental responsibility. This is when the person responsible for a child's care, custody, or welfare fails to permit the child to return home without arranging for necessary care after the child has been absent for any reason. This includes having been in a residential placement or having run away. We see this a lot with our youth, usually about 12 and up age group, who have, challenging behaviors, maybe defiant, some violent behaviors, youth with mental health issues that are involved in the juvenile justice system and are violent, maybe not necessarily to themselves, but are violent with maybe the younger siblings or violent towards the parents. And the parents have exhausted everything and have tried to find him placement, have tried to work with the juvenile justice system, and aren't able to have this child return home. That would fall under refusal to assume parental responsibility and could be looked at turning the child over to the department. There are strict criteria for that to happen, and the parent has to exhaust all means necessary to find a placement for that child before the department takes custody. Exclusion to neglect. It is not neglect if a person responsible for the child's care, custody, or welfare does any of the following. If a parent refuses to permit the child to remain in or return to the child's home when the following are true: the child has severe emotional disturbances, the person's refusal is solely based on the person's inability to obtain mental health services for the child, and the person has exhausted all reasonable means available to the person to obtain mental health services. So again, what I was talking about when we talk about those youth that have severe emotional disturbances, some defiant behaviors, violent behaviors, they're violent to the siblings, violent to the parents. They don't say part of the juvenile justice center and parents have exhausted everything and it's no longer safe for that child to be in that home with their siblings and parents can't have that child return, then the department will do what we refer to as a wrapper case or refusal to assume parental responsibility. And the department takes custody to try to find this child the best placement. All of these criteria have to be met to not be validated for the refusal to assume parental responsibility. It is not neglect if a person responsible for the child obtains an opinion from more than one medical provider relating to the child's medical care, transfers the child's medical care to a new medical provider, or transfers the child to another healthcare facility. So if we have a parent who sees a doctor and the doctor wants these follow-up things or is going to admit the child and the parent disagrees with the physician and takes the child to a different facility, and we get a report that they left against medical advice. And once we make contact, if we find that the family is seeing a different physician, then that would not be medical neglect, as if they did seek a second opinion and they have a right to seek a second opinion. And so under this exclusion to neglect criteria is where it would fall. Allows the child to engage in independent activities that are appropriate and typical for the child's level of maturity, physical condition, developmental abilities, or culture. I believe legislation came out with this exclusion to neglect. The example was that I guess mom had a job interview and I believe left the children home alone for a couple of hours. I don't know when the children got out, but we ended up with an investigation and the mom was validated for neglectful supervision for leaving the children alone. And so it was seen as that the department was scrutinizing mom in so many ways because she was trying to do better. And because of their ages, I mean, I don't believe that they were smaller children, but they were school-age children. Would that be neglect? Was that considered neglect? And so this was added on as that if a child is dropped off at the park, while mom runs an errand, would that fall under neglect? So again, allows the child to engage in independent activities that are appropriate and typical for the child's level of maturity, physical condition, and developmental abilities or culture. That would be an exclusion to neglect. Every case is different, and so we look into those situations. We look at the child's development. I've had a 16-year-old that was left home alone who had the functioning of a 4-year-old. And so in that case, while his age might say differently, his functioning level said that he should not have been alone. So after we get these reports from statewide intake, they assign an allegation that we look into, and then the investigation process begins. Once we determine that the case qualifies for an investigation, it is progressed from a report or intake into an investigation. We determine the nature and extent of any harm to the child, assess immediate safety and risk to the child in their current environment, and pursue any interventions necessary to ensure safety and reduce the risk. Some of the tasks that are completed, all interviews of all children are done in the home, or they can be done at all the children. Let me correct that. We have to interview all children that live in that home. So while our victim child may be just the 12-year-old, but there's 4 other siblings, we have to interview those children as well. We observe those children from head to toe. We document our observations, document our interviews of those children. We have to interview parents and caregivers and any other household members that live in that home. So if mom has a paramour that lives in the home, if there's an aunt that lives in the home, they all have to be interviewed. Interviews with collaterals and references. Collaterals is what we use as references. So we'll ask parents, give us, some people that can tell us about your family and about your household and what kind of parent you are. And they'll provide, some relatives or friends or people who know them. And then we'll contact them as well as part of our investigation. We complete home visits, both announced and unannounced. We complete background checks for all caregivers and all household members, 14 and up. Consultations with medical, law enforcement, and other professionals are also completed in investigations. We assess safety and risk of the child's current living circumstances and then make a determination on whether referrals for services or ongoing intervention is needed. When we make contact, we identify that there's a concern, we try to do the least restrictive intervention. Removal is always the last resort. So if we get out there and there's not any abuse or neglect that we've identified, then we usually no intervention is required. We may just be providing the family with some resources and end up closing that investigation. If there is a danger that's identified or an ongoing risk that exists, then we can implement a safety plan. Parent and child must remain in the same home under a supervision safety plan. We'll talk about some of the specifics of a safety plan as that has changed as well, and when a safety plan would be best implemented. We could utilize protected family members to help in our plan for ongoing safety of the children. We could have the alleged perpetrator leave the home. We could have the protected parent leave with the children. We can also have the parent make a decision to place the child out of the home with relatives or a fictive kinship person. And the last resort is removal. We always try to avoid removal. We want to keep families together. We want to keep children with their families, but ensure ongoing safety. So removal is last resort. Safety plans. Safety plans are implemented when a danger exists in the home. It allows for either or of the safety measures below to be implemented. A parent and child remains in the same home with supervision in place. So if we have a safety plan in place, it's 24/7 supervision. If we're going to have mom supervised due to drug use, then she's supervised 24/7. It's not, just 8 to 5. It is 24/7 supervision. Parent-child moves away from the danger to a safe environment. We see this a lot, I think, when we have either unsanitary home conditions and they can no longer stay in this home, that they stay with relatives or somewhere else that's a safe place until the environment is deemed safe, or domestic violence. If there's domestic violence in the home and we have to, move mom and children out to a women's shelter or a relative or somewhere that's a safe place and they're out of that environment where the perpetrator of violence is remaining in the home. And then lastly, a parent-child safety placement is in place and there's a safety plan outlining supervision between the parent and child. So this one is when the children are placed out of the home voluntarily by the parent. The department does not have custody. It's the parent's agreement to place the children out of the home. And so the parents stay in their home and the children go to either a relative or friend or whoever the parents would like the children to go to. Thorough background checks are completed on any placements, and so they have to pass those checks before we approve that as a parental child safety placement. Dispositions. So at the end of an investigation, after interventions are put in place, we make a determination on the findings of an investigation. They'll either be reason to believe, ruled out, unable to determine, or unable to complete. This is the stats from fiscal year 2020 for the entire state of Texas. 61% were ruled out in 2020, 28% were validated for abuse or neglect, 10% were unable to determine, and then 1% is unable to complete. Unable to complete is when we cannot contact the family or the family is uncooperative or they cannot be located. So it's a very small percentage. Most of the time we can locate them. There's some cooperation or we have enough information to make a determination, even if they're semi-cooperative. After we disposition a case, we determine whether an investigation will close, whether the family needs ongoing services, or whether removal is needed. Family-based safety services, if we're not going to close the investigation, but we feel like the family still needs services, or we have a safety plan in place and we want to ensure that they receive counseling or parenting, drug education classes, maybe mom's in treatment and trying to, get sobriety, we can offer family-based safety services. And this is where the department does not have custody, but the family is willing to work with us and complete services to strengthen their home, to have a better and healthy home, and provide the best care for their children. It's designed to maintain children safely in their homes. They can also be in a parent-child safety placement under family-based as that is temporary. And once the parents are making progress, the children eventually get returned into the parent's home. These services are provided directly by the department through contracted service providers, referrals to community-based providers. They're offered to the family when a child is at risk of abuse or neglect. A child may be in a relative placement outside the parent's home. So family-based is just a different stage of service in DFPS. And lastly is removals of the children. If the child cannot remain safe in the home, a safety plan is not possible. Maybe the family is not cooperative and they're, tying our hands and we're not able to implement safety measures, then this can result in a removal of the children. And this is where the department takes custody of the children. And this could be emergency without an order. So if we have exigent circumstances, such as mom and dad get pulled over and there's methamphetamines in the car, we can't get a hold of anyone to be a placement, and we don't have a caregiver to release to, then the department can take exigent circumstances and remove the child at that time without a court order. We would have to file for a court order the next business day. Emergency with a court order is when we have a situation where we know we need to do a removal. Maybe mom's not offering us any placement options, is not willing to sign a safety plan. There's danger that exists, but it's not exigent at this time. Then we'll get a court order first signed by a judge and then remove the children. Non-emergency removals is something we used to have. Those went away last year, and so we no longer have non-emergency removals. After a child is removed, they become part of our conservatorship, and so the department is a conservator of these children. Region 1 is in stage 2 of community-based care, so St. Francis is our contracted provider. St. Francis is the one that locates our placements. They do the case management for the conservatorship stages. They offer adoption and PAL services as well. We're only the 3rd region in the state to be in stage 2 of community-based care. Questions?
One of the questions we have is, would marijuana be included in the list of drugs that are considered physical abuse?
Yes.
And what is considered a professional reporter? What falls under the mandated reporter status?
Professional reporter is medical staff, educators, anyone working with this family, any professional setting. So even a therapist, if they're a counselor, they see this child, that is a professional reporter.
And so, I'm sorry, with EMS and law enforcement entering a lot of these homes, it just kind of makes me wonder if they're seeing things inside these homes, they would need to call. The slides you showed were a little disturbing. So
Yes.
if they walked into something like that, they would need to call and report that, correct?
Absolutely.
Okay.
Absolutely.
And one of the questions someone wanted to know if you were able to share your slides.
Yes.
Okay. And then I think the last question I have for you, I think there's some other questions in the room, but we see a lot of kids that come in that have been involved in a car wreck that may not be restrained properly, their parents are intoxicated, or maybe they're not even of legal age to be driving. What do we do in this situation?
So you should be calling 911 first thing, and then calling the hotline. Usually by the time you're calling the hotline and we're getting out there, the scene has been cleared. So if you can call your local office and kind of say, here's what we have, then we can get an immediate response that way. Typically law enforcement will call us. It just depends on what law enforcement agency we're working with. But my recommendation is to call the hotline immediately, and you can even call the local office and say, here's what we have, just because, like I said, by the time we get that report, there's a lapse in time, and so our contact is usually at the hospital hours later.
So these are things that you guys need to know about.
Yes.
Okay.
Absolutely, especially if we have a parent that's intoxicated and child wasn't restrained, and we've had child death cases where parents were intoxicated, and we had a surviving sibling. We ended up removing the sibling because of that circumstance.
You made reference to there being multiple reports of a similar case. What kind of feedback is given to a reporter so that they understand the difference between need for repeat reports versus resolution of a case? Say if it's a neighbor or someone that sees repeated instances.
So reporters don't get a lot of information. We can give you a very standard, there were concerns. There's a letter that's sent out at the end of an investigation to the reporter that says, thank you for your concern. We will continue to be working with the family. But it's just a very standard statement. There's not, we removed the kids or anything like that. It's just, you can kind of read the letter. The letter was like, we ended up closing the case. Thank you for your concern. But it's just a very generalized, no information is released about the ongoing case to the reporter unless that reporter is remaining involved as part of the family support.
Is it okay to call the hotline if the situation is questionable to seek their opinion, if it needs to be reported or not?
You could call them. They're probably not going to take it if you're trying to just get an opinion. But I would say make the call and let them decide on whether it's a report or not.
What follow-up is done when reporting a person under the age of 16 who's pregnant? And when does this report need to be initiated?
As soon as it's learned that the youth is pregnant, and it just depends also on the circumstances. If the youth is pregnant by someone of the same age, that may not meet the criteria of abuse or neglect. If the youth is pregnant by an adult, that will qualify for sexual abuse and also neglect.
And I think most of us call the 1-800 number when we're calling. Is there additional numbers locally that we need to be aware of?
My information is here that you can reach me, but our 10th Street office is the investigation for CPI. That's where our investigators are housed. And that's the 10th Street office here in Lubbock that you could call locally. Most of the time, if you're calling locally and it's something immediate, then we can get a supervisor on the line. If you're calling to try to make a report through there, you're going to be routed back to the hotline.
So I know we have those numbers at Covenant Children's so that we can reach someone, especially if maybe there's another sibling. We're afraid that something could happen to that sibling. So yes, we have to use them a few times, and we do appreciate being able to have that information. I didn't see any other questions. So thank you very much, Leah. We really appreciate it. It was a lot of great information.
Thank you.
Next, we are going to be having a panel discussion. We have 3 members that will be on the panel. So our 3 members, Carla Olson, again, Carla was the one that received the Cherish the Children Award. And she is a graduate of West Texas A&M. She has over 25 years of experience working with nonprofit community services, particularly services with at-risk or underserved populations. She is currently the executive director of the Parenting Cottage, and again, previously served as the chairperson of the Child Abuse Coalition. And she will be discussing abuse prevention and community resources that are available. When I said that, it also made me think about, Leah discussed that they avoid removal if at all possible. We used to have people that were afraid to report. They said they didn't want to be responsible for getting parents in trouble or having the child removed. So we just always try to emphasize that CPI also has a lot of resources available that they can offer to the families to help them. So that's great that they have those resources to be able to help out. The next panel person on the panel will be Derek Danner. He attended Texas Tech University and served on the Lubbock Police Department for 26 years, including as a detective in the juvenile crime section. He currently serves as the executive director of the Child's Advocacy Center of the South Plains. And Mr. Danner will be discussing abuse prevention and community resources also. The other panel member is Lauren Westerberg, and she is a graduate of Texas Tech University. Ms. Westerberg has served as an advocate for children who are victims of abuse or neglect since 2007 and is currently the Chief Program Officer of Court Appointed Special Advocates, or CASA, of the South Plains. And then again, she will also be on this panel. And thank you so much, to all of you for coming in. We really appreciate it.
So good morning. I think all three of us are glad to be here this morning to talk a little bit about the prevention side of child abuse and neglect, and also to let you guys know about some resources that are available in the community. You know, sometimes that intervention needs to come a little bit sooner down the road before families get in crisis, and that truly is what the prevention side of it is. So we want to start first by just asking the question, how are the children? The true measure that we really think of what is the state of any community is how the children in the community are treated. If the children are treated well, you usually have a solid community. So this morning, that's really what we want to look at, the state of our children in Lubbock County specifically, and then look at some resources that you guys may be aware of, not aware of. Some of our resources are going to be before the abuse and neglect occurs, but there's also resources that are needed after that abuse and neglect occurs. So when we just look at a helicopter view of Lubbock County's children, there's 73,000 children in Lubbock County. They face a lot of adversity, poverty, food insecurity. More than half of these students are designated as economically disadvantaged by the public school systems. We see a lot of single parent homes, births to mothers with late or no prenatal care. That's almost 1 in 3. And then when we specifically look at child abuse, this is just for 1 year when we look at that. So we measure that in the number of children per 1,000 children. So you can look at any community and compare it against a state rate and get a picture. So in Lubbock County, ours was 12.7. That came back to 970 children in 1 year. And the state rate was 9. So we're still well above that. I think in looking at the different DFPS regions, that puts us pretty high. Then you look at the number of children that we had in foster care during that same 12-month time period, 1,172 children. That's a lot of children. So the state rate is 6.4, 15.2 in Lubbock County, so more than double that. One of the statistics that always bothers me is looking at the reunification rate, because that's ultimately what you want, is to be able to reunify those families, that the parents get some skills and or, you know, some basic needs are met, and that eventually those families can be reunified. So that means that we're only hitting about 1 in 3 of those families affected by abuse and neglect where there is removal, that those families were able to be reunified again. So again, when you look at just Lubbock County, just the number of investigations. So there was over 2,200 of those. They were able to rule out. CPS was 54%. That's a good statistic, but that means that there was still quite a few left. So again, we confirmed 970 victims through investigation, and age 5 and under was more than 52% of those. So those are our most vulnerable children. You know, a lot of them don't have verbal skills. They can't tell you, they can't do an outcry. So definitely the most vulnerable of the children. And again, this is not changed from what we've seen in the past, but, you know, of course, the people closest to those children end up being the perpetrators of the abuse and neglect. So in this case, in 2021, those parents were 72% of those cases. And the hardest number, I think, for all of us to look at is the child fatalities. So that was 4 in just this 1 year. I think it's interesting, you know, if you just look at your own little region, you may not be aware of what's going on across the state, but DFPS divides the state of Texas into 10 regions. And so we have Lubbock County, but we also have the Lubbock region, which takes in about 45 counties around us. So that's where you really need to see the comparison outside of just what's going on in your little individual home. So we plotted across for you so that you could look at it, because you don't move the needle on a statistic like this really, really fast. So if you start programs, it's not going to work within that 2-year legislative period, which sometimes our legislators think. So it took a long time for us to get in the shape that we were in. If you look back in 2011 in Lubbock County, the rate of occurrence was 20.5. So that's almost 21 children out of every 1,000. So it's taken us 10 years or more to get that down to 12.7. And there's some reasons behind that that we'll look at. But also look at your fatalities up there. In 2021, statewide, 199 children. The year before that, it was 251. We're still kind of out to lunch a little bit on what the effect of COVID had. What I hear from my colleagues up here and also from DFPS also is that, you know, overall the reporting went down. So although we might be proud of that 12.7 number, we're not sure how solid that is in terms of, was it actually less abuse and neglect, or was it actually less reporting? And again, just looking at the type of abuse makes a lot of difference. You can see what's going up and what's going down. Like, for instance, I discussed with Derek at a podcast we did the other day on this, that I noticed sexual abuse was up 2% from the year before. That 2% may not sound like a lot. That's a big jump in our kind of statistics and our kind of numbers. So you see small numbers or small percentages, excuse me, in abandonment, emotional abuse, medical neglect, refusing responsibility. And then you see both physical abuse and sexual abuse actually at about 10%. But overall, the one that jumps out to you is the neglectful supervision. So obviously when they do a case or do an investigation, that case could have more than one type of abuse or neglect. So when we look at sometimes the number of cases, the number of victims can be different than that, or a sibling is involved or something, but it's on the same case. So, but obviously you can have more than one type of abuse on that too. So neglectful supervision is what I try and explain to laypersons as we talk about this in the community. It's more about, it's a very important term, but it's where we can group, it's a catch-all term. So it could be the legal definition says something in terms of when you place a child in a situation where a normal person could perceive that that child could be hurt or injured, that's neglectful supervision. So it can be a lot of different things. It can be domestic violence. It can be mom didn't have a babysitter that day, and she went to work and asked the elder sibling to take care of it, and that didn't happen. It's a lot of different things, but obviously that's what's building the number of the caseloads too. So the biggest question that I often get, and I think my colleagues up here do too, is, well, this is horrible. This is happening in our community. Why are we letting this happening? What are we doing to prevent it? And why did we let it get as far as it has gotten? And what's our plan for success? And so in that respect, you have to go back and look at the history of prevention. And that has to do with DFPS as an agency itself. It was formed as an investigative agency. And then in about 2009, they said, oh, by the way, you need to do prevention also. but it only comprised about 1 to 1.5% of their budget. So of course, when mandated budget cuts would come down from the legislature, it said, cut your budget, every agency 10%. Well, guess what got cut? Because they were already short on caseworkers and everything else. So Texas has not done a good job as compared to other states in initiating prevention efforts, in keeping up with them, or in funding them. But that has a repercussion. If you do no prevention at all, then you're left with intervention is your only course of action. And intervention is a much harsh road to go down. But what you see happening is, I just plotted what it looked like in Lubbock. So for instance, we didn't start this until the late 1990s. In 2003, 4 years later, the legislature eliminated all the funding for prevention. So in 2003, we had 764 confirmed victims, and our rate of occurrence was 12.2. We were spending 6.5 million on foster care. Now follow those same numbers, 1, 2, 3, 4. By 2007, without that funding, we had 1,400 victims. We had a rate of occurrence of 22.7, but the number that possibly escaped everyone else is we went from spending 6.5 million on foster care to 9 million. That's just one county. So there is a cost for not doing prevention. You pay for it one way or the other. So, and prevention, as we like to say, is about 20% of what the cost of foster care is. So we used to say, colleagues and I, when we'd have to end up down in Austin for a prevention conference, or say, just give us a nickel out of every dollar that's being spent on intervention, and great things can happen for that. So when we look at where the prevention services are right now, currently, at the end of 2021, this was where prevention programs were in place in each DFPS region. So that included the HOPES program, which is what we have here in Lubbock. That included Nurse Family Partnership, CCAP, CBCAP, all of the, whether they were big or large programs that were funded by prevention dollars. So statewide, that means that only about 20,000 families were served by prevention families. Lubbock County, we represented 2% of that 20,000 at about 407. Again, when there's 73,000 children in Lubbock County. So we're doing as much as we can with prevention services, but you know, the dollars have to match up to the need, and we're still quite out of balance on that. So, excuse me. So we want to look at too, you know, what is the need out there for prevention? How do we know that it works? How do we know that we should be funding this? So one of the things that DFPS did was contract in the last 12 months with the University of Texas Health Sciences Center at Tyler, and also the University of Texas System. And obviously they're already anticipating funding down the road might not be a whole lot better than it is right here. So where are we going to place those dollars, and what impact is it going to have? So they were charged with finding, through multiple known risk factors for abuse and neglect, like the family violence rate, economics, school readiness. There was, I think, 30 different areas that they looked at in this study. And they said, try and identify the top 50 counties in Texas. Well, they came back with 55 counties that were in drastic need of prevention services, specifically something that could be done through home visitation. So Lubbock County was in the top 25% of those counties. We were number 12. So obviously that just solidified there's a reason for prevention services, and certainly in Lubbock County. So again, just to sort of sum this up before we start talking about some resources for you know, the failure to fund prevention doesn't make the problem go away. Again, it only leaves that intervention. Intervention is basically what we're saying to our children is, Well, we're going to help you, but only after you get abused and neglected. That's what intervention is. We intervene after that abuse and neglect has occurred. That cannot be the best outcome for a child. We have to prevent that before that happens. And there's, other studies that have been done. I think this one came back from, again, DFPS also, was that, for every dollar that you invest in prevention, you get an $8 return on that. And that's not even including the cost of foster care. So it's a good investment for our state. We just maybe have to work harder on getting our state to believe that too. So I'm going to talk a little bit just about my agency, because we are one of just two that does home visitation in this area. Nurse Family Partnership through Texas Tech School of Nursing offers home visitation services to first-time mothers. My agency offers it to all families that are prenatal to school entry. There is no cost for any of the families to participate at any of the services at the parenting cottage, but particularly the home visitation services. So when I say home visiting, it's like when I go to hire an educator, I say, you've never done this job before, and I've never hired in the years that I've been there, but one person who had ever done home visiting before. So it is a concept that a lot of people are not exactly sure. Well, what, you go out to their homes and you visit them, Yes, we do that. But the big thing in home visiting is that it is evidence-based. We do have an evidence-based curriculum, Parents as Teachers. It's an accredited program. It's executed by degreed and then subsequently certified educators. But home visitation was started about 35 years ago in the state of Missouri, when all these children showed up at school, at kindergarten, and they were so far behind that the school system couldn't deal with them. And so their thought was, well, if we just intervene with these children earlier, if we go out to their homes and work with them before they start school, this won't be a problem. They will come to school ready. Well, what happened when they went out to those schools, to those homes, and they saw those children, they became aware of why those children came to school unprepared and not ready. There were so many issues in the home. I mean, there was things like lack of basic needs in the home. Parents that had no knowledge of early childhood development or even why it was important. Some of them that were parenting as they were parented because that's what we all do, but it might not be the best effort at things. So home visiting opened up an incredible area of knowledge that if we do this, we can make an impact on these kids. So now hundreds of thousands of children later, and lots and lots of research and everything else on the components of home visiting, then you can basically kind of narrow it down to a few things. So when we go out there to work with these children, again, we're working with both the parent and the child. So it's parenting education. It's also early childhood education. The reason why you deliver those services in the parent's home versus somewhere else, and sometimes we do the visits at a place other than the children's homes, but that's usually the place where the child feels most secure, most safe. A lot of times those families have things to tell you that need help in working out. And if they were in a public place or even at your agency where other people were there, they wouldn't feel safe to tell you that. So plus it allows us to look at what exactly are the dynamics in these families. Maybe there's 2 or 3 generations living there. Maybe there's an extra brother-in-law or sister-in-law. All of that impacts what that status of that family is and where we go forward. So, but our key elements are parenting education, early childhood. We also encourage them to participate in groups. So that could be a story time event, or like we do one on legal rights for parents. And so we encourage those parents to come and interact with other parents, but also to bring their children. Those kids need social emotional skills. They need to learn how to interact with children their own age, but also other adults before they start school. We also do developmental screenings for the kids. And that tells a parent, your 3-year-old is exactly where they need to be in terms of 5 different domains that have to do with physical development, emotional development, social development. And so they're able to see where their child is. For some of the parents that their child is right where it needs to be, they're elated because they weren't sure. But it also allows us to look at maybe problematical issues for that child. Sometimes it's things that a parent can just work on with that child and it'll go ahead and evolve and be fine. But some of those children need an intervention. They need early childhood intervention. They need speech therapy. They need a world of things. But the earlier you do that intervention, the more success that you have. One of the first things we do with the families is just a needs assessment. What's going on in your family? I mean, are you able to meet the basic needs of your family? Because they're not going to listen to my parenting education or me telling them to read to their child every night because it's going to help them if they're trying to figure out how to pay the light bill or what they're going to put on the table for dinner. So let's get those basic needs taken care of. If we can't answer that need, we're going to send them somewhere that they can get that done. The ultimate result that we're looking for is an increase in protective factors. Protective factors are what I call the glue that holds a family together in times of the tough times and the not so good times. But that is a major determination whether physical abuse and neglect will occur, not just physical, but any abuse and neglect. If they're unable to weather those storms that most of us are able to do, that's normally when you see the stress factors go up and the abuse and neglect occur. So these are nationally recognized. These were set up by the Health and Human Services after a lot of years of study that said these are the things that we need to try and build. So we're looking, we evaluate those when we first start with a family, and then we're looking to improve those things on the other end. And it has to do also with their interactions with their children. Do they know where to go for basic resources? There's just 5 different areas that we continually look at. But years and years of research tells us if we can build those protective factors in the family, we can reduce abuse and neglect. So they are what I call the safeguards against that happening. So they need to know a knowledge of parenting and childhood development, social connections. Do they have concrete supports in times of need? Nurturing and attachment. Do they have that between their child? And then where is the child on the scheme of social and emotional competence? So all of that goes together and forms that parental resilience, which is what we're looking for. So if you can build those factors up, those will always outweigh the risk factors for abuse and neglect. It's like being able to offset those things. So, you know, one of the questions that I get asked now, and even as the Child Abuse Coalition, it's like, but what can I do personally? I mean, I'm sitting in this neighborhood, or I know a child that was abused or neglected, or I was abused or neglected. So what can I do on an individual level, or what can we do better as a community? And the biggest thing that we can do is to bring awareness. That's what Go Blue Lubbock is all about, is, you know, participate in those childhood activities. Come to a conference like this, learn more about, if you told people in Lubbock County right now that an average of 3 children a day were victims of abuse and neglect, they'd be shocked. Because it's not on their radar screen. They may not have kids, but it's just not on their radar screen. It's not affecting their life. So educating yourself and then educating others. I will tell you, and we do get some financial help on the local level. United Way funds some of the efforts. CH Foundation funds some of the efforts. Some of the other foundations do. But the major source of funding, both on the federal level and is federal and state dollars. That's the ones that are putting the big dollars or the bigger dollars behind child abuse and neglect. It's not enough, but at least we're making a little bit of progress. But I've worked a lot with our legislators and they were very instrumental, Senator Perry and Representative Frulo, in us getting the Hopes Foundation, the Hopes prevention money into Lubbock County. And, you know, you think it's really easy for a legislature to go down there to Austin and he should know all of this and all of that. I mean, the number of bills coming before them, the number of the time frame that, you know, we want to worry about our water district and all these other different things, you know, we need to do a better job of helping our legislatures and saying, this is important to us, because if it's important in their district, they will make it important in Austin. So that's what we need to tell our legislators is these things are important to us. We don't want 3 children a day in Lubbock to be victims of child abuse and neglect. So, and it's easy for you to do that. All of them have public offices here. All of them have email addresses. They have addresses and, you know, in Austin and Lubbock. And so it's easy enough to do that. Don't wait till the middle of the legislative session to do that, because they already, the committees are, the interim charges like for the next legislative session that doesn't start till 2023 have already come out. So we need to be doing that work now, not when they've already gone down to Austin for the next session. And please think about supporting the local organizations that provide these prevention and intervention efforts. And I've got 2 great ones with me here today, but all of us would like to serve more families than we're able to serve right now. And finances always, always, always is the ultimate barrier to being able to do that. So as we come to this part of the end to this part of it, then our goal needs to be, when we ask that question, how are the children? The answer that we want to be able to say is, the children are well. I think that Dr. Thompson started the conference off well this morning when she said, wouldn't it be great if we didn't need to have this conference? Because that would mean that child abuse and neglect has gotten better. So we would like to be able to not make presentations, but be able to say, you know, the children are well. So I think Belinda introduced my 2 colleagues, but I work with both of them, not just through the coalition, but also in some of the efforts that we do with families. So I think, Derek, you're going to be next in this.
All right. Well, first, I want to say thank you for being a part of the discussion and being invited. Sometimes when PowerPoint has a mind of its own, so if it advances, I'll go back to it. I think it already did by itself, right? So I'm with the Children's Advocacy Center of the South Plains, and we want to serve and are the first stop for children who have experienced sexual abuse, severe physical abuse, and or witnesses to violent crimes. We provide a trauma-informed, child-friendly environment for the children that have suffered abuse and neglect or witnessed violent crime. And with that, we can get with our multidisciplinary team, our partner agencies, so we can discuss the case, and we're trying to achieve the best overall outcome for the families. We want to coordinate our strategies, and we want to get the best experience and overall outcome for the families that we're all going to be serving. We do that mainly in these 6 core services: joint investigation coordination, forensic interviews, family advocacy and victim support, trauma-focused therapy, medical evaluations. Our partner agencies provide those. We do not do those in-house there at the center here, and a multidisciplinary case review. I will tell everyone my history was in law enforcement, as Belinda shared, and 10 of those years was crimes against children, but I'd also worked on cases in homicide and all that. These cases are more complex than any other case that the police department gets involved in. There's so many more different moving parts. We work off referrals from the Department of Family Protective Services and law enforcement. It's really the only cases that you're going to see both sides of a district attorney's office involved: civil on the DFPS side and criminal on law enforcement. You're going to have medical involved for the injuries or the SANE or the CARE exam, therapy involved, all these things. And in years past, before the centers were created in the state, everybody went and did their own investigation. Nobody shared any information. Nobody collaborated. Nobody got together to see what the other was doing. So when they got to whether it was the civil side or the criminal side, at a courtroom, the best overall outcomes were not being brought into the families that everybody was serving. So the state saw this as an issue, and that's where the Children's Advocacy Centers became part of statute in the legislation. We can be found in the Texas Family Code under Section 264 in Section 4. So that mandates what we do and don't do. So we are part of statute, which has been a big accomplishment. There's 70 centers in the state of Texas. We're all part of a CAC Texas, which is our membership group. And as a whole, you're going to see our local numbers, but I'll tell you 69,000 children were served in the state last year alone by all the centers. And we're not covering all the counties in the state. Texas is a very large state. So one of the main reasons for coming together was two things: this joint investigation coordination and also this multidisciplinary case review. So we want to get everybody together, and not only do we want to be the first stop, we hope to be the only stop when this kid has to come and tell their traumatic story about the event that happened to them. We do this by providing the forensic interview, which is a evidence-based, semi-structured narrative. The kid needs to be able to tell their own story in their own words. We use the kid's vocabulary. Whatever they use or name for body parts is what is continued out throughout the forensic interview. These interviews are recorded. The requesting agencies have to be there to observe the interviews, and they do become the property of the investigative agency. We don't keep those in-house. They become their property, and we give those to those investigators. Some of them, again, will require just a DFPS response, but many require a law enforcement and a DFPS, but some may just be a law enforcement response if the alleged perpetrator is not in the house or a member of the family. So, but in the middle, we need to be making sure we're coordinating everybody to be there at the same time when it starts and the interview and get all that going. The importance of the multidisciplinary case review is the fact that we're bringing everybody together in the same room to discuss the cases that have come through and receive those forensic interview services. And we're going to discuss where the case is now, where the case needs to go. And so every discipline has their opportunity to speak about what they've done, where they're going, what they may need to be done. And we can also see what else in regards to resources the family may need, or do we need additional medical, or how we're going to get this child in get our therapy services and those type of things. So in Lubbock County, we review those cases the first and third Thursday of every month. And then in the other counties we serve, we do those on a monthly basis. So we serve Lubbock County and the surrounding 14 counties. And when we go to those other counties, we take and utilize our mobile interview equipment. We want to limit the strain on the family having to come to Lubbock in the center. Also helps with the law enforcement not having to leave their jurisdiction, as well as the DFPS investigators that are serving those counties as well. So we go to them to do that. We have working protocols and memorandums of understanding with 11 of those counties. There's 4 counties we'll see here in a minute that we don't have. When the center started in '97, I'm not sure if they thought that might cost them some money down the line or what, but they weren't in agreement. But we did not want to leave them uncovered, and we wanted to be able to provide those services. There'll be some that are not very populated. King, Motley, Dickens, and Garza will be those counties that I'm speaking of. So in 2021, a significant impact achieved through these strategic collaborations. And we want to achieve safety, justice, and healing for these kids that come through. First, we need to make sure they're safe. Second, we need to get justice if it meets that standard. But more importantly, we have to make sure of that healing. Back to mine, you have all these different disciplines that are involved in these child abuse investigations. You can tend to get tunnel vision on your investigation. For my role in law enforcement, did a crime occur? If so, what crime? When did it occur? Who's responsible? And you can sometimes lose sight on some of the other things going on in the victim and the family's lives. Since I became in this role, I realized that all our core services are important, but that trauma-focused therapy for our kiddos and the non-offending caregivers is most important, because they get a life sentence for whatever traumatic event occurred to them. This is something they're going to have to learn and have the coping skills to move with going forward. So not all these cases are going to get to a criminal court. And even if they do, some of those sentences may be anywhere from a probation to 20 years. But our victims, this is something they have with them going forward throughout. So as that's a very important piece. And when you're kind of up on the balcony and you're looking down on the dance floor, it's all these moving parts in the investigation that are kind of doing their own little thing. And you'd like to get them in coordination so they're all waltzing in the same direction at the same time. So we really are trying to focus on those mental health for our kiddos. We see so many numbers, we do have a waiting list, so we're still always trying to get that down. The collective impact that our results that we always achieve are part of our MDT partners. Community supporters, as Carla mentioned, are huge. Funders, elected leaders, other nonprofit partners, and schools and many others. So it really takes my wife hates this when I say this, but it takes a village to raise a child. She said, well, that's really, really old. You shouldn't really use that kind of dating yourself, but it really does. I mean, we all can't do it alone. We can all do something, but we can't do it all. So state funders, federal funders, fundraisers, Lubbock Area United Way, we're a partner agency with, and just volunteers and people getting involved. We only get involved from referrals. That's how we get activated. So we're heavily right now on the intervention side. Intervention can be prevention because you stop the abuse and maybe then no further abuse occurs from that. But we would much rather be on the front end of that and not having to do these other services. So it really takes everybody. And last year, Carla had mentioned about we didn't know, and I still don't know, like she said, what the total results of that COVID 2022 or 2020 year was. But we saw a 22% increase. When those kids, I think it was around March 13th, got sent home from school, we knew as CACs around the state that we were losing a large part of our professional reporters, which are educators, counselors, daycare centers sometimes were closing. So, and we also know that well over 90% of our alleged perpetrators are known to the victims. They are not a stranger danger. So they were going to be at home spending more time with those offenders than in the past. And there wasn't going to be anybody that could visualize or see their demeanor, marks, bruises, any of those things. So we still, I don't think, know what totally came out of that COVID year, where for that about 6 month period that they weren't back in school. So I think we'll still continue to see that. We did see 893 kids in that COVID year as far as our forensic interview numbers and all, and that was about 200 down from the prior year. So we know and the reports that we read also fell off because we do read the statewide intakes. I think DFPS was here prior to us coming on. And in 2015, the legislature saw the need for the CACs to receive those statewide intakes that were going to law enforcement, because was people at the law enforcement agencies reading those? Was someone designated? Because they come in by, as you'll see, the thousands. And so there were some pilot programs done and all, and they noticed the need that maybe some of these smaller police departments in the counties that we all serve, maybe nobody was reading them, or they would say, well, how are we supposed to receive them? And if they said, well, you can get them by fax, well, our fax machine hadn't worked for years. So kids were falling through the cracks, and we weren't being able to see the kiddos we need to see. So once we started that program, we now do read the statewide intakes for Lubbock County and the other 10 counties that we have MOUs and working protocols with. And you'll see in a minute what those numbers are for Lubbock and our surrounding counties. Now, we have a big vision. We want to reach every child. We want to reach them with every service, and we want to do that by making every effort. And so we still know, even though you'll see that we see a lot of kids, we're not seeing every kid that we'd like to see come through the CAC door. We feel like you're going to get a better interview, a better outcry, if there is one to be achieved, by using our people, our center, and not by being interviewed at school and or at a police department or any of those stereotype scary places. Years before the centers became available, that's where kids were interviewed, on a floor in a DFPS office or a back of a police car. This just was not a good way to do that. So the centers make it, whether we go to you or you come there, we're a child friendly, and we're not one of those sterile, scary places that you're having to tell this story to. We strive daily to make this goal achievable. Like I said, we do see a lot of kiddos, and so we do have a therapy wait list, and we're do our best to do that, refer out to those that want to see kids. Our therapy services are free. It's at no cost to the families we serve. We currently have 4 full-time therapists, and we use 4 therapy interns from Texas Tech University, licensed marriage family therapists there that are completing their master level work. And we do that off-site in another building here. We do travel. Our therapy services do travel to the other communities as well. And we do teletherapy utilizing Doxy.me. So we were established in 97, did our first interview in 1998. So we're working on a little over 24 years here, and you can see the 15 counties we serve. Now, in that 24 years, 18,836 kids have received that forensic interview piece. If you divide that comes to an average of 764 kids a year since we came about. The graph here at the bottom, you'll watch, will show you kind of how that's gone. You can see since that inception of 2015, that number has pretty much steadily grown, and we did 1,094 last year. And I think part of that is due to that statewide intake program. We're reading, finding out who's assigned, and then making contact to see if, and offering our services to those requesting agency. Excuse me. Joint investigation coordination was a piece we talked about earlier. 5,265 of those statewide intakes were read by our staff a year ago for Lubbock and the surrounding counties, trying to get those kids that met our criteria. Again, sex abuse, physical abuse, witnesses to violent crime, in for our services. We did those 1,094 children received child-focused, non-leading forensic interviews. But there at the bottom, you'll see 65.5% of that number was Lubbock County. So the majority are still here in Lubbock County. The family advocates, they're the first one that meet the families when they arrive at the center. They explain our role. We're very clear that we're not associated with DFPS or law enforcement. We're simply providing services. Many of these families come in many different emotional states. They can be angered that they're there. They can be scared because DFPS and law enforcement, and they can be in shock based on what they just found out that their child has outcried to or been exposed to. So those family advocates are really, really trained to deal with the families, explain what our role is in the investigation, and they move forward with these families after those initial services. And they made 1,590 follow-up phone calls to those families that were involved in those 1,094 interviews. And so they'll continue to check, see if any additional resources are needed, and if so, direct them on how to receive those. Our therapy numbers, we did 2,560 hours of that therapy, and we were able to reach 109 children and their non-offending caregivers. One of the main therapy programs we use is trauma-focused cognitive behavioral therapy. It's evidence-based. It's been what's deemed best for kids that have suffered abuse and neglect. But it does take a minimum of 16 weeks and can run out to upwards of 24 and sometimes more weeks, depending on the complexity of the case. And so we have developing some other type of, recently got trained in another one that's kind of 8 to 10 weeks. And so we're going to be incorporating some of that as well. We believe some therapy is better than no therapy. And one of the things I would like to state that I've learned from the therapists and all is the parental involvement in this therapy is very, very important. It's not just the kid. It needs to be a family invested in this to be beneficial and get these kids where they can have those coping skills and move on. We've got to break the cycle. I think anybody up here will tell you, we've had mothers come in and we're interviewing their kids for sex abuse, and we're offering this service, and they might tell us, well, no, they'll be okay. I'm okay. It happened to me. Well, we didn't break the cycle back. And so now it's repeating itself. And I think in any of these cases, either one of these ladies would tell you the same thing. If we don't break the cycle, it's just a continuous perpetual moving forward. Medical evaluations for these cases, 119 children received those. That could be physical or a sexual abuse type exam. That number's low. We continue to work and advocate with those multidisciplinary team members to get these kids checked for their health and safety. It might not be beneficial to their criminal case if they've got that, say it's law enforcement, but we still need to see if they've been sexually abused. Some cases you might run across a victim, and a victim is a victim. I want to be clear and say that. But their past may also show they've been sexually active as well. That doesn't mean they don't need some sort of an examination when it comes to this particular outcry. If nothing else, they need to be checked for STIs and maybe get some education, sex education as well, about the safety and why they should or should not be doing the things that they're doing. Because we're talking about children. We see kids from birth till 17. The young ones may not can obviously communicate, but they may be involved in something, as Carla talked about, that 0 to 5 age. They can't tell us what happened, but we know something happened because they either have a spiral fracture or, some other injury, shaken baby, whatever it may be. So we'll be involved in those cases as well. That case review that we talked about earlier, that's 851 of those last year that we provided. Again, let's keep in mind 65.5% of those interviews we talked about were Lubbock County alone. And then we do have a child and adult education. We reached 1,004 folks, which was not bad. Again, that's going to reflect back a little bit to COVID. And then when school got back in session, getting back into schools was very difficult because of the restrictions, because of COVID and the mask mandates and those things. But we kind of saw that lifting towards January of last year and all, so we were able to get in there. Out of those, though, we play it safe. We taught 5,879 children. That is a pre-K through 12th grade curriculum. Obviously, it's not the same for pre-K as it is 12th, but it's really about body safety. We talked about 90 some odd percent have the APs have a involvement with the kid. It's a known perpetrator. And we need to let them know that if anyone is asking them to do things that make them uncomfortable, they need to tell someone. And it can be someone that's very, very close to them, unfortunately, and many times is. So we like to get in there and get those pre-KKs. One of the ones in this Play It Safe program is a 5th grade program that's cyberbullying. That one is really, really good. everybody has one of these mini computers attached to their hip now, even kids in school. Yeah. And they're constantly using them. Sometimes in ways they shouldn't, they know, but others are reaching them in ways they shouldn't as well because they don't know the trepidation in entering some of these chat rooms and things like that. So it's a good program. The Recognizing Reporting is training counselors, teachers, caregivers of any kind, camp, Boy Scouts, Girl Scouts, Boys Clubs, Girls Clubs, YWCA. We were able to teach 858 adults through that. If these kiddos were to come and disclose to an individual and that individual not know how to accept that information and or do something with that information, they may not tell another person because they'll think no one is going to believe me. So it's very important that those folks that interact with these kids every day know, one, how to receive the information, two, then what to do with the information, which is make those reports of abuse and neglect. Because again, we don't want someone that didn't act be the reason that that child didn't get any kind of services needed going forward. Okay, so in those kids, we kind of broke it down here. You can see out of that number of 1,094, 510 were ages 6 to 12. 184 were in that age group of 0 to 5. And then 393 were 13 to 17. And then that 7% is going to fall into other and sex trafficking. So 751 of the 1,000 were sexual abuse, 102 physical abuse, 133 witnesses to violent crime. Domestic violence is a issue as well. 56 neglect. Oh, there it did it again, mind of its own. 28 sexual and physical. I think Carla had mentioned that some experienced more than one type of abuse or trauma, and you could probably even fall in here some neglectful supervision as well in this sexual and physical abuse. 15 other. We may have been doing those for other states as courtesies, or and we do see that if the kids are here and outcry, we'll get notified by them. Again, they'll need to reach out to either DFPS and or a law enforcement official to do a courtesy, because that has to be observed by one of those agencies if we're providing that service. At 9, sex trafficking. Child sex trafficking is here in Lubbock. It's maybe not as extensive, obviously, as in the metropolitan areas of Dallas and Houston and San Antonio and Fort Worth. But we do see it. We have interviewed some kids that have been confirmed victims. And I don't want to jump off here into Lauren's deal, but a lot of things that we have here is if those kids are wards of the state in custody of DFPS, is placement here in Lubbock. We lack placements here in Lubbock, whether it be for the high-risk kids or just other kids that get removed. And so we we do have a Lubbock County Care Coordination Team, which is to provide wraparound services for either confirmed sex traffic victims, children, or those that we deem high risk, risky behavior on the internet, those type things that's going to end up catching up with them if they continue those patterns. But again, some of those that we've served, they haven't been able to be placed here and then move around just because we lack some placements here in Lubbock. There's a well-known fact that the state of Texas does not make a good parent. So we have just started the first phase of community-based care here in Lubbock County region, Region 1, I guess is what we'll say. And that's now with St. Francis, and we're just like 1 month in. So we'll kind of see where that goes and if that changes anything going forward for any of us. How you can get involved with us, obviously be a sponsor underwriter for one of our events for fundraising. Every kid that comes to the center after the forensic interview and all that, after all that's taken place, we like to give them some comforting items. And that's a new stuffed animal, bear, blanket. They get a book. Reading is a very important part going forward as well. And we like those to be new, and we see the numbers. When we go to the other communities, our family advocates will know kind of the age range and the kids are seeing, and they'll pick those items and take them with them. So they receive those as well. And so we go through those, as you know, by the numbers quite often. We do have a CPI unit with DFPS that officers out of our building here in Lubbock. They see the majority of the cases that we see come through the center. They're some of the more tenured CPI workers that have worked for the department for quite a while. And so sometimes when the families are there and they're working those services and then getting our services, they can be there for an extended period of time. So we always like to have some bottled water, individually wrapped snacks and things like that on hand. They may be there first thing in the morning, could be there at lunch or go through lunch. So we want to make sure that we're getting them some sort of food and nourishment and trying to make them as comfortable as possible. And ask us for a child abuse awareness presentation for your agency or organization. Again, if you want to look at the cost, and Carla told you the numbers, prevention's way down here and intervention's way up here. So I think we'll all tell you we'd love to work ourselves out of a job and not be needed. And so we continue to strive that every day. But getting out there and knowing that whether it be the Play It Safe program or recognizing reporting, we're not coming out there trying to, yes, it isn't a victim identification. That Play It Safe program is. Every time we do that program, we do have someone generally come forward and have questions, one of those kiddos. So it is used as that, but it's not going in and telling your kids something they should know. It's basic, and John's going to kill me because I'm not going to do this right, but really it's about body parts that swimsuits cover on a little boy and a little girl that people are not supposed to look at, see, touch, or asked to see or touch. That's really, in a nutshell, what it's about. If someone's doing that, they shouldn't, and you should tell someone safe. So don't be afraid of the program. And there just was a legislative change in reference to school systems needing some of that things. Came out in December, had to go through 2 special sessions, and it became law in December. So we'll be working with the school districts around that we serve going forward and meeting those. And we'll be more than happy to give you the link and let you look at Play It Safe program and all. But we do need to work on this prevention side to help get it under control. The numbers are unacceptable. That's what I would say.
They are. Well, Lauren, you're going to be the final cog in our little presentation here. So I'm going to let Lauren is the last link after these kids have been through all this. So I'll just let you go forward with that, Lauren.
Thank you, Carla. Thanks, Derek. So as Belinda mentioned in the introduction, I am with CASA of the South Plains. And so I'm going to share with you some information today about our program. What we do, as Carla and Derek have explained, we really come in after an allegation of abuse or neglect has been made and the child has been placed into foster care. But as Derek mentioned, we also believe that there are some areas of intervention that are prevention. And so our goal is to get a child into a safe and permanent home to prevent any further abuse. So at CASA, our mission is to inspire, educate, and empower people in the community, just like you all who are watching today, to advocate and support the best interest of children. So we know that our volunteer advocates create connections and promote nurturing relationships for the child and the family. And our goal is through collaboration and our court appointment to empower our volunteers to share informed recommendations to the judge about what's in the child's best interests. So our vision, much like Child Advocacy Center, is to serve every child. We want to provide every child who's in foster care with a CASA volunteer to advocate for their long-term well-being and best interest. And we have been doing this work here locally in our Lubbock and South Plains community for 28 years. So what is CASA? This is one of the questions we get the most. CASA is an acronym. It stands for Court Appointed Special Advocates. And so CASA volunteers get to know the child, the parents, and the families. They're community members who are working collaboratively to support children and families who are in the foster care system. And our volunteers provide information to the judge during court hearings, as well as to others who are involved with the child's case to help ensure that the child's best interest is being met. Now, each of our CASA volunteers are usually only assigned to one child or one sibling group, so they can focus all of their information gathering and their relationship building specifically with that family. And each volunteer also has a staff member at CASA assigned to support them and help them with their advocacy. So I have a short video here that I think does a really good job of explaining what CASA is.
Every child is born with a chance to dream, to learn, to play, and a chance to feel safe. But what happens when those chances disappear? For children placed in foster care, the chaos of being removed from home and placed in a new environment with new people, court dates, social worker visits, and new schools can be traumatic and hinder a child's desire to learn, play, and even dream. How can we give these kids the help they need? How can we give them all the chances they deserve? For that, we need CASA volunteers. What is a CASA? A CASA is a court-appointed special advocate. They help kids in foster care know there's someone by their side, committed to looking out for them. A CASA is not a superhero or a legal expert. CASAs come from different backgrounds, neighborhoods, and communities, just like the kids they help. To be a CASA, you don't need any professional training in social work or the legal system. All you need is the will to help. If you decide to become a CASA volunteer, you'll be trained to work with children in foster care, navigate the legal system, and speak in court. Once you've gone through training, you're appointed by a judge to help with a child's case. As a CASA, your job is to get to know the child as well as the parents and family, foster family, and everyone else involved. Judges count on CASA volunteers to keep them updated so they can make the best possible decisions for the child's physical and emotional well-being. CASA volunteers are one constant figure for the child, but they're not the only ones. CASAs never work alone. When you become a CASA, you'll work with a CASA staff member who will advise and support you through the entire process. You'll work with caseworkers, attorneys, and others to engage committed adults who will support the child and family. These adults can include members of a child's family of origin, foster family, teachers, faith communities, coaches, and friends. Together, they create a strong support network for the child and family. This support system helps develop a plan and set goals for the child and family going forward. Ideally, the plan will involve reunification with the child's parent or parents when safe and possible. When that's not the case, you may recommend that the child live with another relative or close family friend. Other possibilities may include searching for a loving adoptive home or preparing the child for adult living on their own. Regardless of the outcome, You'll keep in contact with the support network you've helped create until the case closes, so that everyone continues to put the best interests of the child first. If this support group stays committed, the child will have strong, stable adults who they can rely on for years to come. This leads to a greater sense of safety, happiness, and stability, better performance in school, and stronger peer relationships. There are thousands of children in foster care throughout Texas. By becoming a CASA volunteer, you can make sure they are safe and supported. Because every child has a chance. It's you. Find out more about how you can help by visiting becomeacasa.org.
So I like that video because it just, I think, helps explain pretty concisely and with the visual kind of a little bit about our role. So as you heard, CASA does fulfill a legal role. So we are, in each case that we're involved in, we fulfill the legal role of guardian ad litem. And so that role is defined in the Texas Family Code, and it means a person appointed to represent the best interest of a child. So some of the powers and duties that are outlined in the Texas Family Code regarding the guardian ad litem are that we obtain and review copies of the child's records. And so that can include medical records, psychological records, school or academic records. We also interview the child and each person who has knowledge about the case and may be a party to the suit that's been filed. We participate in all meetings and case-related staffings regarding the child. We're also consulted on decisions regarding the child's placement while they're in foster care. And we evaluate whether the child welfare system and providers within the system are protecting the child's best interests, specifically regarding appropriate care, treatment, services, and the rights of children in foster care. And then, as you saw in the video, we also attend all court hearings and legal proceedings regarding the child. So what do we really do? What does it look like on a day-to-day basis? So what CASA does, we help ensure that a child's voice is heard throughout the time that they're in foster care. We are identifying supportive people in the child's life and identifying and addressing any risks that there are to the child's safety and to their well-being. We're also working to help maintain a sense of urgency, so to try to push the case forward with the understanding and recognizing that permanency, both legal and relational, is essential to a child's well-being. We provide information through written court reports and testimony, like I said before, appearing at each court hearing regarding the child and make best interests, so the judge has that information to make informed decisions. Other things that we do, verifying educational assessments are done and that needed educational supports are in place, and that any physical or mental health assessments that are needed do get completed. So some of the things that we don't do, because sometimes I think it's helpful to kind of understand the difference. CASA volunteers would not ever introduce the child to anyone not involved in their case. And we would not ever take the child to our own home or to the home of a friend or family. Sometimes people have that misunderstanding about CASA and think that we provide foster care, that we provide placement for children, and that's not part of our role. We don't ever give money or expensive gifts to the child or their family or caregivers, and nor do we give legal advice, counseling, medical advice, or consent. And in very, very limited situations would we ever transport or drive the child. So this is a lot of information about what CASA does. So what is required for someone to be involved with our program as a CASA volunteer? So these are some of our kind of very basic early requirements. So anyone who is interested in being a CASA volunteer has to be at least 21 years old. And we have a very intensive screening and selection process for our CASA volunteers that involves applications, interviews, references, as well as criminal history and child abuse registry background. checks. Once someone applies and gets through that initial screening process, we have a training program that again was referenced in the video that every CASA volunteer goes through. And that's composed of classroom time as well as some self-study components. We do ask that everyone who wants to be a CASA volunteer commit to at least 12 to 18 months serving the child. And that's because that's the average length of time that it takes for a child's case to go from removal to a permanent home. And one of our goals, our biggest goals, is to be that consistent person for the child throughout this time when they're in foster care, when there can be a lot of other changes happening. And then on average, our volunteers spend about 10 to 15 hours a month doing the work that we've talked about. So just to kind of help you understand where we're at here locally with our CASA program. So this information is from the DFPS fiscal year, which is September to August. And so last year in 2021, in the 6 counties that our local program here in the South Plains serves, there were over 1,200 children in foster care. And our program was able to serve 537 of those children, or 43%. So as you can see, while our vision is to provide a CASA volunteer for every child, we have a lot of work to do to meet that because there are so many children in foster care and because we need more CASA volunteers to join our program. So this is a breakdown of the 6 counties that we serve. And so you can see exactly where our impact was across those counties last year in 2021. So you can see the majority of the children that we served were in Lubbock County, but we do serve 5 additional surrounding counties. So of the children that we served, those who were school age, one of the things that we're very proud about is that 92% of the children that we served did advance to the next grade level last year in 2021. So educational advocacy is a big part of what we do, and we can see that those advocacy efforts are making a difference in this number. 194 children that we served found permanency or were placed in a permanent home and their case was closed and they were no longer involved in the foster care system or with CPS. And our volunteers donated over 5,000 hours last year alone, just in 2021, in volunteer service that were all directly related to working with children and families. And so one of the things that our program does and what that means for our community is a savings of over $290,000 in taxpayer money. And the reason for that is because when there's not a CASA volunteer available to be appointed to serve a child in foster care, the courts still must appoint someone to fulfill that guardian ad litem role. And when CASA is not available, it's an attorney, a county paid attorney who is appointed to fulfill that role. So not only are we impacting the children and families that we're working with, but we're also impacting the community as well. So of the children that we served, this is one of the things that we like to talk about is, you know, I said 194 children found permanency or found a permanent home. So what did that look like? 38% of the kids that we worked with last year went home. And as Carla mentioned earlier, that is always the goal. We want children to be reunited and reunified with their families when it can be safe and appropriate. And so in 38% of the cases where children had a permanent home last year, it was going back home. The next highest was relative adoption, followed by non-relative adoption and then custody to relatives. So I always think that it's just helpful to see a visual of exactly what the outcomes look like. So if you are a professional or maybe you're a family member of a child and in any capacity, you might be working with CASA or with a child in foster care. What does that look like? What does it look like working with CASA? So first of all, as I showed you before, last year we were only able to serve 43% of the children in foster care. So the first step is probably you need to find out, do they have a CASA volunteer or not? So in order to have a CASA volunteer, the child does have to to be in the custody of DFPS or Child Protective Services, meaning they were removed because confirmed abuse or neglect happened. But if you know that happened and you don't know if they have a CASA, ask. So you could ask the St. Francis Permanency Specialist. As Derek mentioned, St. Francis has transitioned in our community-based care in our region. So where it used to be the CPS caseworker, it's now the St. Francis Permanency Specialist. The child's placement or caregiver would know, and you could always call the CASA office and ask if the child you're working with has a CASA volunteer. If they don't, and you think they need one, this is a question we get a lot, is how do I get a CASA appointed to this child that I'm working with? And we can't accept referrals from anywhere other than the court because we do fulfill that legal role of guardian ad litem. So we have to be appointed through a court order by the judge who is overseeing the child's case, so what that means is a party to the case would have to make the request to the court to appoint CASA on the case. And if there are ever any concerns, if anyone's ever working with CASA and has a concern about our quality of work on a case, our professionalism, or whether or not we are fulfilling our statutory role, we take those very seriously and want to address them. And so on our website, there is contact information for our staff for how you could reach us if you needed to. So if you are working with CASA, you know you have a child who has a CASA. What do you expect from that CASA volunteer? So like I mentioned before, volunteer advocates are supported and coached by CASA staff members called advocacy coordinators. So there will always be at least 2 people working on a child's case, a staff member and a volunteer. You can expect contact at least once a month, maybe more often, from the CASA volunteer with the child, their caregiver, their CPS or St. Francis worker, as well as the parents. And you can expect regular contact from the CASA volunteer if you're a medical professional, a therapist, a counselor, a teacher, a daycare provider. We will be having regular contact with any of those kinds of providers who are involved with a child in foster care that has a CASA. And finally, we participate in all case meetings, like I mentioned before about the child, and all court hearings. So, and we may also be requesting records, likely will be requesting records. So things like report cards, special education evaluations, therapy notes, and maybe any other medical records. So just to kind of give an overview about CASA in Texas, very similar to the Child Advocacy Center like Derek talked about earlier, there is an association within Texas called Texas CASA, and that is our statewide association, and there's 72 local programs across the state, local CASA programs across the state. So Texas CASA works to empower and support those local programs like ours. At the local level, we each program recruit and train and supervise volunteers locally. So each CASA program, including ours here at CASA of the South Plains, is an independent 501c3 organization. And local programs, because of different needs in different parts of the state, may have different procedures, different staff structures, and different capacities to serve the children in the area. So I know that this is a virtual conference and there may be people that are not local that you might be working with a different CASA program than ours here in the South Plains. So this is just a snapshot of our training schedule. So for people who are interested in learning more about going through the training process to become a CASA volunteer, we offer 6 training sessions throughout the year at different times of the day, different days of the week. So this is a little bit about what our training looks like, so you can see the hours that's required in person, in classroom, as well as the independent study. So we know that being a CASA volunteer advocate is not for everyone, but we also know that everyone can do something to help. And so if you're interested in becoming involved with CASA in a way other than serving as a volunteer advocate, there are lots of things that you can do, and all of this information is on our website. If you're with a business or a company and want to partner with us, we have corporate partnership opportunities. But like I said before, you know, we're not serving every child who needs a CASA volunteer advocate, and we need more funding to support more staff to support those advocates. So anything that you can do, there's lots of different ways to get involved with CASA. So thank you so much for spending your Friday learning about community resources and child abuse and just furthering your own education, because ultimately that's going to help our kids.
So thanks, Lauren and Derek. I think if I would say anything to kind of sum up what all of us are saying is that all of these numbers that you're hearing, the numbers that we're serving, the numbers that are being served or whatever, were a result of somebody making a report. Even from the other speakers that you heard this morning, somebody made a report, and so that started a chain of reactions. But for every child that is confirmed through investigation as being a victim of child abuse and neglect, there are children out there that nobody knows about and nobody does anything about. And it's because for a lot of different reasons. I know I've asked Derek this question before about, what if that is occurring, that abuse or neglect is occurring with a relative that lives in your home? We know that it's the parents. So I would say to those of you who are maybe on the outside of that family's actual physical home, if you're an aunt, an uncle, a cousin, or a school nurse, or a counselor at school, or a teacher, or any way involved in those kids, is that when you talk to these children as adult survivors of child abuse and neglect, and you ask them, did you ever feel like you could have gotten help if you'd have said something? And they said, their number one reply to that is, I was too scared to tell anybody. And you have to think about that parent-child relationship is the strongest you have. So that child is thinking, if I tell somebody mom or dad is doing this, what's going to happen to me? What's going to happen to mom or dad? What's going to happen to so we always encourage anybody who receives an outcry from a child. Number one, I've heard also people say, well, we didn't know it was true, so we didn't do anything. Children very, very rarely ever lie about something like this. So you need to take it serious and let it play out its course, whether the child is telling absolutely the truth or they're not. You need to assume that what they're saying to you is true, because it could have taken them a long, long time to get up the courage to even say anything to you. And the second thing that child or that young person may say to you is, but don't tell anybody. So you can't promise that child that, because you just broke the trust with that child. So, but you can come back and reply to them and say, I can't promise you that, but what I can promise you is I'm going to get you some help. And that's ultimately what the child needs, and what they want is that this is happening to me and I have no idea how to stop it, and something's going on in my family. And sometimes you'll see the older sibling becomes the one that is willing to talk about it when it begins to impact the younger siblings. He might not have spoke out for himself, but when he sees it with his younger siblings. So, anyway, I hope what we were able to share with you guys today was of value. All of us left contact information for you through our slides, and we're more than happy to do that. And, on behalf of the whole coalition, we thank Covenant so much they led the pack in starting this conference. And, now almost a decade later, we've been able to make it grow and offer different things. But I guess our ultimate goal is not to do it at all. So thank y'all.
Just one quick point on the, here in the state of Texas, we're all required to report, and all you need is a suspicion. And you can't be held, liable for that as long as you're making that in good faith. But we're required by statute, everybody. And again, mere suspicion. You don't have to have factual knowledge if so. Very good point.
There were a couple of questions in the chat box. The first is that Antoinette would like more information on developing skills as a social worker to address needs with families before a crisis to prevent unnecessary protective services involvement. Do y'all have any suggestions for her?
She would like more skills on, I'm sorry. Okay. Well, I mean, all of our colleges and universities within Lubbock County, LCU, South Plains, all of them have that degree plan going that way. Like for instance, in my case, my staff has to have a college degree before I can employ them for that program. So, but there are definitely ways to go. I don't necessarily hire one that has a degree in social work. It's helpful. I like the broad range of education that we get. We use a lot of human development and family studies graduates because they have that early childhood component. So I think it depends on which field you're trying to go into and what the educational requirements are. But you can certainly go through South Plains, LCU, Texas Tech, any of those have that degree plan.
And then there was another question. Is there a statute of limitations on getting a CAC interview? And can a child be re-interviewed if he later begins to have an outcry when he did not 2 to 3 years earlier? And who can request these interviews if CPS does not want to do one?
Again, we do a lot of interviews on delayed outcries. A lot of that is because they wait to say anything until the threat's out of the home and they feel safe. And we can re-interview children if more information becomes available. Not every kid that comes through might make an outcry, but maybe we get them in that therapy component and then they become comfortable and they outcry. We can re-interview them based on that. The referral process is where it gets a little tricky because one, if there's an outcry, delayed or not, they can always make a police report because that's a crime. And so law enforcement can request those forensic interviews. You can always regenerate and should, as a professional, if that outcry comes out later, whether it be in therapy or where not, they should be then making another DFPS report,
As
which
a mandated
then
reporter.
require another reopened investigation so we can get those interviews accomplished.
I know that I've seen cases also that involved your agency, Derek, that were, you had the same perpetrator within a family and he changed victims. So, that's an issue also because that's the same perpetrator, but a totally different case.
Correct. So yes, they can be re-interviewed, and many times that when we're doing the interview, it is a delayed outcry.
And I think the last question we have, I know at Covenant Children's, we service a large area, and I know you guys know that as well. But what do we do for these counties that don't have any representation for these services?
We, as CAC, service these 15 counties. We're not going to probably, like I said, there's 4 of those we don't even have agreements with. We're probably, if you need our services, call us, we'll figure out. The Bridge in Amarillo is a CAC. They service 26 counties. I don't know how they do that. 15 drives us, more busy than we need to be. But I think for our services, either me talking with that ED or something, we can see about getting a kid a forensic interview if needed. It is going to have to come from DFPS referral though, or law enforcement agency. And even when Bailey's one of our counties, so Muleshoe is kind of weird. We're the CAC that provides the services, but the DFPS are coming out of those Amarillo, Hereford offices. So it's, the state's so big and
True. And all of us have contractual, restrictions. I know, for instance, my home visitation program that does receive state funding it only covers Lubbock County. So New Deal, if you live on this side of New Deal, is in Lubbock County. If you live on this side of New Deal, it's Hale County. So we've even had to tell residents within New Deal I'm sorry, I can help your sister who lives on this side of town, but I can't help you because you're Hale County. But I would say also for these, and We service some of the other outlying counties through other programs that we have, like group parenting initiatives, and which can be used for if they have mandated parenting, or, you know, they're getting released from jail and probation may do that. So, you know, each of these agencies may have more than the programs that we talked about today. I know for Derek and I, yours not so much, but yours is pretty straight line. But again, go back to your legislature. Who is your legislature in your county, and say, we don't have any services? Because a lot of times it's our state funding or our federal funding that it isn't that we don't want to serve your county. We're contractually bound not to. So your legislator is the one that can do the very most for you in your county to say, we need this funding to come across us.
Regarding children in foster care, if they're in a county that's not served by a local CASA program, I would just encourage anyone who would like those children to be represented by a CASA to work with their local courts and their local judges, because ultimately that's where the support has to come from first, because we do have to have a court order in order to be able to offer our services. So just to start working locally with judges and child welfare professionals in that local community to talk about how to get a CASA program or a CASA program developed in that county.
And I would just say one more thing in closing on that is that is one of the objectives of the South Plains Child Abuse Coalition, is that we play a huge role in advocacy. We develop a legislative agenda each year. We share that with the legislators. So, you know, if any of these agencies that are involved in the coalition, you can bring that forward to us and let us know what's going on in your county or what your needs are, or you can certainly become involved if you're an entity that's servicing children or families. So, you know, this is what has to happen, is this collaboration and the conversations, and then getting those conversations to the right people.
One of the next questions is, can sexual abuse survivors receive therapy through CAC or just youth currently involved in an investigation?
It's through an investigation with us because how it's activated. Now, we do provide services. Let's say a kid has received services in another county, city where a CAC is, and then they move to Lubbock. We can offer them services as well as they get here, because they had been served by another advocacy center here in the state.
And then the next question, what is the process with CPS forensic when a child recants after admitting abuse in an interview?
You know, I can't answer how that would, obviously that will affect their outcome of their investigation. But if we do the interview, then we're taking what the child says, we're turning that over to them. If later there's a recantation, which happens, then they're going to have to take that as part. And as part of that multidisciplinary team discussion, we'll review that case, and that can be introduced as well. And, you know, there's district attorneys, DFPS, law enforcement, all those folks attend those case reviews.
And then the last question is, do your employees have to be licensed, or do you prefer them to be licensed? And I think that one was for Carla.
For me, all of mine are degreed with, you know, the degrees have to be in the field in which they're going to work in. Then they get further certifications depending on, you know, for instance, the age that they're working with, 0 to 3, 3 to K. So they're very, very professional ladies. I'm amazed every day at the work that they do. They do a lot of, are required to do a lot of continuing education and everything else. So very talented group of ladies.
Well, thank you so much, Carla, Derek, and Lauren. There's Dr. Ian Mitchell, in San Antonio, and we work on a lot of state stuff about child abuse. And both of us say that if 10 years ago you would have told us our passion was going to be about child abuse, we would have told you that we were that they were lying. So I see that passion in y'all, and it's really so great to see. making sure that every child gets the care that they need and they deserve. So thank you again so much for that. So for the participants also, to let you know that in last year's surveys after our conference, we had a lot of questions requesting more information specifically on CPS, CPI investigations, and then some of our other organizations that are available, like CAC and like CASA, and then what resources were available in our region, like with the Parenting Cottage. So I think that has helped a whole lot in getting those questions answered. Felt like we had not included that in the previous 8 years. And so I even felt like I've learned so much. So thank y'all so much for that. And we do talk a lot about Lubbock, the information for Lubbock in our Lubbock area. So those, we have about 340 registered people that registered for the conference. We have a lot that are out of state even and not local. So just to know that you can still use this information for templates to be able to use to help in your area. The mental health initiative that Dr. Trevino talked about this morning, that was an initiative in Massachusetts, and that's how that one got developed using their template. So again, it's things that can still be useful to very many people. We're very fortunate, I think, in this area to have these people that are passionate about caring for children that have been abused or neglected. So the next two things that we have on the slide, these are QR codes, information, or a link that you can use once you've completed your presentation and your evaluation. This one is for the live event participants, the ones that are participating today. This is what you will use. And then this one will be the ones that are using our on-demand viewing at a later time. So we wanted to make sure that we had that information in here for you. Now we're going to break for lunch. So we're going to give everyone 26 minutes. So we will be returning at 12:30. And again, thank you all of our speakers this morning, and thank you to all of the participants out there. So good afternoon. I hope you enjoyed your lunch. Our next speaker will be Dr. Christy Thornhill. She received her Master of Science in Nursing and Emergency Nurse Practitioner at University of Texas Health Science Center, and then her Doctor of Nursing Practice at Texas Christian University. Over the last 32 years, she has served as an ED nurse, ICU nurse, flight nurse, emergency nurse practitioner, trauma nurse practitioner, and a sexual assault nurse examiner. Dr. Thornhill is currently the director of the trauma program, the child abuse protective team, the fostering health program, and clinical surgical excellence program at Covenant Children's Hospital in Fort Worth, Texas. And she still practices as a care team nurse practitioner. She will be discussing several clinical areas related to child abuse. Those include the emergency department documentation, development of a hospital child protection team, and then sexual assault exam updates. So please welcome Dr. Christy Thornhill.
All right, can you hear me, Belinda? Okay, it says it's still unmuting, so thank you for having me. And you had a little Freudian slip. You said I was at Covenant in Fort Worth, but I'm at Cook Children's in Fort Worth. As much as I would love to be there with y'all today. So thank y'all for having me. I told Belinda when I started putting this together after she gave me all the topics, it's like nothing flows from one to the other. So I'm calling it potpourri of child abuse. So I guess next slide. I do wear a lot of hats. I'm very fortunate that I have great managers and great staff that let me do the parts of my jobs that I love the most. So again, thank you for having me. I love that y'all are on your 9th year of having this conference. So I'll jump right in. I've started with ED documentation of abuse. And I know this is always scary for ED nurses, providers, like you want to have all the right things. And then sometimes you don't want to have too much so that you don't have to go to court. And I absolutely get that because that can be scary. But there are some real key things that you need to have. The first thing, obviously, is history. So that past medical history is very important. And it needs to include anything that could lead to mimics of child abuse. So if you have a child that has a history of any kind of bleeding disorder, you would want to make sure that's in there, or any kind of bony injury or bony underlying medical condition that could lead to some mimics of abuse. You want to have good family history. Again, I've had children that I had a child with osteogenesis imperfecta that wasn't identified, and it was a very rare presentation. It wasn't the typical blue sclera, has had a history of fractures in the past, but had some kind of weird fractures. And so we were doing that workup, and whenever I started getting some family history, there'd never been a definite diagnosis of osteogenesis, but there'd been a family history of everybody in the family had had breaks from very simple falls. And so when we did the diagnostic testing, this child indeed had osteogenesis, and likely it was in the family. Nobody had just ever been tested for that. They just thought their kids broke really easily. So getting some of that history is important. Certainly social history is important. And sometimes these are the hardest questions that people have is, who's in the home, who helps take care of the child, who's been around the child in the time frame of when an injury may have occurred. Is there any history of CPS involvement? And surprisingly, how you ask these questions, if you're very non-judgmental and it's just matter of fact, like I'm asking when did you last eat? If you say, hey, have you ever had involvement with CPS? Most of the time families are pretty forthcoming with that. Because again, it's how we approach it, that it's not a judgmental. Is there any history of domestic violence? We know that in families where there's domestic violence, there's a high likelihood that there's also child abuse. So asking those questions. And I present lectures frequently to nursing students when they're in their pediatric rotation. And I always ask who wants to go into pediatrics, who says, no way, never going to happen. And when they raise their hand, I'm like, I was you 30 plus years ago, never had any intention. no matter where you work, whether you're in a community hospital, whether you're only seeing adults, you will always encounter people that have children. Could be your next door neighbors, or at your church. So knowing that if I have a concern that there may be domestic violence, I also need to make sure somebody's laying eyes on those kids. So reports need to be made for sure. Is there any drug or alcohol use or abuse in the family? We want to know that as part of the social history, and also if there's any legal issues in the family, a lot of times custody issues, if there's been any arrests for domestic violence or things like that. So you want to get that in your documentation. Certainly the developmental history. And that's important because if you have a child that hasn't met developmental milestones, yet they're telling you the injury occurred because they were walking and that child isn't doing that yet, or they climbed up on something, but you have a child that's not cruising or able to climb up on something to have that fall, that's important. So having good documentation of, are they rolling? Are they pulling up is important, because that's really what's going to help you with, does this make sense with the mechanism of injury that I'm seeing. And one thing that I always try to tell people is, when you document like you might be in court in 2 to 3 years, because you will not remember details. And I promise you, when I started working in care team, that was one of the things that I had to really work for. And the first couple of times I went to court and had a question asked, I didn't remember those. I didn't remember the fine details. I might remember the big picture, but I might not remember how was the parent acting whenever I interacted with them. How was the child behaving when I interacted? So, write down as much in your documentation as you can. And it's not that defensive documentation that we think about when we're trained of, you may go to court because you're being sued and they're going to blow your chart up and make you look like an idiot, showing every, grammatical error, every period that you didn't have in the right place or comma that was in the wrong place. This is really having that good detailed documentation so it will trigger your memory of those finer points whenever you go to court. Okay, next slide, please. So with the history, we really recommend, if you've got a verbal child, try to interview them separately from a caregiver. Because if you walk in a room, and I'll give you an example, I was a patient in an ER some years back, and my husband was in the room, and he's a police officer. He was in uniform. And I had a nurse that was just going through the motions of, what medicines do you take? Are you allergic to any medicine? And of course, she had her back to me because she was typing on the computer. And she said, do you feel safe at home? And it took me a minute, and I started laughing, because I said, do you really think that I would be honest if I didn't feel safe at home when he's sitting on the stool in the corner with a gun on his hip? Like, there are reasons we ask certain questions and when we should ask those questions. So if you've got a verbal child, speaking to them independently is ideal. And it's not necessarily that you think the parent is the one that's hurting them, although you might have that suspicion. But oftentimes kids, just like we want to protect children, they also want to protect the adults. So they may not disclose that something's going on because they're afraid they'll get in trouble, or they're afraid it will upset their mom or dad, whoever's with them, or that they did something bad. So really trying to get that history independently. And if I have both caregivers when I'm seeing these patients, I also want to interview them and get history independently to see if there's any deviation from what the story is. When you get history, you want to make sure it's open-ended questions, both with the parents and with the child. And then documenting who was in that interview. And we never expect in the emergency department that you're getting history like we do whenever we're seeing kids in care team. But you do need to get some specific things, and you need to document well. So you want to document who was in the room when you got that information. You want to document the demeanor of the caregivers. You want to document the demeanor of the child. Were they cooperative? Were they anxious? Were they angry? Were they aggressive? Those are all important things. If a caregiver or a child says something that you think is important or it makes you kind of go, make sure when you document that you put that in quotes, that it's not that you heard something and paraphrased it to what you thought it meant. Put what they said in quotes. And document what question you may have asked to elicit the answer that you got. Typically, whenever I chart, if I'm doing it in writing and not on the computer, I will put in parentheses what my question was, and then in quotes what their answer was, so that when I go to court, it just makes it easier for me to go, this is what I asked, this is what their response was. And again, those detailed history where we really get down into the nitty gritty of things, it should be by somebody that's trained to do it. The last thing that you want to do is ask a question the wrong way, or a question that could be leading to get a child or a caregiver to say something that isn't what was intended, and certainly don't want to interfere with an investigation long term. So that's why we always tell our providers here, we do need some basic information asked, but you don't need to get down into the nitty gritty details for that. Because again, forensic interviewers at your CACs are trained to do that. We're trained in the medical history, getting down into the detail. And these boxes are just some examples of what we have on our sexual abuse protocol to kind of make us remember how the child looked, how they were responding to questions, as well as caregivers. Next slide, please. So when you get that history, you want to know who was there, who saw what happened, or was it unwitnessed? Because that can be important. If you have a non-mobile child, non-verbal child, and it was an unwitnessed injury, that's important. I mean, that's kind of a red flag for us. You want to know what happened. What was the mechanism? You know, were they sitting up on a kitchen counter in a bouncer and bounced off? Did a dog knock them down? I mean, all the things that we need to know about what happened. You want to know where it happened. You know, was it at home? Was it at school? Was it when they were in the care of the babysitter at their home? Were they with one of the other parents or grandparents? You want to know when it happened. You know, timing is important. You know, we have some parents that if their child has a scratch, they come running, and we have others that are a little more stoic. I always say that's our nurses. If you're a nurse's kid, you may walk around for a day or two with a broken arm, with a splint and ice, because you're going to be fine. But if it is that they had a pretty significant injury, but they took a long time to get that child to the hospital, that's a red flag, and you want that in your history. And then how the child's responded to the injury, how the caregiver's responding, and again, if there's any lapse in time for seeking care for the injury. Next slide, please. So all of those are good things to document. So there's always some red flags, and I think it's important that you know the red flags so that if you have some, you document that. So again, if there's no explanation or there's a really vague explanation for a significantly injured child, that's important that you put that in your documentation. You know, child presents unresponsive, Glasgow of 4. Parents say baby was fine and suddenly, you know, became this way. That's a red flag, because that's not a common thing that babies just go unresponsive without some underlying issue. If any of the important details change, make sure that you document that. You know, at triage stated this, now telling social worker this, versus told the provider something different. Little details may be remembered or added, but if it's the big story, that's a red flag. If different witnesses provide different stories. And again, most of the time, child abuse is a crime of isolation. So it's usually one person that has committed the act, and the rest of the adults in that child's life repeat what they were told. But if that story changes significantly, that should be a concern. Obviously, if the history is not consistent with the developmental age of the child. You know, if they tell me they put the 2-day-old baby in the middle of the king-size bed while they went to the bathroom and they came out and found the baby on the floor, and now the baby's not breathing, that's a red flag. You know, even a 2-day-old shouldn't be scooting to the edge of a king-size bed. So that would absolutely be a red flag. If the injury is due to inadequate supervision, that's important. You know, it may not be that it was an intentional inflicted injury, but it may be neglectful supervision that led to that injury. Again, delay in seeking care without a reasonable explanation. Again, if you're an RN with a kid, oftentimes those children, there's a delay in seeking care because, you know, we'll take care of it at home until we can't. If the witness, if there was witnessed inappropriate behavior that put that child at risk. So, you know, if you have somebody that thinks it's okay to put the 18-month-old out in the front yard with nobody watching, or having the 4-year-old watch the 18-month-old, like that puts that child at risk. And so knowing that history is important. If there's any reported history of physical abuse, that's a red flag that you may have a child that's at risk. If any of the siblings or other children in the household have been seen for abuse. And that's one of the things that we really strive to have our ED providers ask those questions whenever we do have a child that gets brought in with concerns for abuse. Are there any other children at the home? And if they are, then we need to have those children brought in to be screened as well. If there's history of potential trauma in the setting of domestic violence. So again, we know that there's that crossover. And then if we have those children that come in where they've had an ingestion, whether that's an illegal drug ingestion or prescribed controlled substances, alcohol, you know, eventually we need to determine, was it they just had access to it because it was neglectful supervision, or was it intentionally given to try and make that child be quiet or be sleepy or don't bother me? All of that becomes important. Next slide, please. My biggest red flag, my favorite red flag is when I have, and it's, I'm going to usually say it's a boyfriend or mom's significant other that has the children and something happens, and instead of calling 911 as most reasonable people would, he calls his mom or he calls the mom of the child. So, you know, that should be a red flag for you, because most people, even lay people, if they have a child that has a significant change in their mental status, if they quit breathing, if they turn blue, they're going to pick up the phone and call 911. But if they pick up the phone and call their mom or their aunt or the neighbor, that always makes me a little suspicious. And that's something that I'm going to document in my notes, that was the first thing they thought of. And I will tell you, I've had a case recently where it was a licensed daycare, in-home daycare worker, that's what happened. The baby was found on the floor after supposedly rolling off the couch, and the licensed daycare worker, instead of calling 911, and you know she was trained in CPR, she's trained in first aid, called the mom at work and told her what was happening, and actually FaceTime so the mom could see the baby. So again, big red flag whenever you have that, and you'd want to document that. All right, next slide, please. So with physical exam, moving on, obviously you want to do that full head to toe. I am a big proponent, and I know it's not always feasible when the ER is really busy, but really everybody should be in a gown. Get them undressed, get them in a gown, because we need to be able to see the entire body. Unfortunately, there are a lot of kids that are abused, that their bruises are not in places that we will see if their clothes are on. Okay, parents or caregivers that abuse oftentimes learn where to put those marks so that they can't be seen by the general population. So you want to do that good full head to toe exam, even if you can't get them out of a gown. And I get sometimes kids don't want to put on a gown. It's when you do that assessment, it's okay if you don't want to be in a gown, but I have to look up under your shirt. I need to see all your skin to make sure it's healthy. I need to look up, you know, the legs of your shorts so I can make sure everything's healthy. Ideally, you want to include an anogenital exam. That doesn't necessarily mean a detailed exam, but just a cursory look to make sure that there's no injuries to those areas. A good exam of the inside of the mouth. Sometimes we'll have children where we find bruising to the palate, or the inside of the mouth, or the gum line, or you may see frenula injuries on infants. You want to look between the fingers and at the palms of the feet and the soles of the hand. Doing good descriptive documentation of your physical exam is great, but I will tell you what is even better is if you can get photographs. If you can't, diagram is great, but photographs, that tells the story far better than even we can with our descriptors in verbal documentation. So if you're doing photographs, you want to make sure that you include a measurement device. We tend to use the size standard, that kind of double-sided ruler that's got a 90-degree angle on it, but you don't have to have that. As you can see in the middle picture, that's one of the social workers that's in our ER will frequently get a tongue blade. That's still in the wrapper. They'll put the patient's sticker on there so we know who the picture's of, and then that gives us that measurement as well. But I mean, I've seen people use a quarter because that's a standard size that we all know. You want to make sure when you're doing your documentation that you also have an ID photo, that you don't just, with that first picture, you can see that's a bruise, but it's like, I don't know where that is or who that is. So you want to make sure you have a face ID picture as well. And again, if you have concerns for sexual abuse, again, just do that cursory exam. You don't need to take pictures, but you do want to consult with your child abuse team or your sexual assault nurse examiners, whoever handles that at your facility, and get them involved to do that more detailed exam. Next slide, please. And so just some quick photograph tips. So wear gloves, and I will tell you, I will go back sometimes and look at my charts and I'm like, I didn't have on gloves when I recognize my wedding ring, or I recognize my own finger. So I really strive to do that. You don't want anything that's going to identify you in photographs. Get help, especially with little kids, babies. I swear they grow 8 arms and 8 legs when I'm trying to get photographs of infants, especially when I'm trying to get in the mouth to get a picture of a frenulum that may be torn. So you'll need help. You want to make sure you have good lighting. I'll tell you, our PICU is my least favorite place to get photos because it's very cave-like, and the way the lighting is overhead, sometimes it makes shadows. So it's really trying to get where I don't have a shadow that's going to cover up bruising or blur bruising. I always say too many photos is better than too few. So I may have a whole lot of pictures that aren't helpful, but I'm going to take as many as I need to. And then you want to, if you can take the photos within the medical record where they automatically load, that's great. And I know Covenant recently went to Epic. We have Epic, and so all of our providers on our phone, we have Haiku, which allows us to take pictures with our camera, but it doesn't go into our photos. It goes directly into the medical record. So it's there. And I'll always, when I bring it up, I always show the caregiver, you know, this is your child's medical record. This is their date of birth. I want to show you that I'm in the charts, and that's where that picture is going. It's not going into my personal photo stash. But with that, we're able to label those pictures. So this is out of a chart, and you can see it'll show the date and the time that the pictures were taken. And then one was labeled lip abrasion. We had a forehead bruise, chest bruising and abrasion, and facial bruising. So that's nice. It makes it easy when you're going back and reviewing that chart. Next slide, please. If you don't have Epic, or you don't have the ability to automatically load those pictures into the medical record, then if you're using a digital camera, one of the things that you want to do is what we call bookend with an ID. So this is our safety bear. He was my model for this. So the first picture that I will take with the digital camera is a picture of his patient label. So it identifies who he is, his date of birth, medical record number. The next picture that I want to do is just an overall picture, or that ID picture, where I have the patient's face in there. If it's a little baby, I usually get their whole body. If it's a bigger child, again, it may just be their face. Then I want to get a mid-range picture. So Safety Bear had a wound on his left paw. And so I took kind of that mid-range picture. You can see it's still Safety Bear because you see a little part of his body, but then you see there's that wound. And then I want to get that closer close-up picture where I actually have the size standard there. And then flipped him over. He had an injury on his back. So again, I got that kind of overall where you could tell where an injury was. Then I got the mid-range that was a little closer, and then that close-up picture. And then when you finish your pictures, you want to bookend it with another picture of the patient label or patient ID. And that way, if you have multiple patients that you're taking pictures of during a day, you know everything between those two labels are that child. And then the next one is going to be between their labels. Okay. So that's really kind of the high level for documentation in the ER. I'll ask for questions at the end. And so it's not like I have a great segue from documentation, but next slide will go on to development of a hospital child protection team. And so when Belinda asked me to talk about this, I was like, well, Care Team has been here longer than I have. So it's been developed a long time, but there are some great resources out there, and there are a lot of different ways to do it. And even the programs in Texas, we all look a little bit different, but we all follow these recommendations. So the National Association of Children's Hospital and Related Institutions, which is called NACRI, they help define what our role is in child maltreatment. And so this document, and it's a great document, and the Children's Hospital Association has kind of taken over the research that is going on with this and the continued development. But this document's out there, and it's a great one. It doesn't give you like clinical, how you should be assessing child abuse. It doesn't provide assistance with clinical parameters, medical decision making, and it's not an accreditation document, but it is a recommendation. And what this document does, it's to help raise awareness. It helps promote your child abuse team. It helps you look at where are we and what else do we need in our program to help protect these children. And so it really helps play a role in how we respond in our facilities to child abuse, how we're treating, how investigations are happening, and then preventing. You know, what role can we play in preventing? So it really is primarily to help with constructing and staffing, but it also gives you some guidance with upper leadership, with funding and budgets and negotiating what you need on your team to be able to do the best work for these children and to make sure that we're doing it well. And so the original and still involved in this are the American Academy of Pediatrics, the National Children's Alliance, Children's Hospital Association, and the Ray Helfer Society. So, and based on this, I will tell you in 2009, there was Senate Bill 758 that was taken to legislation that has a lot of the information that came out of this resource document. The first one, this one is second round, as to how we built our programs in the state of Texas. So it shows that we're on target for what we're doing. Next slide. So the purpose, again, the fundamental role of a hospital-based child protection team, it's really to ensure that children that there's suspicion of abuse or neglect, that we diagnose them correctly, that they receive the best possible and most appropriate medical care, and that they're kept safe. And so we don't take children away. That is not our role. We don't steal them. We're not in it for the money, I can assure you. And I'll talk about that a little bit later. It is not a money-making endeavor for any hospital, and it's certainly not glamorous. Okay, it's not. I always say people throw money at Cook Children's for our HEMONC children. They throw money at premature babies, but they do not throw money at child abuse because nobody wants to know that that's happening. It doesn't happen in polite society, right? So it's certainly not glamorous. Next slide. So with this document, they they describe or define a three-tier system for child protection teams. So it's not ranking for competitiveness. So I kind of equate it to trauma verification, right? So you'll have some people that are like, well, I work at a level 1 and I work at a level 2. It's not a competition. It's what are our resources and what do we do? What can we provide? It's really just saying if you're at this level, these are the minimum criteria that you need to meet, because you can have a level 3 or a level 4 trauma center that are amazing places. They're just limited by their resources. So again, it's not ranking for competitive value. It's just that framework to help that team to set goals for growth and development within the context of what the community needs are in relation to child abuse. Now, one of the recommendations is that any acute care pediatric facility at minimum needs to meet the recommendations for this basic. Okay, so every children's hospital out there should be able to meet the basic level. And so the essential functions with the basic is they have to have medical leadership. So they need to have a physician that can provide medical leadership and administration that has some training in child abuse. They don't necessarily have to be board certified in child abuse, but they do need to have some training. And I'm going to say passion as well, because if you don't have somebody that's passionate about this patient population, they're not going to do the things that need to be done for this population. You need to have some administrative coordination. You have to have social work. I mean, social work is essential for this patient population. And each of those needs to be a different person, right? So you can't have a physician that's like, I have some training, I'm very passionate, and I'll take on that social work role as well. You have to have some independent people. So this, you also want with this team, they have to have some representative at the community agencies that they routinely participate in your child protection meetings. So most communities, especially large ones, have at least one child advocacy center in their area. And so that means that you're participating in those meetings. And so depending on how often, that could be that they meet monthly, it could be they meet every other week, depending on the volume that you have, is that the medical representation is at the table to discuss cases with CPS, with law enforcement, with district attorneys, with the child advocacy staff who are going to provide ongoing counseling and services for these families. So not only do they have to want to take care of them when they're in the hospital, but they also have to participate at the community level to advocate for these kids. And if you don't have mental health providers as part of your assigned child protection team, you need to at least have them available either in your other hospital departments or within the community where you can refer, because mental health is a huge piece of this patient population. Next slide, please. So your advanced team or your tier 2, you have to have those basic requirements, but you also, this has to be led by a full-time medical director that's board certified in child abuse pediatrics. So you have to have at least one. Generally, there's additional staff with a advanced team. There's also an administrative unit of that program that has centralized management and administrative functions. Again, they meet regularly to present and review child abuse cases, so both within their team and with their community teams as well. Coordinate with the appropriate community agencies involved in child protection. So again, usually those are with your CAC who kind of heads those up. But it may be if you don't have a CAC in your area, but you're still having kind of those, whether it's informal or formal coordination of protection of these children. More likely to serve a broader catchment area, just because it's a bigger hospital oftentimes and has a bigger referral area. And you may offer an accredited fellowship. Now, I'll tell you, based on the definitions in this document, Cook, we're advanced. We have a huge catchment area. Right now, we staff with 15 different child advocacy centers because we have that many counties that we work with for child abuse. So we do a lot of staffings. It keeps us real busy, which is why we have as many staff as we do, because it pulls somebody out of clinic every time you're attending those staffings. We don't have an accredited fellowship because we are not a teaching facility. So we would never have that, but we absolutely are advanced. And I'm going to tell you, I think in a lot of ways we meet a center of excellence, but that we do have some limitations in that respect. So next slide. So Center of Excellence, again, you're going to have to meet all the basic and advanced, but these centers very oftentimes are distinguished because they have that educational and research capability. So most of the time they are affiliated with a medical school because they have that as part of their system. They oftentimes have larger child protection teams, and they include psychologists in their within their team, not just within the facility. They're likely to offer that accredited fellowship so that we're getting more board certified child abuse pediatricians. They may sponsor multi-center trials to add to the body of research that we're doing for child abuse prevention, child abuse awareness, recognition. They'll oftentimes offer advanced diagnostic and treatments that require consultation with hospital, medical, and surgical subspecialists. I'm going to tell you that should be going on at every level. We do not operate in a silo. We are consulting our subspecialists all the time. I'm not a neurosurgeon. I've done this long enough that I know, an epidural goes more commonly with accidental, but I'm still going to consult that neurosurgeon every time I have a baby with a bleed to say, hey, do you think this is consistent, or do you agree this is likely non-accidental trauma? I'm going to consult with our radiologist. I'm going to consult with ortho or ophthalmology, whoever we need to talk to, we're going to get them involved. And then the centers of excellence, they're oftentimes a regional or national leader in child maltreatment and related family violence intervention and treatment. So again, very oftentimes they're associated with a medical school. Next slide, please. So the responsibility of your child protection team, obviously medical diagnosis and treatment, but that's not all. We do facilitate multidisciplinary assessment within the hospital and community. So just like we're consulting our subspecialists in the hospital, we're also speaking with CPS, law enforcement, district attorneys to kind of go, this is what we're seeing. What are you seeing on your side of the investigation? And does any of it make sense, or are we all off track? We also help to formulate that workable plan for long-term management with the hospital and community partners. We're having those hard conversations of this family's not receptive to the things that need to happen for this child. We don't feel like they're going to be protective. We need you on the outside to figure out how are we going to keep this child safe. So having those plans in place and ensuring the safety of that child. As much as we have control, we just need to have that voice so that everybody can hear us. Next slide, please. It's doing those comprehensive medical evaluations and being available 24/7 for consult. We have on our team, we have one provider on call for physical abuse and one SANE nurse on call for sexual abuse 24/7. It doesn't necessarily mean that we have to come in for every single patient, but it's just being that expert that if somebody sees something or has a concern that they can call us after hours on the weekends to say, hey, what do you think? What do I need to do? Am I on the right track, or am I completely missing something? Doing good documentation of all the explanations offered. When we document, when we meet with these families, we're going real deep with our questions, really trying to get everything we can to either support what they're saying or to show why that's not reasonable for the injuries that we're seeing. Forensic interviewers are utilized oftentimes to augment that history that medical staff gets. When we have children that are badly injured that get admitted that we can't get to the CAC for a forensic interview, we will work within our facility with CPS to get a forensic interviewer to be able to come into our facility to get that done. If time is if it's a critical timing issue. Making sure that psychosocial and mental health referrals are made is also a responsibility of the team. And then coordinating that care within the hospital and making recommendations to our cooperating agencies. So I always kind of feel like we're the liaison in our weird medical silo that we have, because we understand the medical world. We have a better understanding of the world of CPS, law enforcement, and district attorneys than most of our other medical peers do. That's a whole different world to them, and they just don't understand sometimes why things happen the way they do or why they don't happen. So we're kind of that bridge between all of the peoples. Next slide, please. So again, other responsibilities. If reports haven't been made, obviously we're going to make reports to CPS and law enforcement. We also educate constantly that every single medical provider is obligated to make those reports. So if I get a call from a primary care physician that says, this is what I'm seeing, and we have concerns, then I have to explain, like they have to make the CPS report. I can't do that for them because they're with the child. They have all the information. They need to be the one to make that report. But every now and again, we'll get on where reports haven't been made or we're the first person that they've seen. So we will make those. Absolutely good documentation of our findings. We also provide expert testimony in court. We probably go to court more than anybody else in the hospital. Now some of our subspecialists go fairly frequently, especially like neurosurgery, ophthalmology, but we typically, our ER providers, hospitalists, they don't have to go as often. Even our trauma surgeons don't have to go very often because we go as the expert testimony. And then another responsibility is helping our families navigate these complicated bureaucracies. So the healthcare system alone is super complicated, and that can be frustrating for families and trying to get them where they need to be and all the follow-up appointments that they may have. But then absolutely, if, CPS is a whole other world. And, this came to light because we deal with CPS all the time. Like, I have the understanding that if a CPS report gets made, that gets assigned to an investigator, and that investigator may have 30 or 60 days to close the case. It doesn't necessarily mean that family's done with CPS, but now that case gets handed off to a different aspect of CPS where they may be working services or having them take classes or, go to rehab. Providers on the inside of the hospital are like, well, they have CPS already. And I'm like, but they have a new injury that needs to be a new report because the worker they now have in this ongoing case may only see them once a month. And so they're not going to know that happened. And so just like our internal medical people don't understand the world of CPS, families really don't. And so it's really helping them, and law enforcement. So many of us have, seen shows like Law and Order for years. And so you see this hour-long show where the crime happens. Olivia Benson goes in and does the SANE exam, my favorite. They go to court and, a week later, the bad guy's in jail. And that is just not how our justice system works. So it's really helping those families understand that this is not a sprint. It's going to be a marathon oftentimes, and it's a long process. And so really helping them understand that. Next slide, please. So another aspect of having a child abuse team is you need to have good policies and guidelines. So having a policy for how referrals are made to your group, whether that's within the hospital or outside, guidelines and protocols for medical evaluation, how we do our workups. When do we get a skeletal survey? When do we do certain genetic testing or refer to genetics? We also have guidelines for collaboration between the team and our community agencies. So we have a guideline that we give to CPS and law enforcement of these are the patients that we need to see. This is when we need to see them and how to get in touch with us, and why something would be considered acute versus something that's a scheduled patient that could, wait until clinic hours versus after hours. Having guidelines for visitation in your hospital when abuse is suspected. Now, I will tell you at Cook, we can't stop a parent from seeing a child, but working with CPS to say this is not a safe person to have in the facility. If they've been aggressive or anything like that, then we will work with that agency to try and figure out what the best thing is. Having policies for covert diagnostic videos if you have that capability in your facility. We have rooms where we have that capability whenever we have those concerns for medical child abuse. And so you want to have a good policy in place of when does that get used, who has access to it, how long is it kept. And on that note, you need to have good policies and collaboration with your risk management team and your legal team. And I will tell you, I think everybody in care team probably has our attorneys on speed dial because, if we have a question, I can text them or I can call them and get that immediate response because it's that important. Next slide, please. Another role that the team plays is prevention. So again, we partner with our outside agencies to help with prevention. This conference is a prime example. It's very multidisciplinary. When I looked at the agenda, you've got people from all different roles, and that's important. Encourage screening in primary care and outpatient settings. We developed an evidence-based screening tool that is used in our emergency department that every child under the age of 4 gets the screening. Once we got that in place, our urgent cares and our primary cares jumped on and said, we want to have a screening tool as well. And so they've kind of taken that and they're tweaking it for what their models look like because not every patient gets an RN triage. But we encourage that and we want that. We would rather get a whole lot of calls from a lot of people than to have things missed. Being knowledgeable about current prevention strategies is essential. Collaborating with local fatality review committees. So one of us is at the local fatality review to have those conversations about, was this inflicted? Was it unsafe sleep? Was it medical? Promoting child abuse prevention. I think anybody that works in this world, we would all love to be out of a job. So we really work hard for getting prevention awareness out there and then providing education and training. And again, there is nobody in my department that if you say, hey, can somebody come speak on this, that we're not going to jump on it. We educate nursing students, medical students, law enforcement, CPS, community. We've gone to churches. We'll talk to anybody that wants to hear about what we do and how to prevent it. Next slide. So with our community collaboration, that again, it's CPS, law enforcement, our child advocacy centers, and having that regular face-to-face contact through multidisciplinary teams. I mean, it's important. It's a team. Not one of us can do what we do well without the others. And we can get frustrated with each other. A lot of times it's because we don't always understand exactly what the limitations are of each agency, but having those in-person, face-to-face conversations helps alleviate a lot of that. Like, I don't think you understand. Oftentimes it is everybody understands, but we're limited by what our, whether it's the law, the latest policy, and then having, good education. We're not a one-man band. It takes an entire symphony to be able to do what our child abuse teams do. Next slide, please. And then funding. This is always the favorite, right? Because I said this is not a moneymaker. So when you look at these types of cases, this takes a lot of time. When we schedule our sexual abuse patients, we're scheduling a minimum of 2 hours. When we schedule our physical abuse patients, it's about an hour and a half. Sometimes they're longer. You know, if we're having to do a removal, it's certainly going to be longer. So just, you know, leadership needs to understand this isn't the, you know, primary care office where they're running a patient through every 15 minutes and being able to drop a bill. The increased time, it's because we're doing those independent history gathering with each child that's verbal, each caregiver that's present. We're doing psychosocial assessments. We may be enlisting mental health services. When our child is out of the clinic, doesn't mean we're done with it. So we may have to go to court multiple times. We're preparing for court. We're writing affidavits. We're doing case review. And some of the case reviews are CPS or law enforcement calls and says, hey, I've got these pictures. Can I send them to you and give me your expert opinion? And that's a child that we never bill for because they weren't actually in our clinic, but we're still involved. And then that consultation with the partner agencies. So it's a lot of time that gets dedicated to these kids, and we've got really poor reimbursement. So absolutely, if you have a child protection team, they're going to have subsidies. Now, based on the legislation that was put through in 2009, the state had a huge grant that all the child abuse teams that qualified, it was called a MedCares grant. That went away last year with our legislation. And that was a huge hit for all of us because it subsidized a lot of the work that we do. So the hospitals that have had that grant for the last almost 20 years have really had to find additional funding or additional subsidies to help support their team. So if you know any legislatures out there, get in their ears and tell them you need to throw more money at child abuse. Medicaid reimburses at about 50% of the cost. So we don't get paid well for what we do. And the mean cost to fund a basic program is about a little over $500,000. An advanced center is going to be about almost $1.6 million a year, and a center of excellence is almost $1.7 million a year. So again, we're not a moneymaker. We're not glamorous. These teams are, you have to think of it as it's mission oriented. It's the right thing to do. And that's why we have these teams in places at our hospitals. Next slide, please. So that's kind of the overview of all centers. Just so you understand, Care Team, we're unique. We're different. We look a little different than some of the really big centers that are teaching facilities and some of the smaller centers. So we are referral based. And that means that a parent cannot call us and make an appointment. If they could, we would be open 24/7 with a staff of about 100 because of custody issues. So all of our referrals come from CPS, law enforcement, or another medical provider that has concerns. We see children with concerns for physical abuse, sexual abuse, concerns for drug exposure, neglect, and that's really severe neglect, neglectful supervision, and medical child abuse. Next slide. On our team, we have 2 board certified child abuse pediatricians, and Dr. Peeler, I think, is speaking after I am. She's the newest to our team, and we're thrilled to have her. We have 3 full-time nurse practitioners. That does not include me. I'm bonus. I still see patients and I take call, but I'm not in clinic every single day. We have 4 full-time forensic nurse examiners that are our sexual assault nurse examiners. They see the vast majority of our sexual abuse patients. So about half of our clinic they see without a medical provider. We have 1 RN case manager that deals mainly with our children that are concerned for medical child abuse, monitoring utilization of specialty medical services. We have 2 full-time social workers, 2 patient care technicians, an office manager, and then this is Kitty. She's our most important team member to all of us because she is our therapy dog, and she's there for the kids, but she's there for us as well. Next slide. So that's Care Team and our team. So I'm going to do just real quick with SANE updates. I know y'all had a really in-depth lecture about SANE exams I think, at your last conference. So I just want to touch base on some things with the CDC that changed. And we don't like their changes. I'll just be real honest. I've decided that somebody that's in a lab came up with these changes and they've never worked with a patient that had to take this medication. So the latest recommendation for treatment of acute sexual abuse or assault is that we give the patient doxycycline twice a day for 7 days and Flagyl twice a day for 7 days, where the previous recommendation for an acute was that one-time dose of Zithromax and one-time dose of Flagyl. That was hard enough to get them to keep that down, but doxycycline and Flagyl both cause such severe GI symptoms, most patients are not going to take this. And so that's kind of become a hot topic with us. Next slide. And this just talks about non-acutes. We treat them the same for acute exams, but it's based on testing. So it wasn't an acute. We did the testing when they were in clinic. They come back positive for GC chlamydia, then we're going to treat them based on that. So again, the treatment is rough. Doxycycline and Flagyl twice a day for a week is really hard. Next slide, please. One of the things that we've started in the last, gosh, I guess it's been about 2 years now, is we started doing HIV non-occupational post-exposure prophylaxis, or NPEP. And so every sexual abuse child that we see will do this screening. We have high risk, which is condomless receptive anal sex, or that they're sharing needles. Those we're absolutely going to offer the NPEP to. Moderate risk is if they've had condomless receptive vaginal sex, condomless insertive anal sex, or prepubescent receptive genital sex with injury. With those, we would consider that treatment, and we'll discuss that with the patient and family. And then there's low risk where we're not going to offer PEP. Next slide, please. So if we have these children, we're going to screen to make sure that they don't have any symptoms of acute HIV.
Christy, I think we lost your audio. Can you hear us? If you'll give us just a second, we'll work on getting Christy back online.
Am I back?
You are.
I was texting Belinda. I was like, I got the hook. She said, what is that? And I was like, like the hook where they pull you off stage. I don't know what happened. That was so weird. So one of the things that we will do is we'll screen every patient to make sure that they don't have acute HIV infection. So if they have a high fever, rash, sore throat, lymphadenopathy, or hepatosplenomegaly, then or any other thing that makes us concerned, then we're going to order that HIV PCR viral load and ensure that they get follow-up. Next slide, please. Other labs that we're going to do if we're offering the NPAP is we'll get that 4th generation HIV AB-AG test. We'll get, if we're worried about the HIV infection, we'll get the RNA PCR, Hep B, Hep C, CMP and CBC, and then whatever STI testing is appropriate based on the age of the child and the type of contact that they had. Next slide. And then we'll choose a NPAP regimen. All of these are 28 days. So with the new, and these medications can be hard on the stomach as well. So one of the things that we're having conversations about right now is, what are we most worried about? So if we have this kid that's at high risk for HIV exposure, we may say, you know what, the NPAP is the most important. Let's get them, and they're going to take it if they're agreeable. Let's get that started. Let's do that. Then we can always come back and test, just like we would for a non-acute exam, to test for GC, chlamydia, and trich, and then treat for that afterwards if necessary. We haven't quite hammered all that down, but those are some things we're worried about, because there's just absolutely almost zero chance that you have somebody that's going to take doxycycline twice a day for 7 days, Flagyl twice a day for 7 days, and then one of the NPAP drugs for 28 days. It just causes too much GI distress. They have to eat. So, if you're saying, well, just time them at different times, and they're like, but I'm eating 24 hours a day to be able to do that. So it's really HIV's worst case scenario. Let's worry about that. GC, chlamydia would be next, because we worry about long-term, fertility as well as, spread, and then trichomonas would be lower on our regimen. Next slide, please. And then we do a lot of counseling. So the potential risk and benefits for taking the PEP, their readiness, they have to be agreeable. This is an expensive medication. We have very fortunately gotten a drug company, Biktarvy, that will give us samples that we can get to these families and get them on a program. They have to understand the importance of lab follow-up and potentially clinic follow-up. Recognizing that window for conversion to HIV goes as far as 6 months out. Recognizing that HIV prevalence in somebody that's committing sexual assault may be higher than in the general population, so that's why their risk is higher. And then also going over what the signs of acute HIV are, so that they know when to call us, or if there's concern. Next slide, please. So the other thing to think of is also considering discussing PrEP, which is pre-exposure prophylaxis, after they've completed PEP. So if you have a child that has received NPEP in the past year, more than either equal to or more than one time, or if they're in situations that they are at risk for future HIV exposure. So you think about some of our homeless, our runaway, our trafficked kids, they're just higher risk, so they may benefit from consideration for PrEP. And then advising on that follow-up. Again, what the signs of HIV are. We're going to touch base with them a week out to see how they're tolerating. Are they taking their meds, and are they tolerating those? Have they been able to get the additional medications that they're going to need beyond the sample pack we gave? And then at 6 weeks and 3 months, they're going to need lab work for HIV as well as RPR for syphilis. And then at 6 months, they'll get another HIV test as well. So that's kind of the big changes that we've had. Next slide. references are there. Next slide. And are there any questions? So considering I got booted off, I think I did pretty good for that hour. Are there any questions?
Hi, Christy. We do have a couple questions.
Okay.
One is, a lot of the attendees liked the slides. Are we able to share those?
Yes, I don't have
Okay.
anything in my slides that I'm not willing to share.
Okay, perfect. And the second question is, from an ER standpoint, or I guess from a children's hospital standpoint, we see documentation from an outside facility, from maybe EMS, all the way through to the ER and the ICU, and it's just a little bit different. And so when we talk about changes in stories, do y'all take that into consideration, that it might be the way those questions are asked of the kids?
We do. And, you know, one of the things, whenever these cases go to court, and the ADAs will get the entire medical record, right? And so they go through and they will have conversations with us. Well, you know, in this area, they said this, but here they said that. And if it's subtle differences, again, it may be how the question was asked, but if it's really a completely different story, or they've now come up, my favorite is, you know, we'll tell them this child's being admitted because they have a head bleed. And then whenever I go to see them, I'm like, well, now we've identified some rib fractures and this bruise and that. And then they're like, oh, well, 3 days ago they did this, and a week ago they did that. Like, all these things get added. That's more of that red flag. But having how you ask the question, if you put that in the parentheses, that's very helpful. And again, subtle changes in what they said, we might expect to see. And oftentimes, whenever your child abuse team, if they get consulted, we go in and try and clarify a lot of that to determine is it how it was asked, or maybe it wasn't asked at all, and get that information. That's a good question.
And Christy, we have another question, and we've had someone ask us this, and I've also seen it before. What is your advice on if a family member is, say, law enforcement or a CPI investigator or someone in that type of position?
Uh-huh. Yeah, or how about they work at your hospital? Because we've had those as well. My first thing is you need to have another agency involved. You know, the first thing that we do is we reach out to our legal department to say, hey, you know, we have somebody that works here at the hospital that there's concern, or we have, you know, a police officer or a CPS worker that, you know, their child's been referred and there's concerns, and we let them work with the legals for those agencies. So, and I did have, I saw a child that was admitted, and where the police officer lived is not where he worked, but I still reached out to his chief to let him know what was going on, because they need to know that. You know, that may be somebody that they want to pull off the street, or, you know, not working cases until everything's evaluated. And the same thing with CPS. I would just go up the chain of CPS to reach out to the supervisor or their legal department to say, this is what we have going on. You know, ideally they would self-disclose if there's a concern, but if they're guilty, they might not. Or they're scared. You know, that's the other thing. I'm just scared and I don't know what to do. But, you know, but yes, I would you have to let those agencies know that there's somebody that there is a concern that's within their department. And like I said, we've had we've had a few instances where it was Cook employees that their family, you know, their child was being seen and we were having to evaluate. It's hard. That's a good question.
Thank you. I haven't had any yet with a family member that worked in the hospital, but we have had the other instances before. And I know we also consulted our legal counsel here at the hospital, and in both the cases I was involved in, they got Texas Rangers involved. So, but I didn't know if you're a smaller hospital and you don't have a legal counsel, I guess administration or something that could help you out in that type of a situation.
Yeah. And even smaller hospitals probably have legal counsel. They're probably not as visible.
First.
Yeah.
Yeah, or is versed in it. Yes.
Correct, yeah.
Well, thank you so much, Christy. You gave us a lot of great information, and thank you for taking on the potpourri of all the topics that we requested.
You're
Those were
welcome.
recommended from our conference last year also. So thank you very much. Enjoy
You're
your
welcome.
award dinner tonight.
Thank you.
Christy was supposed to be here in person with us, but she is getting a prestigious award in Fort Worth this evening. So congratulations and enjoy it. Thank you.
Thank you. Thank you. And if anybody, we are more than happy to share policies. So if anybody needs policies, shoot us an email. What we share. It's not a competition. We want everybody to have everything that they need to do the best they can. Thank you.
Yes, thank you so much. So our next speaker is going to be Dr. Elizabeth Peeler. Christy mentioned her. She is, Dr. Peeler received her Doctor of Osteopathic Medicine at the University of North Texas Health Science Center in Fort Worth, and then completed her Master of Science in Clinical Science and Child Abuse Pediatric Training at the University of Texas Southwestern. Dr. Peeler is a board-certified pediatrician and currently serves as a child abuse pediatrician at Cook Children's in Fort Worth, Texas. And Dr. Peeler will be discussing child abuse versus neglect versus poverty. And thank you, Dr. Peeler.
Thank you so much for having me. Can you hear me okay?
Yes.
Oh, great, great. Thank you for having me. This is an awesome opportunity to talk with people that are passionate about the same things that I'm passionate about. So it's a huge honor to be here. I know we have a lot of people from different backgrounds, and what a topic. I was asked to present on child neglect, and I've given a lot of talks. This is not a popular one, but it's such an important one, and I think it's not popular because it's complex and it's difficult, and so I'm really glad that we get to kind of like jump into it today. I did a lot of research on this, and so I just want to give credit to Dr. Dubowitz, who's a child abuse pediatrician who's really, really passionate and published a lot of literature on child neglect. I borrowed a lot of information and research from him, and I just wanted to tell you a little bit about my background. So I see patients anytime there's concerns about child abuse or neglect, and so that's really the perspective that I'm coming from. I want to talk to you about, you know, caring for these patients, diagnosing these patients, treating these patients, and then how to partner with community agencies to help these families long term. Next slide, please. I have several objectives today. I want to just kind of define and categorize child neglect, go through some basic definitions, but ultimately discuss the complexity of child neglect. This is a really hard, challenging topic, and we'll dig into it together. And then lastly, I want to just kind of identify some key principles and practices for addressing child neglect. So when you see these cases in your role, you know, where can you start and what are some like practical approaches for helping these families in our communities. Next slide, please. I wanted to talk and just do a little bit about background. Neglect actually is the most common form of child maltreatment. And so when you look at statistics published by each state and they look at physical abuse, sexual abuse, neglect is actually overwhelmingly the most common form of child maltreatment. And it actually constitutes 3 out of every 4 calls to CPS and a similar percentage of substantiated cases. And so I just want to remind every person that's out there in the medical community that what you're seeing in your clinic is just the tip of the iceberg. We are only taking care of a small population because actually, you know, a larger population is being addressed by DFPS in the community. And then similarly, a large portion of these cases go unreported. And so if you're actually seeing a kid for concerns of neglect, that's just the tip of the iceberg. This is a really prevalent, common public health problem. And next slide, please. I wanted to remind you that neglect can be fatal. I think people forget that. I think we think that this is mild or this is small potatoes. But neglect is scary and it's serious. And so this slide reminds us that though it rarely involves a deliberate attempt, and we're going to talk a lot about that, about intention and neglect. Neglect, you know, it doesn't really help us to think, is it deliberate? Is it accidental? it doesn't really matter. But even though it's rarely intentional, it's not benign. This is serious. And so this is actually random trivia, but I think it's key if you're in this field. It's the #1 cause of mortality in children who die as a result of maltreatment. And so if you're an investigator, if you're a caseworker, if you're a pediatrician, if you're an ER doc, you're a school nurse, you're a teacher, this is really what we need to be looking out for. This is where we can make a big impact, and this is where we can do a lot of improvement on prevention. And I picked this picture. Grey's Anatomy doesn't really get medicine right a lot, but I think this is one place where they were right. These are those cases where you go into the hallway and you take a moment, and you have to have an emotional breakdown, and you have to catch your breath, and because these are the cases that are hard. And these are the cases that are tricky because they are so serious and they are so scary. Next slide, please. So I think it's important that we talk about how do we define child neglect. That's key. If we're going to talk about it, we have to come up with a definition. And our definition that we pick will then shape our response to the problem. So people have to be mindful when they come up with a definition. And really, when you talk about the definition, it depends on the intent of the definer. So are we trying to blame the parent, or are we trying to care for the kid and help this family? And so there's increasingly more and more a preference for a child-focused definition. And so all of us here will agree that the definition should have fit with the interests of the kid. We worry about their health, we worry about their safety and their well-being. And so really there are different variations of definitions, and these definitions can vary state by state. But I want to request and hopefully convince you that a child-focused definition is important, and that's key. Next slide, please. There are some common themes when we talk about child neglect, depending on where you are, what state and what policy you're used to, different communities. There are kind of 4 common themes to every definition, no matter where you are. So I put these in 4 boxes. So somewhere in each definition, they talk about omission in care. So failure to protect, failure to provide. They define that this is by a parent or a caregiver in some capacity. And then they usually include that the definition causes significant harm. And I put an asterisk by this last component, which is that the definition may or may not include risk of significant harm. Some definitions and some policies and some lawmakers have laws that address risk of harm. Others do not think risk of harm meets the definition. And so we'll talk about why. I have mixed feelings about this. I feel like sometimes a near miss or a risk of harm is where we can intervene and where we can talk about prevention of future significant harm. And so we may have a missed opportunity, but I understand, reasons that, we can't address every risk of harm as well. So some definitions may not include risk of harm. We're going to talk about that later. Next slide, please. I looked up the most recent Texas Family Code definition, and here's what I found, and I cited the reference there. So in the state of Texas, an act or failure to act by a person responsible for the child's care, custody, or welfare, evidencing the person's blatant disregard for consequences of the act or failure to act that causes harm to the child. And that's something that's going to create immediate danger for the child's physical health or safety. And so that's the definition of the Texas Family Code that we're currently going by. Next slide, please. Depending on where you are, if you cross state lines or go to a different community, you might have a different definition. But this is hard. Even if you have a definition that seems black and white, it's there, we can read it, we can understand it. Neglect is on a continuum. And I don't know if that slide is projecting like I wanted it to, but what that I'm showing you on the left side is supposed to be an arrow of a graded response to neglect. And it kind of occurs on a continuum. You can have really severe neglect, or you can have really mild neglect. That's almost an oxymoron to say mild neglect, but it's a continuum. And then on the other end of the spectrum is oppression. Really severe, controlling, maybe abuse. And so, I want to suggest to you that maybe good parenting lies somewhere in between. And it's hard to draw a line in the sand. I know I work with investigators all the time, and they say, Doc, is this neglect or isn't it? And it's not that simple. It's not black and white. Often it's gray, and there's a large gray zone. And these cases are complex, and so we have to go through them, and they change. You know, this is a day-by-day thing, but somehow, some way, we have to kind of, you know, work together as a team and decide, you know, is this concerning for neglect or is it not? And it might take us kind of getting into the details because it's just not that simple. Next slide, please. So when we approach these cases, there's some literature on how we should think through them and some things that we should address and kind of some factors that we can consider when we're talking about the severity of neglect. We've talked about this before. Is this actual harm or is this potential harm? What is the nature of the harm? Is this chronic? It's been happening for a long time. This seems to be repetitive. Or is it, you know, what's the frequency? Is this a one-time pattern or is this something that's been going on and on and on? So, you know, I want to encourage you to consider these things when you're talking about the severity of the harm. Also, I want to remind you that neglect doesn't occur in a vacuum. There may be more than one type of neglect. So we may have physical neglect, we may have educational neglect, we may have supervisory neglect. Also, there may be some type of abuse in there. It's not uncommon to have neglect and abuse at the same time. So, you know, widen your scope, change your perspective, and make sure you're not missing something. And then also, when we talk about neglect, we need to consider this in context. How does this context of the neglect affect and impact the child? Ultimately, everything should go back to the child. So we need to be kind of sensitive to the context. So, you know, consider a cultural context. I put this picture because, you know, in some cultures, older children are responsible for kind of looking out and caring for younger children. And that's kind of controversial. You know, some people will think, well, the parent wasn't there, so that's supervisory neglect. But, you know, and that's an inappropriate burden to place on an older adolescent. But in some cultures, you know, that's how they develop responsibility. And, you know, that's typically normal. And so we have to kind of, you know, take everything in context and recognize, you know, there are certain situations that require, you know, a little more thought. Next slide, please. And then, you know, I wanted to circle back and talk about this actual versus potential harm. There's a recent paper Dr. Sterling wrote, you know, and published in 2020, kind of walking through this and talking about the medical professional's role. But some places you have to actually prove that the condition in question poses a risk of harm, and that can be difficult to prove. The standard of harm or potential harm can be difficult, and it can be difficult to assess or prove in a court of law. So currently CPS tends to follow a standard. You know, they have their own definitions, and they will rarely intervene if there's just something that is perceived to be risky. So the CPS is involved in these serious cases, you know, more when there's significant risk or when there's actual proven harm. But I highlighted this last bullet in red because I think it's really, really important. I want to, you know, imply that, like, really review this and say that if you're making a referral, it's going to be the responsibility of the medical professional to help the multidisciplinary team understand what science tells us about the nature and the severity of the risk to the patient. So if you are on the medical team, you understand, is this, you know, really severe harm? Is this potential harm? How risky is too risky? And based off of evidence-based medicine and what science tells us. So I want to, you know, encourage you to participate in these discussions because you're very knowledgeable and you have really good input and you know the science. Next slide, please. So here's, you know, some typical cases that we may work through, which is actual harm and which is potential harms. Like, for instance, we're talking about anti-vaxxers. Should vaccine refusal, which is like exposing your kid to a small risk of great harm, be, you know, equally culpable to a kid who isn't wearing, you know, a parent who doesn't recommend their child wearing a bike helmet, right? So riding your bike, you know, without a helmet is also risky. There's higher risk of lesser harm. And so, you know, I just want to kind of articulate that these are two cases that are completely different, where we have to kind of weigh the severity of the actual harm versus the potential harm. And, I hope I'm just articulating to you that these are tough, challenging cases. These are multifactorial. These are dynamic cases, that evolve over time. And so I think that these cases are going to require long-term follow-up. This is not something that, we can go in and fix in 20 days or 30 days. These are something that, is going to require long-term relationships. Next slide, please. When we look at contributors to neglect, there's been a lot of research on this. And this is a diagram that I like to consider. When we're looking at neglect, there's a lot of different components. And so there's factors that contribute to neglect at different levels. We're talking about the individual level with the parent and separately than the child, because we know those can be similar, those can be different. Additionally, if you kind of peel away a layer, there's a family layer that contributes to neglect. Cultural context, dynamics, relationships in the family, and then the family is within a community, and a community is different and got a lot of resources and supports available. And then all of that community falls within society, and there's different societal factors that contribute to neglect. And so you really can't see a patient or work with the family and just work on the individual level. That's too simplistic. We have to consider that this is kind of a really multi-layered approach, and we need to address individual factors, family factors, and other factors. Next slide, please. When we talk about risk factors, there's a lot of research on this, and I picked this list, which is published in the literature, that we can go through. These are kind of the same factors, but these are some red flags or risk factors for neglect. So when you're working with the family, we know that children that are disabled or premature babies are at risk for neglect. Literature tells us that. We know that parents with depression, parents that have difficulty with drug and alcohol addiction. We know parents that have low IQ, or parents that are, just limited in their nurturing skills are risk factors for neglect. Similarly, intimate partner violence. It's scary. That's a risk factor for neglect. If the parent is uninvolved, if the parent has many kids, it can be hard. If there's an unwanted pregnancy. If we peel back a layer and get to the community layer, we know communities can be isolating. If there's social isolation, if there's violence in the community, if there's lack of professional support in that community, that places that child at risk for neglect. And then at the society level, we're going to talk a little bit about poverty. We could probably, there's chapters and textbooks about this. So I'm not doing it justice, and I'm just going to address it for a minute. But poverty, we know that's a risk factor for neglect. And then lack of health insurance goes along with that. And so, there's a lot of different facets to this. Next slide, please. When we talk about risk factors and neglect, we're going to talk about poverty for a minute, but I just want to say that there are also protective factors. So I think we're really good at identifying these risk factors, but I wanted to also address the protective factors. So we can't give this talk without talking about poverty. We could, have an entire conference on neglect and poverty, but I just want to say that there's a ton of research on neglect and poverty. I think we understand this. I think we probably should stop researching this because we have a lot of data on this. And we know that poverty appears to be strongly associated with neglect, but I have this picture here to tell you that poverty does not equal neglect, okay? Poverty is associated with neglect, but poverty does not equal neglect. So we know that poverty can cause harmful effects on the health, the safety, the development of our kids. We know that. We know, however, that low-income families are not always neglectful to their children. That's not fair to say, and that's not fair to think that way. And similarly, we know that neglect doesn't happen in low-income families. Neglect happens in all communities. It's not limited to poor families or communities. We see neglect in, other parts of town. It doesn't matter the socioeconomic status. So I just want to let you know that we know that neglect is and poverty associated, but neglect does not, poverty does not equal neglect. Next slide, please. I just wanted to offer this resource while we're talking about poverty. If you are caring for kids in some capacity, the American Academy of Pediatrics has a great website on poverty and child health, and they talk about practice tips, they talk about communication materials, they talk about advocacy resources, and they have awesome, community-based interventions and tips. And so if you're a provider, I want to encourage you to reach out and click this link. Go to the American Academy of Pediatrics, and I think they can have some tip sheets that you can use in your clinic or in your community. Next slide, please. And then I wanted to talk about protective factors because I think they're equally as important. When we're talking with families, we need to identify these green flags, not just the red flags. So we want to try to identify kind of internal protective factors or external factors and see if we can strengthen those and see if we can highlight those. So if a parent has a good sense of accomplishment, or they feel really competent, or they're good at positive parenting, we want to encourage that. We want to reinforce that. If they have good options in the community, if there's a social support system, if they are connected with resources in the community, they're going to do better. And we want to highlight those and encourage those and provide those resources. And so, I want to say that I don't think we want to just always identify the red flags and identify problems. If we can be part of the solution, we can ultimately helps, improve outcomes. Next slide, please. So there's a lot of types of neglect. There's different definitions. There's physical neglect, medical neglect. We're going to go into those two in depth just because those are the ones I most see often in my clinic, and I can speak to some case examples. But there's dental neglect, and that's a huge problem. There's papers about dental neglect. Pediatricians and dentists are trying to work together to help kids improve their oral health, which we know improves their physical health. There's such thing as supervisory neglect, right? Failure to provide adequate supervision. There's emotional neglect, which is devastating, which has long-term consequences. Failure to provide adequate affection or psychological support. And educational neglect, which is unfortunately really common, where children aren't enrolled in school. They're truant, they're not attending classes. And that affects, absolutely everything. And it's sad how common that is. And then there's like this other category of neglect. And that's where you have like domestic violence, drug exposure, things that don't quite fit into these other categories, but are still really prevalent and really common. And so I wanted to hit and spend some time on the first two, just because those are the ones that I see in clinic all the time, and I think are the most common. Next slide, please. So we're going to talk a little bit about physical neglect and then medical neglect. Physical neglect is failure to provide the basic resources, so like food, clothing, shelter, hygiene. And I want to just be clear that this excludes failure caused primarily by financial inability, unless relief services have been offered and refused. And so if you don't have access to the resources, that's not fair to hold against you. So we're talking about you have been offered food, clothing, shelter, hygiene. There are resources available and you're still refusing. That's the definition of physical neglect, probably one of the most common types of neglect. Next slide, please. I picked this one as a subset of physical neglect because this is probably what you see in your clinic. And this is where, as pediatricians, as family medicine doctors, ER docs, if you're a school nurse, this is what we're seeing. And so failure to thrive, malnutrition is one of the most common forms of physical neglect, defined as a height and weight measurements that fall below the 3rd or 5th percentile. Another definition is when you have a downward change in your growth across 2 major percentiles, or we know that this is associated with abnormal growth and development. And so you are seeing this. If you're practicing medicine, you are seeing this. And these cases can be tricky. These cases can be multifactorial, and sometimes neglect is a piece, and sometimes medical is a piece, sometimes environmental is a piece. And so neglect may not be the only piece of the puzzle. There may be a lot of things that we have to address, and we can't act alone, just in medicine. So it's our job as pediatricians to figure out which part is medical, which part can we fix, and which part do we need to help the community address from other perspectives. And so next slide, please. We're going to go through how failure to thrive can be kind of tricky and some of the helpful ways that I have found working with these families. So the first and most important step when you're seeing these kids is to plot their weight and their length and their head circumference on a standard growth curve so that we can determine trends over time. And so I want to show you, this is the growth chart of one of my patients that I am really proud of, that I think was really successful. And I don't know if it's projecting like I wanted to, but you can see that their birth, if you're looking at the x-axis, there's age, and the y-axis, has their growth parameters. And you can see that baby was born on the growth chart, a little bit under the 50th percentile, and then they have no points until they're older, until they're several months old, about 8 months old. And so What that shows you is they didn't receive any routine medical care at our institution, and I was able to find out they didn't get any medical care anywhere. And it wasn't until they came in that they were off the chart small. See how that first growth point is off the chart small? And so that's concerning, and that's where we got to get to work. And then I want to show that, you know, with time, you can see that slowly but surely, week by week by week, the patient was able to grow and get back on the growth curve. But I want to highlight, look how many points there are there. I saw that patient almost every week to 2 weeks, because these patients, I want to really encourage you that they require a lot of constant follow-up, constant feedback, constant checking in. This is not someone that you can see and say, I'll see you in my clinic in 3 months, right? We have to do weekly weight checks, bi-weekly weight checks. And we want to make sure that they're slowly but surely getting better. Next slide, please. So we do have some numbers. We, as scientists, we don't make things up. We do have some research. I found this chart actually off of this random website that was pretty user-friendly and pretty easy to read, but talks about the major, you know, milestones that we shoot for. And so we know that babies should gain about 25 to 30 grams a day. So that's about 175 to 210 grams per week during the first 3 months of life. So when you go to the pediatrician, that's what we're checking. By 5 months of age, about 4 to 5 months of age, they should double their birth weight. By 1 year of age, they should triple their birth weight. So these are kind of some milestones that we're calculating and we're thinking. By 2 years old, they should be 4 times their birth weight. And by 3 years of age, they should be 5 times their birth weight. And so these are kind of just some ballparks that you can work through with your patients, with a nutritionist, you know, with the community, with the WIC office, to try to help your patients get to their ideal weight. Next slide, please. This is kind of an older paper now, but I actually cut and pasted the graph from a study in 2016 that talked about failure to thrive, because I think it helps us visualize putting failure to thrive in buckets. So there's kind of 3 main buckets when we think about failure to thrive, or potential causes of failure to thrive. There's kind of inadequate caloric intake, and that's where neglect is going to fall in. They're not getting the nutrition that they need. They're just not getting the calories. Mom is maybe mixing the formula wrong. They have food insecurity. They don't have enough resources. But there can be other reasons for inadequate calorie intake, such as they have reflux, and so they're spitting up everything. They're not getting in the calories they need. Mom is not making enough breast milk. The baby's not latching good. And so when you're reviewing these cases, I actually keep this chart by my desk and I kind of check each box and make sure I'm addressing every single one. It may be that they're not good at absorbing it. Maybe they have a medical condition, celiac disease. Maybe they have cystic fibrosis, and they literally cannot absorb the nutrition that they're getting in. Maybe they have an inborn error of metabolism. And so we need to go through this list, make sure we're not missing a medical cause. That's our job as the medical team, is to make sure we're not missing a medical cause. They may have increased metabolism. Maybe they have congenital heart disease. You know, hypoplastic left heart. Essentially, their body is running a marathon every day and they're burning through calories. It doesn't matter how much mom gives them, they're not gaining weight. And so it's our job as the medical team to rule out every single one of these cases before we consider neglect. You know, we want to make sure that we've thought through everything, we're mindful of these, and we've thought through every single one, and we're not missing anything. Next slide, please. And then what happens? What happens to these kids? We help them with failure to thrive, but what happens long term? What are they at risk of? And we know that they're at risk of vitamin deficiency, nutrition deficiencies, of course, poor cognitive development. They can be at risk of learning difficulties, behavioral difficulties, infections. Some of them may be normal. Some studies show that once we get kids back to normal, they don't have any long-term consequences. And so I think that provides hope, and that's what we work for, is that we want to get these kids optimized as soon as possible, get them back on the growth chart so they can achieve their be as successful and be great. And so not every patient that you see that's severe failure to thrive is going to have a long-term consequence. I'm hopeful that a lot of them get better. Next slide, please. I created a list of tips for medical professionals. And so I wanted to kind of say, here's some things that I learned maybe you should consider these. I always ask about the environment. So if you're part of the medical team, ask about the environment. How is the baby feeding? Are they sleeping? Are they sitting up? Do you guys eat dinner together on the floor? Do you sit at the table? Do you guys watch TV? Kind of what's the family eating patterns? What do you eat, Mom? What do you eat, Dad? How do you guys grocery shop? Do you have enough food? What do you have in your pantry? How do you prepare food? Is it the team effort, or is there someone assigned that's responsible, and what resources are available? Do you have groceries in your community? We got a lot of, communities that are grocery deserts, and there's not places to buy fresh produce. And so we can brainstorm, resources in that type of environment. Ask about medical conditions in the family. Mom, does celiac run in the family? Does cystic fibrosis run in the family? Does anyone have intolerance or allergies that may, be a family medical problem? And then I had to be sassy for just a moment. Forgive me. But I also want to remind you that sometimes, because this is hard for pediatricians, I think CPS and law enforcement understands, but pediatricians, it's hard for us to admit that our families may be lying or not telling the whole truth. And so I want to remind you to, always trust but verify. Sometimes parents may not be telling the truth. They may be liar, pants on fire. And that may be for several reasons. Maybe they don't feel comfortable telling you about their situation. Maybe they've got a lot going on and now is not the time. And so they may not be disclosing the whole truth. And so for that reason, I think we have to have a high index of suspicion. And here is where close follow-up is key. If you can see that patient regularly, or if you're with the department and you can get them in for regular weight checks, we may have an opportunity to build rapport. We may be able to formulate trends and see how the patient's doing over time. And that may help us get to the root of the problem and then be able to find solutions to the problem. Next slide, please. I also wanted to come up with tips for investigators. So I work with a lot of these families really, really closely, and I work closely with the department, CPS, and with law enforcement. And I came up with some tips for investigators. When you're working these cases, what can you do to partner with the medical community? So I would encourage you, if you are an investigator, to actually obtain the medical records. That is key. I think it is hard to do an investigation for concerns of child neglect or medical neglect without the medical records. It's almost impossible. And I know it's hard to get those. You have to, sign up for them, a release, go through the medical records department, contact the pediatric office. But I want to suggest to you that it's impossible to do investigation without those. So I want you to, if you're an investigator, ask the family about the appointment. How did it go? Did you make the appointment? What did the doctor say? But I want to suggest to you, do not only ask the family about the appointment. Call the doctor, call the nurse practitioner, call the nurse manager and say, how did the appointment go from your perspective? I work with a lot of investigators who just call mom and mom doesn't tell them the whole truth. And so it shouldn't turn into a they said, we should partner together. But I want to suggest that maybe the medical team holds a little bit more credibility than the parent. So I wouldn't take the parent necessarily at face value. I think you need to get information from both perspectives. And then, for investigators, calling and just seeing if the family came to the appointment does not necessarily mean compliance, right? That doesn't necessarily mean they're doing what they're supposed to do. They may not be giving the right formula. They may not be giving the right nutrition. So we have a lot of investigators that'll call the office and say, did the family make it? And then close their case. And really, it's more nuanced than that. We need to know, is the child gaining weight? Is their nutrition improving? Are their medical problems improving? And so just attending an appointment isn't enough. And then I want to consider family-based safety services, or FBSS, which is follow-up with CPS, which is a long-term, after 30 days, option for some families. If that's possible, if you can work with the CPS investigator and say, hey, is this family a candidate? I think this is where we can improve and prevent abuse. If we can work with these families long-term, offer them family-based safety services long-term, we can help. And that's like, in my experience, that's the most challenging part of these cases. We have a 2-month-old baby. The department CPS gets involved and they close their case in 20 days. But we know that baby is still at risk for several more months. And so if there's any way that we can work with these families long-term, I think that's key. Next slide, please. So we're done with physical neglect. I wanted to talk for a minute about medical neglect, which is another common type of neglect. So that's either failure to heed obvious signs of serious illness or follow the physician's instructions. Once medical advice has been sought, that's the definition. And this is when medical needs are neglected. Consequences can be really more immediate and can be more fatal. So if you've got a sick kid, you know, that's going to be more important that we address their medical needs than a healthy child. Next slide, please. When we're making this diagnosis, when we're working with families through medical neglect, there's an important paper. There's been several papers on this, but most recently in 2019 by Dr. Booz that goes through these 5 factors necessary to make a diagnosis of medical neglect. I think the slide is coming up. Next slide, please. 5 factors that are necessary to make a diagnosis of medical neglect. And really, medical providers only have to have 3 of the 5, but the 5 are really important. I think they're coming. These 5 factors are what we go through as a checklist. Oh, I think we went one too far. One back, please. These 5 factors talk about, is it necessary to review all of these before you make this diagnosis? So is the child harmed or at risk of harm because of lack of health care? That's the first one. And then I think through, is the health care going to offer significant benefit to the child? And these can be tricky, right? Do the benefits outweigh the risk? Is the recommended health care the standard of care? Does the anticipated benefit significantly greater than its morbidity? And these can be tricky, right? We have families that refuse chemotherapy when their child has cancer because there's a lot of side effects and it's hard. So not all of these cases are straightforward. We want to also try to show that it can be demonstrated that this family has access to care and it's available to them. It's hard to say medical neglect if they have no access to medical care. And then lastly, we want to make sure the caregiver understands the medical advice. So I have this list printed out and I go through this when I'm considering every family. Is this available? Have we explained this? Have we offered an opportunity to answer questions before I finally make this a diagnosis and say, you know, I think we're at the neglect point. Next slide, please. And so what is adequate health care? You know, when is too much and when is too little? There's some papers that have talked about like reasonable, adequate healthcare and what that means to people. So number 1, it talks about I think we're going to the next slide. It talks about adequate healthcare, like cleaning a cut. There's a minor injury. Did a parent try to clean, make a reasonable effort to clean a cut? I think we went one too far. I may be on a delay. That may be the problem. Can we go one back, please? There we go. Perfect. Thank you.
Okay, I wanted to make sure. Thank you.
Yeah, thank you. Thank you. So adequate healthcare is like people think of, does the parent clean the cut? Is that reasonable effort? Did they seek professional care when there was a moderate or severe problem, like such as there's trouble breathing? Did the parent bring them to the ER? And I put this one on here twice. It's number 3 and number 5, because I want to suggest to you that this doesn't just fall on the parent. As the medical community, that we have to make sure that the professional care meets the needs of the standard of care. And then we want to talk about, did the child receive preventative care? So those are all kind of signs of mild to moderate adequate health care. Next slide, please. And then I just threw this in here because I find, in my experience, when I work with investigators, there's a lot of misunderstanding of these 2 topics. And so I wanted to compare and contrast them. I know we're talking about medical neglect, but I just want to emphasize that is the opposite of medical child abuse. So medical child abuse, or what we used to call Munchausen by proxy, is sometimes confused with medical neglect by people in the community. So medical neglect is actually too little medical care. In contrast, medical child abuse is inappropriate or too much medical care. And so I think sometimes, a lot of times I find that we get these terms confused, whereas medical neglect is like an act of omission. Medical child abuse is an act of commission. Both of them are scary. Both of them place the child's health at risk, Both of them require, and we need communication with all the partners, and we need an extensive medical review in both cases. So I want to suggest how important reviewing the medical records are in both cases, but I just find that sometimes these terms can be confused. So I wanted to point that out. Next slide, please. So we're going to talk about when you're in your clinic, when you're seeing these patients, you're out in the community, you're in the schools. Here, what are we looking for? How do these patients present? These are the patients that are non-compliant. They're not taking their asthma medicine. They're not taking their seizure medicine. They're not taking their insulin. They may have a delay or even failure to get health care whatsoever. They haven't seen a doctor in 5 years. They're behind on their shots. They may be failure to thrive, like we talked about, or they may be obese. They may have exposure to environmental hazards, such as drug use, such as domestic violence, and they may have poor hygiene. So these are your kids that are disheveled. They're dirty. They're filthy. They've got dirt under their fingernail. They've got a rash on their neck. They've got skin breakdown because their hygiene isn't good and their diaper's not being changed. Next slide. When we talk about medical neglect, I kind of go through these questions. Is it really medical neglect or is it not? And every case is tricky. Is this a lack of resources or barriers to medical care? Do they have a lack of medical literacy? I do the teach back method. Mom, tell me what you understand. You teach me about the medical condition, so I make sure they understand. Is there a cultural context? We have some communities around here where adolescents, are perceived as young adults. When they're younger than I normally would think they could accept responsibility, but we have to take that in context. So, parents don't really get involved because it's an adolescent and they think the adolescent should be autonomous. I still think they require help from their caregiver. And so we have to take those cases, case by case. Maybe mom isn't coming to the appointments because she's being threatened by dad or vice versa. Maybe parents have mental health issues. And that's a big one. That's a huge one. So I want to suggest that you address that mental health issues of the child and the parent. And then lastly, just kind of a self-check. Is this a reasonable choice, but I wouldn't make it myself? That happens sometimes too. Sometimes we have to work in a team and we have to check our biases and we have to say, hey, I wouldn't make this choice, but does that meet the definition of neglect? So they can be tricky. Next slide, please. We know that it's complex. We know there's a lot of reasons why parents don't go to the doctor. I'm going to show you a list here. Poverty, lack of health insurance, mistrust of the medical system, misinformation, language barriers. There's studies on this. More and more recently with Dr. Google and access to the internet, we've got a lot of misinformation out there and conspiracy theories and mistrusts. And so we've got parents that really just, don't want to come to the doctor. They don't have anything to do with the medical system. And so that's a challenge that we're fighting. That's a battle we're fighting. And so, it's this constant battle of is that acceptable or does that you miss the standard of care? Next slide, please. We also know that there's healthcare provider factors why people don't seek medical care. Maybe their doctor isn't helpful. Their medical community isn't helpful. They're not sensitive to their culture. They don't communicate clearly. They don't speak my language. They don't have good teaching practices. Maybe the kid's an adolescent and they won't cooperate. They don't want to be sick. They're fearful. They don't want to take their medicine. So there's a lot of different reasons and from multiple perspectives why the family may not get medical care. So take that into consideration. Next slide, please. And then what do we do about it? If we're worried, do we always have to get CPS involved? That always seems so punitive sometimes, even though it's not meant to be. I view CPS as a resource. But here are some ways that you can confront the family to try to address the issue. You always want to talk about the health and safety of the kid, but without CPS or legal involvement. We use our social workers. We use our psychologists. We use our pharmacists. Hey, can you meet with mom and go over this insulin? We use our chaplains. You may involve the ethics committee and, we may involve hospital security. So I just want to suggest that there's a lot of ways that we can, as multidisciplinary team, kind of confront this issue before we absolutely are mandated reporters and have to involve CPS. Next slide, please. Why not report? Why do medical providers not report? We know there's a ton of literature that they don't. So many providers actually, did you know, are more likely to fire parents from their practice from missed appointments or non-compliance than to actually report to CPS. which is not helpful. Now the child doesn't have a medical community. They don't have an option when they get in crisis. Some providers know about this therapeutic alliance, like they feel like they're caring for the kid. They don't want to harm that rapport that they've established for 10 years. They don't want to harm that relationship. They think that they can slowly but surely help this kid. But actually, in the end, you know, we have to kind of weigh the risks and benefits, and we have to report if we suspect. Next slide, please. So when you're seeing these patients, you know, I want to kind of walk through step by step. What can we do? So we're going to end. I know we've got a few minutes left. When you're assessing the kid, I want you to talk to the parent in private, talk to the child in private, but also please, if you're in the medical community, talk to CPS and help them understand what are their concerns, what are their questions, because you know the literature best, you know the science best, and help articulate and explain to other professionals in the community. Talk to teachers, talk to social work, you know, talk to judges, talk to attorneys to explain the science. And next slide, please. And, you know, talk to parents about the red flags and the green flags, protective factors, risk factors. Ask when you're talking about neglect, do you have a crib at home? I worry about safe sleep. Do you have a car seat at home? Let me help you secure these resources so we can make sure that kid is safe. Next slide, please. When you're doing your physical exam, I want you to look at their weight, their height, their BMI, head to toe checkup, looking at their skin. We focus a lot on the skin, on the teeth, on the genitals, make sure that they're safe and healthy. Look at their general appearance. Look at, are they groomed? Are they disheveled? Are they dirty? Check in on their mental health. Are they depressed? Are they hungry? Are they irritable? You know, talk about their development. Are they behind? Are they advanced? Is there some area we can supplement with resources? Next slide, please. And then when you make the diagnosis, I want to suggest to you that that's the starting line. It's not the finishing line. So if you make the diagnosis of medical neglect and you're worried, what do? That's really where we start the race. You can't just abandon, call CPS and sign off. The goal is to help the child get to a nurturing environment where their medical needs will be addressed. So this is when the work starts. A lot of people think that's where we end, but that's actually where we start. So next slide, please. So when we respond to neglect, these are challenging conversations and they take time. I'm lucky that we have really lengthy appointment times and we can go through the nitty-gritty with parents and get into the weeds. But I know you all, when you're seeing patients, you may not have time, but I want to suggest that a two-way exchange is important. You want to ask questions, but also give the parent time to ask you questions. Make sure they understand, validate, reassure, talk about the goal. The entire goal of the entire visit is to make sure the kid is safe and healthy. Try not to use medical words. Take time to say, Mom, what's your agenda? What are your questions? What are your worries before you introduce your suggestions? And try to partner with the parent. Try not to avoid them and ask open-ended questions. Give them an opportunity to explain, but understand that they may not feel comfortable explaining. Next slide, please. I always consider the safety and the severity. So is this a failure to thrive kid that we need to admit today? That's going to be more severe. Is this kid near death? Do they need to go to the ICU? That's different than a kid that's in clinic that you can follow up regularly. Talk about the parents' needs, the child's needs. I find a lot of parents need mental health resources. You know, they're just not at their best and they can't take care of others if they can't take care of themselves. So try to be kind, but firm. Because we worry about kids. Begin with the least intrusive intervention. We don't want to come in and change 100 things and suggest that they're doing everything wrong. I try to just offer small, helpful tips. Ask the family to partner making the plan. If they're part of the plan, they're more likely to do that plan. And then establish regular follow-up. So keep them in your clinic long-term. Next slide, please. We can be really knowledgeable about community resources. And I know this is hard. If you're in a busy clinic, you're seeing a lot of patients, this may be where you bring in your social worker or your practice manager and say, hey, we need to help. So, you know, we need to be knowledgeable about WIC and food bank and help me grow. Different community partners that may be able to help families get the appropriate resources. Try to help facilitate referrals. Do they need a dentist? Do they need an eye doctor? Do they need an endocrinologist? Have applications in the office if possible. But try not to overwhelm families. If we try to send them to all these resources, they can't get anything done and they don't know where to start. So slowly but surely partner with them. And then, I think this is probably the most challenging part, is that recognize we can't fix everything on our own. This is not something we can just do. We have to reach out and develop a team approach to these long-term cases. Next slide, please. So here are some resource, options that you may consider. We talked about WIC, we talked about food bank, mental health resources, drug treatment programs, domestic violence resources, nurse family partnership, Help Me Grow, child care facilities. It's hard to work if you're also supervising kids, shelters, medical legal partnerships, and CPS. CPS is a resource I use all the time to help families. So try to be knowledgeable about these and have information about these in your practice. Next slide, please. This is kind of the summary. I know we're out of time and I appreciate your time. These are kind of what I think is most important. I think, that a child-focused, blameless team approach is the best way to care for these kids. And I want to emphasize, this is just my personal opinion, but I think these families need help long-term. So if you can be one piece of the puzzle and try to stay involved with these families and work with them as long as possible, that's going to be key, and that's how we can help. So that's kind of my end, and I have some resources, and I think I have my contact information if there's any questions.
Thank you, Dr. Peeler. We did have one question in the chat that wanted to know if you would be willing to share your slides.
Sure. I'd be happy to. I can send, let me make sure all my references are up to date, and I'll send you the PDF.
Perfect. And then I think we have one more question here in the room.
Dr. Peeler, I know that to prove like neglectful supervision, you need, I guess, for the prudent person, would they consider that neglect? So being obviously in the careers that we are, I always wonder, are we too, I guess I'd say judgmental, but say if we have an 8-month-old that is left on a bar stool, kitchen bar stool, alone, or maybe a pool, they have a pool, but they don't have a fence around it, and they have a large doggy door that they have a 18-month-old or something that could go out of that. Would those things be considered by a prudent person as being neglectful?
Those are hard, right? I feel like every case is hard and every case is individualized. And that's why I would suggest that we have a multidisciplinary approach and different perspectives, because we may have different opinions on these issues, depending on how we were raised, where we were raised. For example, recently, I grew up in the city and I thought it was crazy that people burned wood outside on the farm and let their children just roam. But I have learned, and I was corrected, that that's normal and that, that doesn't scare people. It terrifies me. So I had to be checked. Someone had to say, get with it. And so I think sometimes we may need different perspective on these issues, and it may require an investigation. It may not be something that we can, just figure out in one conversation. We may have to do a lot of digging and see, is this a pattern? And, sometimes sometimes there's just bad parenting, and it's not necessarily neglect. So it's hard to define each of those cases, but ultimately it's the department's job to decide, when does this break the definition, is when does this break the law?
Thank you.
Dr. Peeler, another question is, do you consider it neglect or abuse when a child has decayed or broken teeth secondary to a bottle left in its child's mouth at night in their crib?
I do, and there's definitions of dental neglect, and there's really great publications on dental neglect. And we know that places the child at risk of poor nutrition, infection, abscesses, they can't grow. And so I do consider that dental neglect. What happens with that is I don't have great follow-up on that, because that would require a dentist. But I think in those scenarios, often it's education and access to resources. But yes, there's absolutely a definition of dental neglect, and I would consider that dental neglect.
Well, thank you so much, Dr. Peeler. You gave us a lot of great information, and we really appreciate you doing this presentation for us.
Thank you. Thanks for having me.
Thank you. So our next speaker is going to be Dr. Sarah Victor. Dr. Victor received her master's and PhD in psychology at the University of British Columbia in Vancouver and her postdoctoral training in psychiatric department at University of Pittsburgh. Her research areas include adolescent suicide, borderline personality disorders, and self-injury. She is a licensed clinical psychologist currently. She has a private practice and then also serves as an assistant professor at the psychology department at Texas Tech University. Dr. Victor will be discussing self-harm and suicide.
Thank you so much for allowing me to present on a topic that's very near and dear to my research endeavors and my clinical work. I apologize that I'm not able to be there live for the actual conference, but I'm really grateful to be able to kind of get this material out there, and I'm very happy to answer questions via email or meeting after the conference if people have additional follow-ups as well. So my name is Sarah Victor. I'm a licensed clinical psychologist and faculty member at Texas Tech University in the Psychological Sciences Department. And essentially all of my research to date has focused on understanding and identifying risk factors for both suicidal thoughts and behaviors, as well as non-suicidal self-injury urges and behaviors in both youth and adults. So today, I have a number of objectives that I'd like to discuss and cover with you, really starting from the assumption that many people haven't had a lot of training in these issues or may have had training a while ago or may not see them in everyday practice. So trying to kind of cover all of our bases here. Starting by talking a little bit about what suicidal thoughts and behaviors are, what non-suicidal self-injury is, and how they can sometimes overlap, and of course, the ways in which they're different. You'll notice that I abbreviate non-suicidal self-injury as NSSI on the slides, just for succinctness. And then I'll spend some time talking about identified risk factors for both suicidal thoughts and behaviors and non-suicidal self-injury urges and behaviors as they apply in youth, with a real focus on the types of risk factors you might learn about in your practice or in your interactions with youth. Then I'll spend some time talking about methods of assessment to better understand level of medical severity, level of psychological risk, and some strategies to ask questions about these really difficult topics. And then lastly, I'll talk about interventions for suicide prevention and for NSSI prevention and treatment. Now, the goal of the presentation isn't necessarily to kind of fully dive into each and every one of these interventions, but to at least talk about some common principles that apply across interventions, as well as give you some directions for further reading if you're interested in learning about specific types of approaches to address these issues with youth. So talking about NSSI, it's important to kind of define what that is and what is not included in that definition. So our main professional organization, the International Society for the Study of Self-Injury, defines NSSI as an intentional, direct destruction of body tissue that is not for suicidal purposes and is not socially sanctioned. So oftentimes when I talk about non-suicidal self-injury, the first thing that comes to mind is something like cutting oneself. But there's also other methods that folks use, such as burning, hitting oneself, hitting objects. And then there are sometimes even less common methods, for instance, sticking oneself with needles, pulling hair for the intention of causing pain or injury, which is a little different than a disorder called trichotillomania, where people essentially can't stop pulling hair as a habit. And even in some cases, much more severe injury, like ingesting toxic substances or intentionally breaking bones. Those are less likely to be seen in outpatient practice, of course. And then it's also important to say, well, what doesn't fall in that definition? So there are certain types of behaviors that, at least in certain subcultures or in certain communities, are treated as normative behavior, even though they involve some kind of bodily damage or injury. So for instance, tattoos or piercings. In many communities, those are perfectly acceptable, and so we wouldn't include those under that umbrella of NSSI. And then, of course, because NSSI specifically is non-suicidal, we would not include a suicide attempt in this category. And I'll talk a little bit more in a few slides about how we sort of try to differentiate that if you're not quite sure what someone's intentions are. And then we also typically exclude behaviors that may have an impact on one's physical health, but where the goal of the behavior is not destruction of bodily tissue. So for instance, substance use, we know, can have serious physical consequences. Disordered eating behavior can have physical consequences, but those generally aren't the motivation behind the behavior in the moment. So obviously still clinically important, but doesn't typically fall under this umbrella. And then when we think about suicidality as kind of a broad construct, typically researchers and folks who specialize in this clinical practice try to differentiate between suicidal thinking, suicidal preparation, and suicidal behaviors. Because we know those look different and the level of risk involved is also quite different. So suicidal thinking or suicidal ideation is often differentiated into so-called passive versus active thoughts. Passive thoughts might be more along the lines of wishing you were dead, wishing you could go to sleep and never wake up. Typically, those thoughts involve thoughts of death more so than thoughts of actual suicide. Whereas active suicidal thinking involves the thoughts, I wish I could do something to cause myself to die, or I wish I could do something to kill myself. A lot of people actually in the community, when we look at prevalent studies, both in children, adolescents, and adults, these thoughts are quite common. If you ask people, have you ever had a thought like this in your life? A pretty significant proportion say yes. Where we see quite a drop off in terms of prevalence is in the next steps that people take. So far more people have these thoughts than eventually act on them or take preparatory steps. So those could look like researching a specific method, thinking about a way in which one might kill themselves, obtaining means to enact that method, or determining a specific day or time or place where the person's thoughts about suicide are becoming more concrete and more potentially easy to implement as they're thinking about the details. And then those thoughts typically precede suicidal behavior. So this could involve suicide attempts or death by suicide. And in the research literature on this, we usually don't differentiate on the basis of the medical severity of the act. We look at the intention of the act, so what the person was trying to do. And this is particularly important in youth because we know that youth sometimes have very different and potentially inaccurate perceptions of how lethal a certain behavior is. And so there can be times where a young person tries to engage in a behavior that they think is relatively safe, but is actually very, very dangerous, or vice versa, where they engage in a behavior that they think is very highly lethal, but is actually not particularly medically severe. And so usually we're focusing on, well, what were you hoping would happen when you engaged in this behavior? Were you hoping that you would die, or were you hoping for something else to happen? And the methods certainly vary and are often different from the methods of non-suicidal self-injury. One method that's particularly important to know and think about, especially in places with high gun ownership rates, is firearms. And I'll talk a little bit about that in the intervention piece as well. We know that firearms are a relatively uncommon method of suicidal behavior, but they're very, very highly lethal when an individual chooses to use that method. And so oftentimes it's sometimes a complicated conversation to have with children and families, but important to know about how guns are stored in the home, especially in relation to safety if a child's at risk. So just a couple notes about language here. There's lots of different terms that are used across these fields. Because I do a lot of scientific research and we're often very wordy, we use the abbreviation NSSI, but few people in the community who engage in that behavior use the term NSSI. One term you may see in older literature is self-mutilation, which tends to not be used as much anymore. And in terms of suicidal thoughts and behaviors, there's a lot of different terms for different experiences. One thing that's been recommended, particularly when you're talking to journalists or to the media or in kind of public-facing communication, is trying to avoid the language around committed suicide. And essentially that's because often the term committed is used to refer to things that are immoral or illegal, right? Someone committed a crime, someone committed a sin. And historically, that's often been how suicide has been viewed. But many people really object to that terminology because they feel it's stigmatizing. So often we'll recommend journalists say died by suicide or something like that to try to avoid that kind of unintentional potential baggage associated with the language. So another thing that I think is really important to talk about with both of these sets of experiences is why people engage in these behaviors. This is often the first question that I get from parents whose children are struggling or from clinicians who, I'm doing a presentation and they don't see this that much in their practice. And they say, why would someone do that? That doesn't make sense to me, right? And thankfully, we've actually had quite a lot of research in the last 15 to 20 years to try to answer that question. So non-suicidal self-injury, and I would say actually both of these types of behaviors have similar kind of divisions of how these behaviors happen or why they happen. By far the most common reason that people report engaging in self-injury is as a way to regulate or change their internal emotional experiences. So the most common answer that people give is, I was feeling really, really terrible. I was having really intense negative emotions. Maybe they don't phrase it quite that way. And this was something that temporarily made me feel better. Often then what happens after that is guilt and shame and sort of this cycle where those negative emotions come back. But in the short term, people report that it does something to distract them or to feel slightly better in the moment. The next most common reason, which is also extremely common, is to punish oneself. So the perception, well, I did something wrong or I'm not a good person. This is a way to feel like I've punished myself and then I feel better because I feel like I've done something to address this perception that I'm not a good person or I did something wrong. You do then also sometimes see it, particularly for folks with a history of trauma or difficulties with dissociative experiences, where they report it's kind of a way to feel something. Like I'm not feeling anything, I feel numb. And so this is a way for me to generate some kind of feeling, even if it's painful. Now, there are some what we refer to as interpersonal reasons for NSSI as well. But on average, these are endorsed much less frequently. And the truth is that many people, probably the majority of people who engage in self-injury, don't actually tell other people that they engage in it. So historically, there's been a lot of kind of views that this was attention seeking or was done to kind of get a rise out of other people. And now we know that, yes, that can happen. And it's not the majority of people who are struggling with this behavior. So we do occasionally see people who say this is a way to get care or attention from someone else, or to kind of get out of a social situation with somebody else to kind of avoid those interactions. And this is some parallels with relation to suicidal behavior. So this is actually a relatively newer area of study. A lot of times motivations for suicidal behavior were kind of inferred on the basis of what people around the person, how their reactions were, as opposed to saying, well, what did you actually hope would happen when you engaged in this behavior? Or what prompted you to, you've been thinking about suicide for a long time, what prompted you to act on it on this particular day at this particular time? So most commonly what people report is feelings of hopelessness, and often in conjunction with this very intense emotional pain. So the idea that I'm suffering, I feel terrible, and I don't have any reason to think it's going to get better. And some people will describe that using the language of escape, the idea that my experience is so intolerable that this is the only way I can escape these negative feelings. In terms of interpersonal reasons, again, they're less common. And even when they are interpersonal, they're related to how the person kind of feels about their interactions with other people. So very few people report, well, I'm engaging in this behavior to try to get attention from this other person. But sometimes that emotional pain can be motivated by either feeling like you're a burden on other people, like your experience causes pain for others around you, they'd be better off without you, or feeling like you don't belong, like you don't have that social connection, you don't have those other people to rely on. So sometimes when I'm going through these presentations, I get asked, well, how are they seem a little similar, or, why are you presenting them together? So generally when we're trying to differentiate these things, we're primarily thinking about the intention behind the act. And that's something that you can really only get to by talking to the person, right? What were they hoping would happen? And as I mentioned before, this is especially true in adolescence, where trying to infer their intent based off of the medical severity of their injuries may not be accurate. You may look at a youth that engaged in low medical severity behavior and think they're engaging in non-suicidal self-injury, but they may have really hoped that they would die at that point. So very important to ask. And then, of course, even though these have key differences, there's a reason why I often talk about them together. The most key reason being that these experiences serve as risk factors for each other. So we know that youth who engage in non-suicidal self-injury have higher later risk of suicidal thoughts and suicidal behaviors. We also know that youth who experience suicidal thoughts or behaviors will sometimes use non-suicidal self-injury as a way to cope with those feelings in the moment. Now, that's not something that you would, certainly encourage in a therapy context, but it's important to know if a youth is engaging in NSSI, is this something you're using because you're feeling really suicidal? And as we try to help you come up with alternative coping strategies, how can we make sure that you're staying safe when you're having those suicidal thoughts? So there's a lot of reasons why, if you're encountering someone who's experiencing one of these things, you should pretty regularly ask about the other as well. So I'll transition a little bit to talk about risk factors for non-suicidal self-injury and for suicide. So in general, we know that youth who have psychiatric or mental health disorders are at higher risk of NSSI compared to youth who don't. So across lots of research, we see that certainly depression has been associated with non-suicidal self-injury. Some anxiety disorders, although the patterns seem to differ depending on which anxiety disorder you're looking at, as well as when we think about behavioral disorders like ADHD, oppositional defiant disorder, things we might put into sort of the externalizing spectrum. And within anxiety, I should say that PTSD in particular seems to be associated with non-suicidal self-injury. And I'll talk about that a little bit when we talk about the history of abuse in a couple bullet points. And then also eating disorders and folks struggling with substance use disorders. There seems to be some overlap between the capability to harm oneself physically in certain ways, along with other ways as well. So just very important to kind of know that if you're working with youth with these experiences, assessing for NSSI might be an important component. We also know that exposure to either non-suicidal self-injury or suicidal thoughts or behaviors is associated with risk. This could either be within the family, so parents, siblings, or it could be within peer groups. And this is sometimes a tricky thing to navigate, in part because certainly within families, we don't know if that's because of actual knowledge of the behavior, or if it's because of maybe genetic risk factors that contribute to mental health difficulties broadly. And within peers, it can be really challenging to figure out, is this risk higher because these youth are somehow reinforcing each other, or is it that youth who are struggling tend to find each other and find other friends who are also struggling, right? So oftentimes when I've worked with youth and they have friends that are struggling, they say, well, it's not that my friend convinced me to do this or that I feel triggered by this friend. I really want to help them and they want to help me. And we have a hard time helping each other because we're both struggling at the same time, right? So those are just some of those nuances that are tricky. You know, I certainly wouldn't recommend saying you can't have any friends that are also struggling, but you may want to find out what those relationships look like and whether they're helpful or harmful to the particular child. In terms of a history of abuse, we certainly know that that is associated with increased risk of NSSI. One sort of set of findings in the literature specifically focused on childhood sexual abuse and whether that was a unique risk factor for NSSI compared to other things. And essentially what they found over several decades was that childhood sexual abuse is a risk factor for a number of negative mental health outcomes, right, across the board. And so it doesn't seem to be uniquely associated to NSSI specifically, but is a risk factor broadly for all sorts of difficulties, including NSSI. So that's just one thing to keep in mind. Research in other types of childhood abuse has been a little bit less consistent. And then we also want to think about demographic characteristics that might be indicators of risk, not necessarily that those demographics are causally related to risk, but that they might indicate a higher need for screening. So we know that overall rates of NSSI appear to be higher in cisgender girls compared to cisgender boys. Part of this is tricky because of the way self-injury is often assessed. So girls are much more likely to engage in cutting behavior compared to other types of methods of non-suicidal self-injury, whereas boys are more likely to report things like hitting, hitting themselves, hitting a hard object, burning, things like that. And so some of the data that shows that there's a higher rate in girls has been from studies that just asked about cutting by itself. And so one of our concerns in trying to study these experiences is whether we may be missing boys who are experiencing this because we're not asking broad enough questions, or we're not asking them in the right way to maybe capture how this might look different between boys and girls. So that's just something to keep in mind. We also know that rates are higher for youth who identify as lesbian, gay, bisexual, or transgender, or queer. And research seems to suggest that that's because of the additional stressors that youth with those identities experience, such as bullying, family rejection, victimization at school, things like that. So it doesn't seem to be related to the identity itself as much as what experiences those youth have that are really psychologically stressful that heterosexual cisgender youth may be less likely to experience. In terms of racial or ethnic differences, I don't have a bullet point here for that because there's actually been not a particularly clear pattern of results in terms of racial or ethnic differences. Some research finds differences, some research doesn't. So in terms of risk for suicide, this research has been going on for longer, so there's a little bit more information out there in terms of risk factors. Some of these are the same risk factors as for NSSI, so I won't go through the list again, but then some are more unique. So certainly youth with psychiatric disorders, but also youth with physical health problems. So disorders that are associated with recurrent pain, especially pain that's difficult to manage, so chronic physical health conditions, as well as traumatic brain injuries, so things like concussions, head trauma, whether that's because they're related to pain or because they're related to difficulties in kind of inhibiting someone's emotional or behavioral experiences. It's a little harder to tell. And then certainly exposure to suicide among friends, family, and even online. One thing that we've noticed in the last 15 to 20 years as social media has really kind of exploded onto the scene is that youth are able to access a much larger community of peers than when they were sort of limited to who was in their school or who was in their neighborhoods. And in some cases, that can be really great. Youth can find other people to connect with that maybe aren't reflected in their local communities. But it also means that they may be exposed to communities that are sort of encouraging these things, or where suicidal thoughts or behaviors are treated as really normal. And that can make it more difficult for kids to ask for help or to kind of identify that I don't have to feel this way. And there's been research on specifically kind of how the media covers high profile suicide deaths and trying to create ways for the media to cover those deaths responsibly without kind of sensationalizing or creating the idea that, you know, this is a way to get people to recognize how much pain you were in. We also think about this in the context of suicide clusters or suicide contagion, which is when within typically a local community, you experience multiple suicide deaths at the same within a short period. Often when we see this, it's in schools. And there's some specific recommendations for what to do in those contexts to try to recognize the loss that those students have had, while also not unintentionally kind of reinforcing that this is a decision other kids should make. And the focus of study on those kinds of clusters is often referred to as suicide postvention. So we have prevention, trying to prevent suicide, and postvention, what you do after a suicide's occurred in a community. So if that's something that you support communities with, or God forbid at some point that comes up for you, just know that the term you're searching for is suicide postvention, and that's where you're going to find resources for how to address that in communities, which I'm not going to talk much about in this set here. So again, youth with a history of abuse, neglect, childhood trauma, we know those things are certainly associated with suicide risk, and youth with access to lethal means. So as I mentioned before, firearms being one of those, but that can also be things like toxic chemicals, pesticides. If a youth has a driver's license and can take a car out, and you know that they are feeling very suicidal, you might want to think about, do we want to have them operating a motor vehicle at that point? And then in the short term, we know that significant psychosocial stressors are associated with short-term changes in risk. So for instance, being, the target of bullying, target of harassment, rejection, loss. Oftentimes these are interpersonal in nature, but sometimes these negative experiences might be related to achievement stressors, like problems at school, problems in a sport that the child's really invested in. We also know in terms of substance use that acute alcohol use is particularly concerning for youth who are at risk of suicide, because they may behave more impulsively while under the influence of alcohol. And when we look demographically, we find that there's some differences related to gender. So on average, girls are more likely to engage in suicide attempts, but they are less likely to die by suicide compared to boys. And this seems to be primarily because of the types of methods that are more commonly used by girls compared to boys. Boys tend to pick methods that are more likely to be lethal. So in both cases, it's hard to say one is more at risk than the other, because you want to be assessing risk in both cases. And again, we see that suicidal thoughts and behaviors are more common in youth who identify as gay, bisexual, queer, again, related to a lot of those stressors that we talked about before. So I'll talk a little bit about now about some strategies to assess for NSSI and for suicide. So this is actually a pocket card that was designed by a colleague of mine. The reference for the article that it comes from is at the end of the slides. You can download it, you can print it out, and it was actually designed for MDs who were working in an emergency room setting or in another setting that wasn't primarily psychiatric, but where they might see youth with NSSI and not really know where to start. So the idea was, we're going to come up with this acronym, this SOARS acronym, that's going to be easy for people to apply as just sort of a first pass set of questions that you might need to ask if, let's say, you're in an emergency room and you have a youth that needs stitches because of self-injury, right? So part of this is more related to the medical side of things. So there's a really nice question at the top of this that just asks about NSSI broadly. So have you ever hurt yourself on purpose without intending to end your life or attempt suicide, like cutting, biting, burning, or hitting? And in my view, it's really important to ask these questions showing that you know the difference between non-suicidal self-injury and suicide. A lot of times people will ask, well, have you ever done anything to hurt yourself? And youth sometimes don't know how to answer that question, or they might be concerned that if they are struggling with NSSI, that you might think that they were suicidal if they say yes, right? So I can say, at least in my clinical experience, that when I frame these questions showing, hey, I know that there's a difference between this experience and that experience, and I want to know about both, youth in general seem to trust me more with that information because they're a little less concerned that I'm going to overreact and assume if you're engaging in NSSI, I need to send you to the hospital right now because you're at imminent risk of suicide. So if the youth says yes to this kind of summary question, there's these follow-up questions asking about some key risk indicators, both in terms of physical risk and emotional risk. So the suicidal ideation question again gets at this way to make it clear to the youth, I know that this isn't usually about suicide, but sometimes people are thinking about suicide when they engage in these behaviors. Do you ever feel like that? So again, you're asking this really important question where you know that these youth might be at higher risk and you're validating that you're not making an assumption about that person's experience. The next section, just asking for more details about the actual behavior. So how long it's been going on, how often it's happening, and what they're typically actually engaging in. So for instance, you might be concerned about infection risk if you're an MD trying to assess this in an ER. And that's also part of the reason for the aftercare question, trying to figure out, is this something where we could be concerned about an infection, about blood loss, about, acute medical needs. And then the R stands for reason. So this gets at kind of that, why are you engaging in it? And it really starts from this sort of motivational interviewing approach of assuming that people do things for a reason. So rather than saying, well, that seems dumb, why would you do that? Saying, it sounds like this is doing something for you. Kind of what is it doing for you? And then you can sort of improve buy-in with youth to figure out, well, okay, if that's what it's helping with, then you can ask, is this something you'd ever consider stopping? What are maybe the downsides of it? And that's that kind of last set of question around stages of change. Some youth will say, no, I'm not interested in stopping. And in that case, it depends a lot on your role working with the youth, right? If you are a medical provider who's going to discharge this child in 5 minutes, you may not have enough time to kind of talk through those benefits with them. If you're an outpatient therapy provider, you might be able to say, okay, this is how you feel about it right now. Let's table it and talk about it next time. Versus if it's something where there's a real high medical severity, you might need to kind of be a little more directive in the short term. When assessing suicide risk, we have a lot of different kind of components. I don't have quite as neat of a little card to go by, but these are really sometimes things that you're going to be asking specifically of the person in the moment. And some of it you may already know if you're working with someone in a therapy context or you've engaged with them before. So One of the really important things that I think often gets missed is what's driving the person to feel so terrible that they are thinking about suicide. So where is this pain coming from? You know, what's been going on that is prompting them to think about this? Even if you can't necessarily fix it in the moment, it can be really validating for people to know this person's not just interested in, you know, deciding whether I go to the hospital or not. They're interested in trying to figure out how to help me. With respect to the actual kind of suicidal piece of this, you want to find out how intense the thoughts are and what levels of preparation or behavior the person's been engaging in. So are these thoughts that have come up once or twice and they, you know, disappear pretty quickly? Or are these thoughts that the person's having all day, every day, just kind of repeatedly in their head? And you can ask, you know, when you have these thoughts, have you thought about something specific you would do? Okay, what would that look like? And then try to figure out, is this something where the person's taking steps to make that more feasible? Or is this still in kind of the vague, you know, just kind of thinking about it level of preparation? You also want to know what the person describes as their ability to cope with these thoughts. So, you know, to what extent do they have strategies that they use or that they could use when the thoughts come up? So when they happen, do you distract yourself? Do you call a friend? Do you have a clinical provider who knows about these thoughts? What have you talked to them about in terms of how to actually work with these thoughts? And do those strategies work? So oftentimes we ask, well, what could you do if you have these thoughts? And someone says, well, I could call a friend. And then, at least in my experience, sometimes I ask, okay, have you ever called a friend? They'll say no. Say, okay, well, what's the difference between knowing I could call a friend and actually calling that friend? Maybe it's that these thoughts happen at 3 a.m, and so they don't want to call the friend when it happens. Or maybe texting is better than calling or something like that. So kind of troubleshooting and the extent to which the person can engage in that conversation with you is also a really important indicator of risk. You also want to know about a history of impulsive or risky behavior. So one of the real challenges in suicide prevention is knowing that people's thoughts and their intentions change over time. Somebody sitting with us in an office might say, I feel a certain way, I feel like I can stay safe, and 2 a.m, they might feel different. And so trying to figure out, has this person ever engaged in behaviors that were kind of spur of the moment, where they didn't think they were going to do them and then something changed and they did them? And that also can relate to things like substance use, especially alcohol use, because we know that that can change people's intentions. Certainly history of non-suicidal self-injury or suicidal behavior. We know that those things are risk factors. And we know that there's no guarantee that if someone's experienced these in the past, they'll necessarily experience them in the future, but you always want to know what that looks like. It's also really valuable to talk through what the person's reasons for living are. So when they've had suicidal thoughts in the past, what kinds of reasons or things have they thought about that kept them from acting on those thoughts? That could be moral values, religious values, the impact on family or friends, hope for the future, you know, really trying to get them to generate what those are. And if the person says, I don't have any, that's also a really important risk factor to note. And then again, you're assessing for access to lethal means. So if the person lives in a home with a firearm, is that firearm locked up? Is it stored loaded or unloaded? Does the person have access to both the ammunition and the firearm? For youth, often we're thinking about, you know, do they know where the key is? Can the parent put it somewhere where the youth doesn't have access? This can also relate to things like medications. So sometimes we'll ask parents to kind of lock up medications if that's what the youth has talked about potentially using, sharp objects, really kind of depending on what the person's reporting as what they're thinking of. So I covered a lot of things to ask about, but there's also a lot of things to sort of avoid doing. So oftentimes when I'm training graduate students in clinical psychology, I try to emphasize that there's this balance between overreacting and underreacting. So you certainly don't want to say to someone, well, you don't have anything to feel this sad about, or you're just making a big deal out of nothing, right? That's invalidating. It means they're probably not going to tell you about when they're struggling in the future. But there's also risk associated with kind of assuming the highest level of risk when maybe that's not indicated, and jumping to interventions that may have significant costs to the person and may lead them to not want to disclose to you again. So I can think of a number of clients I've worked with where they were struggling with non-suicidal self-injury. They had lots of safety plans around suicidal behavior, and they told a new therapist about the non-suicidal self-injury, and the therapist, without consulting with them, just called the police to take them to the ER. And a lot of times clients say that was really terrifying. I didn't feel like I was in control of the information I had shared. I had been told this was going to be confidential, and it wasn't. I was scared that I was going to be involuntarily hospitalized. And so that's not to say that there aren't situations where you might need to call the police, but to really think through what is the level of risk of this person in front of me right now, and what's the best way for me to help them in kind of the least restrictive way possible. So particularly with youth, we often struggle with this question of disclosure. So if a young person tells us about this, do we call the parents? Do we call the guardian, right? And a lot of times when I talk with clinicians and when I talk with parents, they say, I'd want to know. So yes, of course I'm going to tell them because I'd want to know. And it's important to keep in mind that that's actually not typically what our kind of codes of ethics actually require of us. The assumption is that youth do have the right to privacy and confidentiality the same way that we as adults do, unless they're at imminent risk of serious harm or danger to themselves or someone else. So again, you're trying to balance the ability to continue to work with that youth, with maintaining rapport with them, with keeping them safe, with knowing that, sure, if I was a parent in that situation, I might want to know that information. And that's not necessarily reason enough to make that disclosure if there's not really imminent risk involved that meets that legal threshold. It particularly comes up a lot with non-suicidal self-injury, where it's quite rare that we're talking about very serious physical harm, but oftentimes clinicians kind of follow a different set of standards, and youth, as a result, don't want to disclose. And of course, if they don't disclose, you can't really help them with it, right? Sometimes you can also work with a youth if you feel like it's important for the family to know, to talk through that process about why they haven't told the parents, what kind of pros and cons there are, and try to make that a more collaborative process rather than taking that power out of the hands of the child. Another thing that sometimes comes up in these contexts is the idea of a no harm contract. These used to be really, really popular, with the idea that you would have a client sign that says, I'm not going to engage in self-injury, I'm not going to kill myself. There's kind of an intuitive appeal to it. It feels like you're doing something. Unfortunately, the data suggests that these contracts do not actually prevent people from engaging in these behaviors, and often are perceived by clients as sort of a CYA mentality, and are not considered the standard of care. So a lot of times clinicians will say, well, I had them sign a no harm contract, so that covers my legal liability. And that's actually not true. You're required to do lots of other things beyond that. So shifting to talking about interventions, as sort of general principles, you of course want to make sure that the youth is physically safe, whether it's related to an acute injury they have or restricting access to means. You're also going to try to identify what coping skills this person already has to manage in a crisis, really brainstorming with them about how to make this work, and trying to identify support people that they can reach out to. Sometimes that might be you, depending on your role. You know, if you're a school counselor and the child's struggling during the school day, they might be able to come talk to you. But you might also need to identify support people, for instance, if they're struggling in the middle of the night. And then trying to connect with mental health resources in your community. Again, if that's not the role you're already playing, right? So there are a number of specific interventions that have been tested for addressing non-suicidal self-injury and suicide risk in youth. just a broad list here. And again, we're not going to go through in a ton of detail. A lot of these are based off of cognitive behavioral therapy principles or dialectical behavior therapy principles, which is essentially cognitive behavioral therapy with an added mindfulness acceptance component. We've also seen a lot of family-focused or family-involved therapies, either added on to other treatments or standalone. There's also some evidence on brief contact interventions, which I'll describe in a couple slides, as well as means restriction, so talking about that access to lethal means piece, and psychoeducation. Across all of these types of interventions, you see a lot of shared components. So education about mental health, about kind of coping, about distress tolerance, developing coping strategies, social support, and trying to increase barriers to engaging in these behaviors, such as removing access to means or building up alternative strategies. So for cognitive behavioral therapy, we really see a primary focus on identifying distorted cognitions. So often we see this with depression, for instance, the idea that I'm a bad person or things are never going to get better. Really trying to challenge those, as well as changing problematic behaviors. So helping get out of this cycle where, for instance, someone might be engaging in avoidance behaviors, not interacting with others in their social environment, and then feeling even worse because they don't have those social connections. CBT is often a relatively brief treatment. You can do manualized CBT where there's kind of a specific agenda for each session, but a lot of people take these principles and apply them even without a specific manual. But typically they do involve homework or between session practice where youth are asked to, track their thoughts and write them down and challenge the evidence for and against, or track their behaviors and see if they feel better or worse doing something differently. Dialectical behavior therapy is kind of a newer expansion on CBT that includes principles around acceptance and toleration of emotions and mindfulness to the present moment. So this kind of has the strongest evidentiary base for treating non-suicidal self-injury and suicide in youth. The unfortunate part is that what's referred to as full model DBT is very time and resource intensive. It's intended for youth who have quite severe difficulties. It was originally developed for adults with borderline personality disorder and then later adapted for adolescents. And it typically includes a weekly group, weekly individual therapy, phone coaching, and a consultation team for therapists. So that's something that if a child has access to it, great, but oftentimes that's not necessarily available. Family involvement, again, could be standalone or in integration with these other approaches. And oftentimes you're involving the family specifically in safety planning. So identifying a parent or caregiver that the child can go to when they're feeling suicidal, who's going to make sure that the child doesn't have access to potentially dangerous means. And then there's also some research on what's referred to as brief contact interventions, where essentially providers, do pretty minimal reaching out following, say, a hospitalization, where they send a postcard that says, hey, we're hoping you're doing well. Please reach out if you need support. Or even from informal sources. So data from the University of Michigan shows that having youth nominate sources of informal support outside of their families that they can contact, and then training those informal support givers with very brief instructions about how to support that child are associated with decreases in risk. So that's promising interventions. So in terms of means restriction, we've already covered kind of these categories, so I'm not going to go through them again just for the sake of time. But really, this is a component in pretty much all of the interventions that we've talked about before. So rather than going through a specific list of resources or further readings for you, I have a list on my website that includes both web-based trainings, community organizations, national organizations, both for family, caregivers, people who have suffered a loss due to suicide, as well as people who themselves are struggling with non-suicidal self-injury or suicidal behaviors. So there's a lot of really great, well-reviewed resources on there. None of them are mine, so I'm not trying to talk up my own work, just that this is a compilation of a lot of really great resources from like the American Foundation for Suicide Prevention, the International Society for the Study of Self-Injury, things like that. I also wanted to put up my contact information, including my broader website, which has publications and more information about the research that we do in my lab, as well as a way to contact me if you have follow-up questions, to set up a time to talk. I've also got a list of references here, which I believe will also be distributed to you as a part of the conference itself, so you don't need to write them down right at this second. And then I wanted to make sure that we left enough time for questions. Thank you so much.
Thank you so much, Dr. Victor. I do have a couple of questions. One thing is we have seen a significant increase in suicidal ideations or attempts in the younger children, 7 years of age, 9 years of age. So are there reasons, just because I had not seen it in that young before, are there reasons different than the ones that you discussed earlier, or why would all of a sudden that happen in younger children?
That's a really good question, and I know that the data certainly have shown that the rise in preteen and younger children has been much more dramatic than the rise in adolescents. There's a lot of different kind of hypotheses about why that is. Is it social media? Is it learning about this from other kids? And I don't think we have enough data yet to fully say this is the cause. One thing I think may be happening is as we have more conversations about mental health, younger and younger, we may be hearing more about kids struggling this way, not because there necessarily are more of them, but because we didn't know about them before, right? If we think about, a kid growing up where mental health is not a part of the conversation, that kid's probably a lot less likely to go to a parent or a teacher and say, hey, I'm struggling with thoughts of suicide. And so one of the challenges we face is as we talk more about these things, kids hear more about it, they come forward with their experiences, and it looks like, oh gosh, are we giving these kids ideas? But what actually might be happening is those kids were struggling before and we just didn't know it, right? And so I think there's a lot of work in this area. It's probably too early to tell exactly what's happening, but you're right. It is certainly what we're seeing in terms of hospital, ER attendances and things like that, is we're seeing much more reporting of it in younger kids.
Thank you. We also, go ahead.
Well, I just had a question. I was going to ask you before I had this written down as a question about your little assessment, the pocket card.
Sure.
I was going to ask if we could share that with everyone, but then you kind of left me at the end. Is it okay if we share your presentation?
Yes, of course. Okay. Yep.
That was one of my questions, because I know that will come up because there was such great information in there. And we service such a large area for smaller hospitals. They usually transfer patients into either UMC or here at Covenant Children's. And I'm just curious, these smaller towns, is it more likely that children in these smaller areas are going to receive treatment like virtual? Is that an option? Traveling seems a little difficult to do to come all the way back into Lubbock for treatment, but would that be an option for them?
Yes, so that's a great question. I'm so glad you asked. So actually, I know that TTUHSC's psychiatry department actually just recently got a quite a large federal, I can't remember if it was federal or state, I think it's federal distributed through the state grant specifically to try to increase services for child psychiatry in our region. Because you're right, Lubbock itself is about 300,000 people, but the catchment area for Covenant and UMC serves like, I think around 600,000 people. It's something like probably more now because of all those regions around us. And yes, if you have a youth that's struggling and you say, well, this kiddo needs weekly psychotherapy, and you've got to drive 3 hours into Lubbock every week and 3 hours home, you know, that's, if you've got other children, you've got to work, like that's a huge barrier. And so at least as of right now, a lot of the regulations around telehealth have been relaxed a little bit because of COVID. And so our hope among the folks that I talk to who do primarily clinical work is that now that we've seen that this is feasible, it's feasible to do telehealth, it seems to work just as well as in person for psychology and psychiatry, that we can hopefully keep those portals to care open, because it's so different. You know, if your kid has a rash, they might need to actually physically see a doctor, have someone actually look at it and touch it and take a test. But for psychology and psychiatry, the information we need, you don't need to be in the same room, you know? So there is, I think, some planned expansion to try to improve that access. Now, one of the challenges, if you're coming from a particularly rural area, is access to internet that allows you to do that virtual, you know, to have a video up. But I still think it's better probably than it was 3-4 years ago in terms of doctors knowing how to use those systems and being willing to do it. So that's my hope, at least.
You discussed the PTSD. What is the youngest age that you've seen PTSD in, or how young is that typically affect them?
That's a good question. So I believe that technically, according to the DSM, the Diagnostic and Statistical Manual, I think you could diagnose it as early as 6. I typically work with adolescents and adults, so I don't typically see kiddos 6, 7, 8. But I think the presentation, you would just expect to see maybe more of the physical symptoms and a little less of kind of the cognitive symptoms. Like when we talk to adults with PTSD, we often are assessing, you know, what are your beliefs about the cause of the trauma, your beliefs about the impact of the trauma. You could have more of those conversations. Whereas in kiddos, they may not be at a place where they can describe, well, because this happened, I feel like the world is unsafe. They might be a little bit better at saying, well, I'm just angry all the time, or my stomach hurts all the time, or I can't sleep, right? And so you might need to be a little bit more attuned to some of those experiences that are just easier for younger kids to report.
Presenting for us. We are getting ready to do a panel discussion again. We will have 2 members in this panel. The first one is Trey Mayer. He attended Texas Tech and is a certified Texas paramedic in addition to being a licensed master police officer. Mr. Mayer worked as a paramedic and flight paramedic for 25 years, has worked for the Lubbock Police Department for the last 18 years. He has served in many roles in the police department, including working in juvenile investigations, sexual assault, domestic violence, and the homicide units. He will be one of 2 panel members. They will be discussing human and sex trafficking and social media investigations and prosecution. Our other member is Davila Shongeldeb. And Special Agent Davila attended Texas State University and is a licensed master peace officer. She has worked with the Texas Department of Public Safety since 2005, serving in many roles. Her roles included crisis negotiations, narcotics, sex offender compliance, human trafficking investigations. She also serves on the the sex trafficking Allied Response Team. She currently serves as a special agent in computer IT and electronic crimes in the Criminal Investigations Division of DPS. Special Agent Davila will be one of 2 panel members with Trey that we'll be discussing, as we said, human sex trafficking and then the social media investigations and prosecution.
Hi, good afternoon. Thank you for the introduction. Again, my name is Davis Shongeldeb, and I'm with Texas DPS. A little bit about myself. I started in the department in 2001 in communications, then went into highway patrol, and in 2010, I started working in narcotics. In El Paso, Texas, in about 2011, I started working human trafficking and crimes against children. And I still work investigations that entail those types of crimes. Real quickly, I just want to kind of discuss some of the PowerPoint that I have that I'll be presenting today will contain some sexual content, some slang terms, inappropriate language on some of the slides, and then we'll get into, why all those things are important and how they relate to these types of investigations. And then towards the end, I'll share a case study of a juvenile sex trafficking investigation that I worked. All right, human trafficking, a lot of times people will get trafficking confused with smuggling. And the difference between trafficking and smuggling is a crime that's committed against the country where people illegally come into the United States, whereas trafficking, you can have trafficking that occurs within the United States with United States citizens. Now, you might have a smuggling incident where someone is smuggled into the United States and is also trafficked. And so those investigations do happen and do occur, but there is a difference between the two. People often ask, especially in the Lubbock area, is trafficking really a big deal? Do we have a lot of trafficking here? And my answer to that is always yes. We do have familial trafficking, and we'll go into that a little bit in detail as far as what the difference is in familial trafficking versus organized trafficking. And some of those cases meet the threshold and the definition for human trafficking, but they're filed under different arrest titles. So some of the crimes that you'll see when it relates to human trafficking for adults is prostitution, promotion of prostitution, aggravated promotion of prostitution, compelling prostitution. And the definition just says that you have to engage in this and through the use of force, fraud, or coercion. And when we talk about juvenile trafficking, you don't have to prove force, fraud, or coercion. Obviously, children can't consent to sexual activity, so any type of sexual abuse, force, fraud, and coercion is not required to be proven. And then here are some of the arrest titles that fall under that statute as well. And that would be with children, continuous sexual abuse of a child, indecency with a child, sexual assault, aggravated sexual assault, prostitution, promotion of prostitution, aggravated promotion of prostitution, compelling sexual performance by child, employment harmful to children, and possession or promotion of child pornography. So why do people engage in human trafficking? And the number one thing is just that it's a lucrative business and there's a reusable commodity. Let's say, for instance, if you are selling narcotics or in the drug, in the drug circle, and you're out there on the street and you're selling marijuana, cocaine, methamphetamine, when you sell that commodity and you collect that money, you have to go, what we say in slang terms is re-up. So you have to go get more product so that you can push that product back out on the streets and sell that. When it comes to sex trafficking or labor trafficking, once you own or take possession of or you're controlling a person, that's a reusable commodity. So you don't have to sell that person and then go find another person to start selling. You just resell that person and use that person over and over and over again. Unfortunately, the demand for commercial sex is always there. You'll hear people say things like, oh, it's just prostitution. Prostitution is the oldest job in the world. But the reality is that these girls and victims and children that we work with and that we deal with, they are forced into this lifestyle for various reasons, and we'll go into that as well. A lot of times it's hard to detect whether or not a child is involved in the trafficking industry, be it labor trafficking or sex trafficking. And we're working hard to combat that and to train our law enforcement officers to conduct roadside interviews, even on routine traffic stops. If they see children in the car, we're getting better about talking to kids and asking them, how are things going? Who are the people in the vehicle with you? And training our officers and detectives in all facets of law enforcement to learn how to talk to children and to identify and pick up on any of these signs or items of interest to further an investigation that could potentially lead to the recovery of a juvenile victim or an adult victim for that matter. There's a large lack of cooperation from victims, and in one of the investigations that I share with you guys, a case study, I'll explain in more detail how law enforcement presence with these victims is sometimes very difficult to gain trust and build a rapport so that you can get victims to make that outcry and to trust law enforcement and to tell us exactly what's going on and to trust that we're going to actually help them. So I'll explain some of the roadblocks to that too. The victims that we deal with, especially in juvenile trafficking, they're super easy to target, recruit, and grooming. And I'll say that with COVID, people not being in school and being stuck at home and the use of electronics and technology has been super easy for these children to be enticed, to be recruited, and to be targeted. Loneliness is a huge factor in some of these children getting involved in the trafficking trade. And with COVID and being, in solidarity and being stuck at home, it's easier sometimes for these guys and girls that prey on and recruit these children to gain access and to recruit through those methods. All right, victims don't always look and act like victims. When we used to think of trafficking back in the day, you would think of you would see images on campaigns back in the day where there would be a child that was chained to a radiator in a basement and being starved and deprived of basic necessities and being controlled in that manner. Now, sometimes trafficking looks totally different. You might have an adult or a child that seems to have it all. Their life looks put together. They have access to everything. They come from a prominent family with money, and really there's things taking place in the background that you might not ever know or realize is going on. And so we'll talk about how you might be able to identify some of those victims that don't necessarily look or act like stereotypical victims. And then there's also the lack of prosecution or the hurdles involved in prosecution. I like to compare the laws related to especially adult trafficking to our former laws that related to domestic violence. So back in the day, of course, laws have changed and changed for the better since, time has moved on. But there were times in domestic violence where if the person being violated in that crime could choose not to press charges, and there's that manipulation and that cycle abuse would continue. And so you would always hear and see, oh, the law enforcement officers are going to this house again where so-and-so is being abused by her husband or boyfriend or whatever. And then they would be right back there the next day because charges were never filed. And then eventually the state was able to take on those charges where we could say as peace officers, look, if it looks like a duck, it quacks like a duck, we know it's a duck, we can file those charges. And whether or not the victim who's terrified and scared and afraid to press charges wants to, the state will take those charges on and we'll move forward with prosecution. In trafficking, unfortunately, we're still kind of stuck in some legal hurdles where we have to prove the force, fraud, or coercion. And that can be very difficult if you have a victim that is so controlled by her pimp or her facilitator or whomever is involved in that circle of trafficking. If there's someone that's terrified or scared or worried and they're not likely to, cooperate with law enforcement, then it's going to be very difficult to seek prosecution. It doesn't really look good, especially when you have an adult victim on a stand and they're saying, oh no, I wasn't being forced into prostitution. I was doing that because I wanted to, and this is just my boyfriend or my friend or whatever. So even though we understand and know what the signs are and what's going on, and we have the evidence to prove it, we still have to combat some of those hurdles where our victims, if they aren't, continuing to show an outcry and say that they are victims, it could hurt our prosecution. The lack of law enforcement also working and combating human trafficking is a difficult thing. We have law enforcement agencies all across the nation that are struggling with manpower. Just in Texas alone, we've got a lot of efforts focused to the border, dealing with border security. We've got retirements, and so many agencies are severely understaffed. And so you've got lack of training and you've got lack of manpower that also makes it difficult to combat human trafficking. And then there's the old school mentality of, well, that stuff just isn't happening here. And that is unfortunately something that we hear a lot in Lubbock, especially in the Bible Belt areas. No, that doesn't happen here. And the thing is, it happens here. It is prevalent here. It's not talked about as much, or like I said, maybe instead of a trafficking charge, the people involved are being, arrested on offenses of, continuous sexual assault of a child versus sex trafficking of a child. So sometimes it's mislabeled, but I guarantee it is happening here. And we're doing our best to try and work that. And then the last thing is money. There's obviously money involved in this. There's money to be made. And so you'll see how that makes it difficult for us. Labor trafficking, same, you've got force, fraud, or coercion. Obviously, the difference is instead of being thrown into the sex trade, these victims are used for all different kinds of work. So you have the farming, ranching industries, oil field restaurants are prevalent, nail salons, massage parlors, textile clothing and laundry services, cleaning and motel type services, domestic helpers and nannies, door-to-door sales, and even narcotics, packaging, cooking, and distribution. In some areas, people are forced into labor trafficking. And the cycle of that is hard to break, because if you have labor trafficking, especially people that come from, let's say, other countries into the United States and they're forced into labor trafficking, you might have someone, for instance, that's told, hey, we're going to take you to the United States. There's a lot of employment opportunities there. You can send money back home to help your family. And that man, female, or child that comes to the United States comes here with the hopes and ambitions of being involved in a, lucrative business where they can make money. They gain, or they have trust that the people that they're working with or going into the United States with is going to provide them with shelter and food and clothing and help them kind of get going. And what ends up happening is once they get to where they're promised to be, they get turned into whatever labor trafficking they're made to work. Sometimes their documents are taken from them, their clothing, whatever ways they use to control, they do that. But the clock starts ticking from the moment they cross into the United States, and then they're charged with, you owe us this much money just for crossing into the United States. You owe us this much money for food, shelter, clothing, the basic necessities. And it becomes such a big thing that they can never repay that debt. So they're kind of stuck, and they're having to work off a debt that ultimately could never be repaid. And then they're fed and brainwashed with a lot of lies about, well, you can't run off because you'll get deported. If you're deported, we know who your family is back home. They're in danger. There's threats made against their lives. And ultimately, the worry about being deported and sent back home, and it's just unfathomable for some of these people. And then they're told not to trust law enforcement. So that makes it super difficult for us to work, because they don't want to talk. They're reluctant to talk. And so it makes our investigations difficult to work. Okay, you have your organized trafficking on both the sex and labor sides. You've got cartels that are managing labor trafficking. We've worked investigations that, cartels have been involved with trafficking both adults and children for the purpose of labor. And then you also have your sex trafficking. Not all sex trafficking and not all labor trafficking is managed or run by gangs. And one of the cases, the case study that I'll share with you guys later, is not gang affiliated. You'll see how anyone can be a trafficker and how that works. But in a lot of areas, and especially when I was working in the El Paso area, we did see a lot of commercial sex trafficking that was being organized and managed by gangs. Let's see. California did a study in 2016 where they studied facilitators, people that had been charged with pimping or trafficking. And from the stats that they pulled from that study, they learned that out of 72 gang members, 34 of them identified themselves as facilitators or pimps, and the others did not acknowledge that they were pimps at all. 25 reported that pimping was purely entrepreneurial. So basically they were saying, yes, they're gang members, but they were just doing this as like a side hustle and not at the direction of the gang. and 29 reported that it was operationed, taxed, and or organized by their gang. So whether they're trying to protect the gang or trying to avoid an organized criminal activity charge or whatnot, some did admit openly that they were being directed and managed by the gang, and the others were saying that no, it was just kind of like a side hustle for them. All right, coerciveness. There's three most common types of coercion that have been reported in the study that was conducted in California. Economic coercion, of course, was the highest. It was defined by a high percentage of earnings. 50% above was taken by the facilitator. I would say that 50% is extremely low. The cases that I've worked personally, I've never seen a victim of trafficking be able to walk away with any of the money that they earned while being trafficked. 100% was always turned over to their facilitator, their pimp, whoever was controlling them. And if they were lucky, they might get fed that night, or they might get money for what they would call routine maintenance, getting their nails done or hygiene products or things like that. But for the most part, 100% of all their earnings was expected to be given to their trafficker at the end of each night or at the end of each service provided to whatever services they were involved in, be it labor trafficking or sex trafficking. Psychological coercion was next at 57%, and it was defined as social and emotional isolation, induced emotional exhaustion, degradation, including humiliation, denial of victim's power, and name calling. And you'll see on some other slides here where some of these facilitators were interviewed, and they talk about how easy it was to manipulate women and juveniles and the language that they used to kind of control these girls and these victims. Chemical coercion, we're seeing less and less of that, although it is prominent. Sometimes there are rules in place of what drugs and narcotics these victims are allowed to have. Obviously, if you have an addict that's being trafficked at your direction, they're not going to make as much money for you because they're probably going to try and steal and save money or put money aside to continue to chase that high. They're going to be wanting that money to stay high or to stay dependent on whatever drug or narcotic of their choices that they're using. So chemical coercion is lower, I would say, in most of the cases that I've worked, or in some cases that I've seen, there are rules in place. One particular investigation I worked, the trafficker had anywhere from 25 to 30 women in his stable. And when I say stable, that's a slang term used for the number of trafficking victims that he housed at any given time. And his rules were that you could use marijuana, but nothing else. If you were using anything else, you were fired. And fired wasn't just a term like, oh, you can't work for me anymore. Fired meant you usually got beat up, you got sold to another pimp, and things were usually exponentially more difficult and harder for that person if they had a different pimp that, was more aggressive, so to speak, than this current pimp. But yeah, some of them do have rules, and all of it comes down to, at the end of the day, is bottom line and how much money these trafficked victims can earn for their facilitator. Like all stats, most of these are underreported, and that's just because not a lot of people will come forward and admit that they're victims or seek help on their own. The average age of entry from this study in 2016 was 16. I can tell you, just based solely on investigations that I've worked, that the youngest person that I interviewed as a sex trafficking victim was turned out by her own mother at the age of 11. And since then, 11, 12, 13, I've seen that more and more. So 16, again, these stats are skewed based on reporting. We don't always get, the best data when we do studies, but 16, I believe, is kind of on the high end, just from personal experience and investigations I've worked where girls were, introduced to the sex trafficking trade as young as 11 years old, in my experience. Common recruitment locations include homeless shelters, foster care systems, schools, bus stations, fast food locations, shopping malls, social media. The case that I'm going to talk about here in a little bit, the facilitation for that pimp to meet up with and recruit girls took place across the street from a high school that had an open campus lunch. So his targeting occurred during lunch hours, just right across the street from a high school campus. Social media, we see that more and more and more. Kids are on devices. Technology is one of our biggest threats in combating crimes against children, especially trafficking. Everyone's got Twitter, Snapchat, Facebook, and every time one goes down, another one pops up, and it seems like there's just exponentially more and more social media platforms and applications that kids know all about and they share with their friends. And just like they're involved with these applications and learning how to use them, those that are targeting them are learning about how to use these as well. And so those can be super dangerous, and there are ways for parents and adults to try and safeguard our children against that. Pop culture has desensitized trafficking. You can go back and you can think about what does a stereotypical pimp look like. At Halloween, people glamorize the pimp life, the pimp cup, the pimp culture. You'll see people dress like pimps, the music, the rap videos. They glorify and, just make it so common and normal and funny, and sexualizing exposure is just kind of the norm these days. If you look at television and explicit lyrics and movies and what it takes to be rated X and rated R these days, it's just America as a whole culturally has become more and more desensitized to that culture. And of course, the trafficking lifestyle has been glamorized, hyped up, praised, and accepted. So you'll have kids that talk about how that's their goal and their dream. When they grow up, they want to be involved in making stacks and popping bands and all the things that they hear about in school, like bands, rubber bands around cash, all of the things, the slang terms that they talk about. And it's just praised and accepted. And so that's one of the things that we have to keep in mind, especially when we do outreach programs at schools, is making sure that our target audience understands that, yeah, it looks nice and glamorized and cool on TV and online and in music videos, but there's more to that lifestyle than meets the eye. And here's some of the things that you don't learn about until it's too late and you're trapped in that lifestyle. And it also helps for us to have victims that have gotten out of the life, that have been there, done that are able to go in and talk and do outreach programs with us to kind of help combat. They can say, hey, I've been where you are. I thought that lifestyle was amazing. That's what I wanted to do. I was going to make money, have a fancy car, do all these things. And then they share their personal testimony, and it helps us to either save victims that are currently involved and maybe even deter other students or children that are thinking about trying to chase that lifestyle. So identifying and profiling traffickers, again, facilitators can come from all walks of life. You can have familial trafficking where a parent, a guardian can be the person that's involved or in charge of, the trafficking in that home or whatnot. Cartels, gangs, including but not limited to Bloods and Crip sets. Refugee settlement cities have cases involving Somali Crip sets. So there's all different traffickers out there. It's not always going to be the pimp that you see on the music videos. It's not always someone that you can identify. And just like it's difficult to identify a victim of a sex trafficking investigation, it can also be very difficult to identify someone who's a facilitator or a trafficker, because those people do tend to implant themselves in communities and try and carry on a persona or live a different lifestyle or have kind of Jekyll and Hyde personalities. So just like a victim can be anyone, a trafficker can also be anyone. There's different labels assigned to some of these traffickers. You have people these days that refuse to be called a pimp, and they refer to themselves as protectors. We will often recover juvenile or adult victims of sex trafficking when we do prostitution operations. And sometimes the facilitator will be there with them, and they'll say that they're not pimps, that they're just there because they care about the person that they're with. They're providing transportation or protection, or they're just there as friends. So sometimes we'll hear things like that where we actually know what's going on, and through the use of cell phone search warrants and digital evidence, we can prove that those persons are actually involved in either the facilitation of those dates being set up or they are controlling the money. All right, you have the OG pimps that like being called pimps also. And then we have different terms that we use when we talk about pimps. You'll hear non-government officials or like your victim services outreach people will refer to pimps sometimes as your guerrilla pimps or your finesse pimps. Guerrilla pimps are going to be the facilitators that use more force to control their victims. And then you have your finesse pimps are the ones that are more like your Romeo pimps. They will tell these victims that they love them. They will fill them with kindness and make them feel special. And a lot of times that's all it takes to control some of these girls because they've never felt loved or they've come from a situation where maybe the previous pimp or facilitator that they were working under the direction was beating them all the time. And so you'll see both sides of that. And then sometimes there are those that kind of go back and forth between the two, and they are really skilled in mental games and brainwashing and controlling their victims that way. All right, again, familial facilitators, those are going to be parents. You know, there's a quote during an interview during that 2016 study in California, and somebody had said, I've seen someone selling their daughter. I don't know if you'd consider it prostitution. She's a dope head, so she let somebody F her 9-year-old daughter because she wanted dope. So the victim that I talked about earlier that we recovered in an adult trafficking investigation, she was sold by her mother at age 11 because her mom had a narcotics addiction. So this is very common. And so the facilitator in this situation was a family member. So we would consider that familial trafficking at that point. I'm gonna kind of skip ahead. I don't want to run out of time. Slang and street terms. I know in the medical world, just like in law enforcement, sometimes just spending any amount of time with victims, hearing them talk, just trying to understand some of the vocabulary that's being used can be very beneficial to identifying what kind of lifestyle these people are involved in. Urban Dictionary has been my friend in my career. I learn new words every day, and it seems like every day I learn a new word, something else is made up and becomes whatever it is. There are tons of key terms for different slang and street, definitions. So here's a couple. I won't go through all of them, but if you are talking to someone and you're interviewing them and they say something like, I was walking the blade and this happened, and, or someone's injured and they come into a hospital and they slip up because they're so used to using certain terms with their friends and with, their pimps or facilitators or whatever, they might use those same words in a hospital setting or in an ER or whatever. So if they say something and you might not understand what that term is, seek clarification. Ask them, well, what do you mean you were walking the blade? What does the blade mean to you? If they backpedal and say, oh no, what I meant to say was whatever, take note of that, because you can go to Urban Dictionary, you can look up, well, what is the blade? The blade is walking the streets and selling yourself for commercial sex. So if you can look those things up on the side and keep note of that, that helps tremendously in providing the healthcare that they need and seeing, what kind of lifestyle they're involved in, but it also would help law enforcement and NGOs in getting them the aftercare that they need if they're choosing to get out of that life or to get them out of that situation. There's so many. If you have victims that come into a hospital setting or seek medical care and they refer to their daddy or Mac, or if you see tattoos or insignia on these women that is Mac or daddy's girl, things like that, pay close attention to that, because if you are involved in a commercial sex trade as a trafficking victim and you're working for a pimp or even a street gang, they treat you like property. You belong to that gang, you belong to that pimp, and it's very common for these girls to be branded and marked by their pimps, for one, so other people know that they belong to someone else. They're going to try not to step on someone else's turf. It also does a lot emotionally and mentally to the victim to have a brand or a tattoo on them. It's degrading, and every time they look in the mirror, they remember they don't belong to themselves. They belong to the gang, they belong to their pimp. So pay close attention to that, and you know, just different things like macaroni. Is there a tattoo of macaroni on someone? Well, is that funny? Do they really love macaroni and cheese? Or do you think that's just a cute, clever way that their pimp is trying to label and brand them without bringing attention, like some of the older tattoos that they might have used? If you have a group of girls come in and they all have the same tattoo, again, that's also indicative sometimes of girls being in the same stable, or what they might refer to each other as sisters or sister wives, but they're possibly under the same control of the same trafficking organization. Renegade is one term that I like to discuss. When you have girls that have been in the game for a long time and they start to age out, they're not as attractive, or they start to have substance abuse problems or whatever, or if they're just not profitable anymore and they get kicked out on the street, they're on their own, they might actually start trafficking themselves just to get by, and they may refer to themselves as a renegade. For the most part, you're not going to see a lot of true renegades, but you might have someone that says they're a renegade just because they don't want to bring any shame or attention to their trafficker, and that's what they're trained to do. They're trained to deflect all attention away from the organization and those that are controlling them for the sake of keeping their family safe. And okay. Identifying victims. Statistically, females are the most common victims of sex trafficking, although male victims have also been identified. Average range of trafficking victims in the United States, again, this was in 2016, was ages 13 to 25. Studies nationwide revealed that 89% of trafficking victims were over 14 in age, 90% were female. All juvenile sex trafficking victims recovered in 2016 were identified as being citizens. Now, I think, again, a lot of these stats are skewed because of the lack of reporting. And if you did have non-citizens that were recovered, a lot of times they wouldn't disclose or even talk about any kind of victimization. They were more worried about naturalization or citizenship status. And so, again, stats are skewed because of lack of reporting or disclosure. 60% are runaways, and that's very important to note because when you have someone that's a runaway, they're definitely higher risk for being sucked into that world and being recruited. If you have a runaway that's not being looked for, that's even better because nobody's looking for them. It's a lot easier to gain control and access to a runaway. And just by offering food, water, and shelter, sometimes these traffickers are able to gain access and control very quickly and early on. So pay attention to runaways. And it's also important to find out if you are dealing with a runaway on the medical side or even in law enforcement is why someone is running. There's usually two reasons why people run away. They're either running to something or they're running from something. So we've seen trafficking victims that run away from abuse in the home. Maybe they've been routinely sexually assaulted in the home or in their home environment. Lack of supervision in the home is a big deal. Broken families, single parent homes, or parents with narcotics or alcohol dependencies or any kind of abuse. So running away from that situation sometimes into trafficking, they think, well, they have more control over what's going on in their life and it's not as bad as what they're running from. And then those that are running to trafficking, those are the ones that we see a lot of times that really don't have any problems at home, or maybe they do, but they're minimal, but they've met someone online or through social media that has swooed them and wooed them and convinced them that the grass is greener on the other side and they're running to love or running to whatever. And it all has to do with online manipulation and gaining access or control of that child before they decide to run away. 36% had criminal records. 84% of sexual exploited victims were more likely to disclose past abuse by family members or friends. Again, we hear this over and over and over from those that were abused in the home. A lot of them turned to sex trafficking because they thought they could take back some control of their body. When they were being abused in the home, it was sporadic and they had no idea when it would happen. If a family member or family friend or someone that had access to them would show up unannounced or in the middle of the night and they would be violated. That was super intrusive anyways, but they look at going into the commercial sex trade and saying that, well, yes, I'm involved in prostitution, but at least now I'm getting paid for it, or at least now I can choose who I see as far as John's, or I can set my own schedule and hours. So they try to, make it more acceptable, and their whole thought process is that they're kind of taking a little bit of control over their body that they wouldn't have normally had from whatever situation they were running from. These statements are from interviewed subjects from the study. These guys were in prison for trafficking victims. One of them said girls are very vulnerable and they're very weak-minded. You can crash somebody's dreams down, and you can do it to a girl very quickly and very fast. You know, in the pimping game, you never compliment your hoe. You don't want her to think too fine of herself. You know, you want to tell her shit like, go clean your effing face when nothing is on her face. You know what I'm saying? You want her to make her feel like she has to prove herself to you. You don't want to ever stop, because once she starts to feel like she's proved herself to you, she doesn't respect you anymore. Now she's moving on to the next pimp. Another pimp stated that the best pimps are the ones that you don't even know exist. The girl feels comfort in that. Most time the girls don't need the guys just need her comfort zone to feel loved, to feel like you're her dad or a bodyguard. However you feel, you know that you're the protector and you know what's going on. If the money keeps rolling in, everything's smooth, no one gets hurt. People are happy both ways. The girls are happy, the guy's obviously happy, and the metaphor pimp is happy, so he can control the business to make money in other ways as well. So here's just two examples from the mouths of pimps on how they were able to control the girls in their brothel or their stable. And one, of course, was obviously using derogatory remarks and beating down mentally and emotionally his victims, where the other was more of a finesse or a Romeo pimp, and he knew how to kind of appease and build up the emotional needs of the victims to gain their trust and rapport. Resources and education and community cooperation are the best tools that we have to combat trafficking. Our outreach programs, resources and handouts, early education on trafficking, what it looks like and how to combat it, online resources, resources through churches, schools, and government, what we're doing today, awareness and prevention, proactive policing, interdiction. Again, we've done really good at realizing that there was a lack of interdiction training for law enforcement. We are really good at going out there and looking for drugs, money, drunk drivers. But we realized that there was a necessity and a need to look for victims on traffic stops. And so the mentality of that has changed exponentially, and training is being provided nationwide, globally, for law enforcement officers, just simply to take more time out of their daily routines on standard traffic stops and just communicate with everyone in the vehicle and to try and identify any victims of these types of crimes. Public awareness and media, and then of course, prosecution and punishment. The more prosecution and punishment we have, the better the deterrent is. I'll skip that one. Here's my information. If you want to jot down my phone number or email, I'm very good to reply to emails or phone calls. If I don't answer right away, leave a message, I will call back. If you have any questions, or if you ever have any tips or feel like someone may or may not be involved in something and you just have questions, you can call or email me at any time, and I'll provide you with whatever assistance or point you in the right direction. And I can pull that back up here in a little bit if I need to. So the other PowerPoint that I wanted to share with you guys was an investigation that I worked in El Paso, Texas. And this entire investigation involved juvenile trafficking victims. And it started in July of 2013. I was helping the FBI with a cross-country operation. It was a multi-agency undercover operation that was used to locate and recover victims of human trafficking. We conducted the operation, we made multiple arrests, and we got some tips about a trafficker that was only known as Swan. Several girls that were not related to each other in any way were talking about word on the street about a guy that was trafficking juveniles. And a lot of them kept saying, oh, well, he finds them at high school. So myself and another FBI agent just started going from high school to high school in the El Paso area. There are a lot of high schools in El Paso. And we just went from school to school to school, and we did outreach programs. We sat down with principals, superintendents, coaches, counselors, teachers, whoever would be in attendance, and we would talk about classic victimology. And what we would talk about with the students was, you know, sometimes, and unfortunately, teachers and people in school settings would see these children often more than their own parents would. And so teachers would see day to day the kids in their class, and they would notice any changes or, behavioral differences. And so we talked about a student that may or may not be involved in sex trafficking. Like, have you noticed that someone that's on free lunches all of a sudden wearing expensive clothing, carrying Louis Vuitton purses to school, or expensive clothing, expensive accessories, getting their nails done? Because women know getting your nails done is not very cheap, especially if you're in high school. Who's paying for that? Being truant, missing school, sleeping all day because they're up all night. So just a bunch of different things. We went through a list and, giving the teachers and the staff the power to say, hey, sometimes getting answers to tough questions is asking the tough questions. So we did this outreach to all the different schools, and we received a phone call one day after an interview that we had done, or an outreach program that we had done. And a counselor had called and said, the whole time y'all were talking, I was thinking about a girl that's come in for counseling in the past. And just over the last 3 months, I've noticed significant changes in her grades dropping, truancy, sleeping, the way that she's dressing, more sexualized, more provocative clothing. Her language has changed, her behavior has changed. And she comes from poverty, single parent home. Yet all of a sudden she's got all this money. She's eating off campus when she's been on free lunches, and all of a sudden she's able to afford to eat off campus with her friends. So we ended up conducting an interview with her. That girl was 14 or 15 years old at the time, and she did end up outcrying that she was being sex trafficked by a trafficker known to her only as Swan. This is the trafficker. His name is Adam Deswan Guzman. And when I talked earlier about facilitators and pimps, this guy is not in any way affiliated with any criminal street gang. If he had discovered Amway, he probably would have been like the top of the pyramid, multi-gazillionaire, because he was very skilled in manipulation and controlling and doing all of those things. But Guzman started out in the theft world, and what he did was he would steal things and then turn and sell them on Craigslist. And then he started recruiting kids to do that for him. And then he realized, well, I can make more money using these kids to do other things. And so what he might pay a kid $20 to go steal a KitchenAid mixer at the mall and then sell it for $200 or $150 on Craigslist, he learned very quickly that if he could get these girls to model lingerie, he could sell that over and over and over and over and over. Again, a reusable commodity. If you steal something, you can only sell it once, just like narcotics. But if you have control of a person, you can sell them over and over and over. If you can take photos of these girls, you can sell them over and over and over. And that's exactly what Swan did. He started with recruiting girls for theft, and then, once he kind of built some rapport and trust with them and they thought he was cool, he would then say, well, if you really want to make more money, you can do this, but I don't know if you're ready for that. I don't know if you can handle that. And my first victim that we recovered, that's the situation that she was in. Her mom was struggling, working 3 jobs, just trying to make ends meet. She had a sister that took her own life. I believe she was a product of sexual assault in the home. And then she had a sibling that was in the process of being transgender and trying to change her gender from female to male. And so there's all these things going on in the home. And although she denied ever being sexually abused by, members of the family, we believe that, her sister definitely was, and possibly her brother too. But all of this started with, she had a friend that was making money. She asked her friend, how are you making money? My mom can't afford to keep the lights on at the house. The utility bill came. We're about to lose our electricity. And so she started selling pirated DVDs for Swan. And then she started stealing KitchenAid mixers and whatever from the mall. And then eventually she was graduated into the sex trafficking world. And this picture here is the actual advertisement that we recovered. Backpage.com has since been shut down by the federal government. And although people look at that as a success, it really did hurt us in law enforcement, because we had already started getting used to the legal process with getting search warrant returns from Backpage. And once Backpage was gone, now we have all these other sites that popped up in its place with servers that are overseas and not being controlled by the United States, very difficult to work. So, but very similar to these, this is what an ad looked like, and you can still find ads similar to this on different sites. And this is how girls are advertising commercial sex these days. It's not like Pretty Woman where you walk down the street in the red light district and the girls are just out there passing out business cards or leaning into your window, and then they drive off and go have sex and get paid and then get dropped back off. But this is more of what the advertising looks like for sex trafficking. As you can see in this advertisement, Swan had given her a name, Ruby. Obviously, Ruby wasn't her name. He had a thing about gems, so he had, Ruby and Emerald, and he would give nicknames to all of his girls, and he would purchase lingerie for them, take pictures, would sell the pictures, but then he would use the pictures to advertise these girls. And we had been doing back page investigations for so long that we would go in and we would print pictures of girls that we thought might be underage or close to underage. And while we were interviewing this girl and she gave her outcry, when she started talking about the lingerie and what the bedding looked like, we were able to go through our files and find this picture and identify her based on the bedding in the background and the lingerie that she was wearing. He posted that she was 26 years old and she was 15 in this photo here. But you can even see, even in this photo, it's hard to tell if she's a juvenile or an adult, but she was 16 in this photo here. After interviewing her and getting very, very good information from her, even though she never knew the true name of her trafficker, she just knew him as Swan, based on her memory and recollection and being able to drive us around and share with us about other girls. We were able to identify 6 victims total that were already trafficked by him. We had additional victims that were being groomed in the grooming phase that had not yet been sexually assaulted by him or turned out to be assaulted by others, but they were in that, gradual grooming phase where he had control of them and was prepping them for that lifestyle. Ultimately, Swan was arrested on state charges and federal charges of sex trafficking. We did identify one of our victims, John's. There were many, but there was one that she was able to give us very good details on. And with search warrants, we were able to prove that he did in fact commit sexual assault of a child. And we arrested him in 2014, and he was indicted on sexual assault of a child. And then we came to find out that not only was he a John and we were able to prove the sexual assault charges, but he worked with adolescent kids at one of the school districts in like an ROTC program. So he was implanted in a position where he worked with at-risk youth, and there's no telling what he had done or could have done had we not identified him through the use of that victim that we had. So that's just one example of, how juvenile sex trafficking can happen and how prevalent it is. And it doesn't always have to be a gang or an organized group of traffickers. It can sometimes just be a person that decides that that's the crime that they want to be involved in that day. And that's all I have.
Great, thank you. We are going to go ahead and take some questions now before we go on to Trey. So we have a couple of questions here. Do you have any, Casey? Okay.
You spoke about the outreach programs a couple of times for schools.
Yes.
Is that primarily for high schools or junior highs? And is it for both the administration and teachers and students, or does it only focus on one of those areas?
Okay, so outreach programs, we do a lot with the National Center for Missing and Exploited Children. And also, believe it or not, the Secret Service has curriculum that they fund financially for us to use. But we have curriculum that's from kindergarten all the way through high school, and we have programs that we can do for teachers, staff, administration, parents. In fact, I'm actually doing one at a church tomorrow on Saturday, and the curriculum is targeted for homeschooling teachers and church staff. So there's all kinds of curriculum and handouts and resources out there. If you go to NCMEC's website, they have different links that you can click on. NetSmarts is really good, and I think it's NET, and then Smarts has a Z at the end, if I'm not mistaken, netsmarts.org, I believe. And they have curriculum and training on there as well. And then Secret Service has some links that you can click on and you can actually download material for that. But there is tons of resources out there. I know in the El Paso area, we had a lot more federal agents that we partnered with, and we would do outreach programs at least once a month. But, you know, those are available. And if there's anyone that's seeking that, I can plug you in with someone who can provide it, or I can maybe do those for you.
Thank you. Next question is, in younger victims, is there a correlation in like the socioeconomic status and trafficking rates? So like data, like homeless versus maybe the more wealthy that have like more access to technology, those type of things?
So your question is there a higher correlation of victims that are more from like poverty stricken areas? I think that, you know, it's easier to say that they're more likely to be victims. But, you know, we look at cases that we've had even in Lubbock County where some of the victims came from very wealthy, well-to-do families, and you might not have ever expected that some of those victims would be victims at all. Poverty is an issue. You know, again, runaways, those demographics do tend to weigh heavily on victimization. But it all kind of depends too on reporting. It's hard to know the accurate number of those, but we do see a lot more in lower socioeconomic neighborhoods and situations.
Thank you. That was what we were wondering. And that, because you talked about that statistic surprised me for sure, but 60% are runaways. So how, you know, you talked about the resources and education. How do you get the resources and the education to runaways, you know, if they're not in school and those type of things?
Right. And see, and that's difficult too. So in order to target runaways, you've got to have a captive audience of runaways, right? So if they're maybe now living in a juvenile facility for repeat truant offenders, or if they're runaways, but they end up in the system, in the foster system. And we do have a lot of foster children that run away, you know, so trying to target them and having counselors and providers and teachers that have, you know, the training and the understanding to give them those resources. But yeah, it's difficult because if they're running away, they're not willing sometimes to sit down and talk with you. And I'm glad that you brought that up too, about going back on the socioeconomics and victimization. You might have a sex trafficking victim that's a juvenile that might have been seen by a doctor, and a doctor or a nurse might have recognized signs of abuse, especially sexual trauma. And if you are in a socioeconomic situation where you can't even afford to go to a doctor, then you don't have doctors looking at you or checking on you. And that's one of the things that we talk to our victims here is, you know, are you forced to work all the time? Do you get days off? What about when you're menstruating and you're on your period? And these girls are like, we work. We put a tampon or toilet paper or whatever they're given up their vaginas, and they're expected to still continue to see some as many as 10 Johns a night while menstruating with, you know, a tampon inserted that entire time. And so they talk about the pain, and I know sane nurses and examiners can, you know, be able to do those examinations and see what kind of trauma that causes physically on the body. But, you know, when you take into account, you know, someone that can't afford to go to doctors or doesn't have access to doctors or medical attention, then that kind of hinders, you know, identifying victims as well.
Very sad cases.
Yes, ma'am.
Okay, so then Trey, we're going to move on to you.
Well, that's a great presentation, and this is one of the few answers that you can say, well, what do we do from this point forward? How do we prevent these type of crimes? And the outreach is just one step. The investigation is another step, but then it's the tail end of this when they do what they do when they've done their time. Now, here recently, sex offenders are on the rise more than anything else. And so it takes an army of people to follow these offenders after the fact. So they've already gone to prison. So how do they become a sex offender? Well, they have to have already committed one of the crimes that involves sex, obviously. So you have all your sexual assaults, your aggravated sexual assaults, burglary with intent to commit sexual assault, anything under the sun that falls into human trafficking now. after this last legislative update, you become a sex offender. And I think that is the biggest push that was seen in sex offender regulatory rate in a long time. And so that's within the last 5 years. Possession of child pornography, that's your other one, because you slowly start eliminating your audience, then hopefully you have condensed the population. But it's just like we said earlier with the runaways. How do you get them to talk to you? Those are your victims. They're the victims, but these are all the people searching for these victims. I mean, on any given day, this world is over sexualized, so you can click of a button, find anything you want in instant gratification. So you have to slowly start taking that away. And so once they're caught, which is way down the road before they're a sex offender, that's how we eliminate it. That doesn't mean between point A and point B that you're going to save a ton of people, but eventually everybody has to be accountable. And once they get caught, it is impossible. And the sex offender programs in these cities, Lubbock, every city has one. Somebody's in charge of every sex offender in every state and every city and every county in Texas. Somebody has to be in charge of those people. They have to keep tabs on these people. And we have made it very difficult, particularly in Lubbock, to we put you out on everything that we can. Before I get too far ahead of myself, but some of these sex offender cases, they retroactive law all the way back to 1972. So, I mean, that's a long time ago. I was investigating a child sex abuse case between two brothers one time, and the grandfather just struck me as something's wrong with this guy. And I found out later on that he was an actual offender, and he had never been registered because his offense was back in 1974. And so through that, I was able to put him into the sex offender program, into the sex offender registry, based off of an unrelated investigation. So it takes an army of people to control a handful of people. And that's unfortunate, but that's the world we live in. So what do you do with like some sex offenders that come into town from other areas? Well, they have to have a similar substantial offense. So case in point, Colorado uses the word rape cases. We don't use the word rape, it's sexual assault. So if they have a first-degree rape case, that's the same thing as an aggravated sexual assault case here. So that means they're a lifetime registrant. And so what do we get this authority to file the cases, and what makes the authority? The Texas Code of Criminal Procedure, Chapter 62, is the governing body that allows for the prosecution of the convicted sexual predators. And it is a long chapter, and it's boring, and it's written by lawyers. So it takes a lot of reading it over and over and over again to figure out what does what mean, because what could mean something else on the next line. And so it's not simple. It's very long, and it's a process, and it takes a couple hours to just register one individual. And you have to realize that these guys, they've gone from, the hustle all the way to the pen. So then they have to hustle their own life, because everybody's gonna find out what they did in the pen. And you would hope that street justice still survives, but it does not anymore. In today's pen culture, it doesn't matter what you did on the outside. You're in here now, so now you're in survival mode. So you click up with whoever you can in the pen to get through. The old wives' tale is that, they're gonna find out they're a child molester and they're gonna kill them. No, that's not what happens anymore. Because in fact, we all know what goes on in prison. So it is what it is, and there's not an easy answer for it. So what we do is we make them jump through hoops when they get out. Chapter 62, if you're really bored, the Texas Code and Criminal Procedure is an excellent chapter, and it's important to medical people as well. And here's why. So we have so many different levels, and the condensed version of this is you have federal crime, you have state crime, right? And so sometimes your federal crime links into your military and your tribal crimes, and they all mean something different. Well, at the end of the day, it's still a crime. So some of the acronyms we use in the sex offender regulatory area is a post-10. So believe it or not, if you attempted anything, you attempted to make contact with a underage girl on the internet for the purposes of having sex, you're only going to have to register for 10 years. It's insane. I don't understand how this happens. But if you own a picture of that same girl, you're going to register for a lifetime. It doesn't make any sense, because to me, attempting to make contact with that child to have sex should be a higher offense than just mere possession of a picture. I didn't make the law. So you have what's called a post-10, a post-15, and 25, and so on. And all those, anytime you see a post 10, 15, post 10 is pretty common, but a 15 and 25s, those are all military and or a federal offense. So you break it down, if they mess up with their fail to comply, they're going to get a state jail felony. All right. So the minimal charge is a state jail felony. That is the baby felony. You know, you get a speeding ticket, that's a Class C misdemeanor. Then you break all the way up to a Class A misdemeanor, and then your first felony mark is a state jail felony. So your post-tenure individuals that are registered sex offenders, they mess up that first time, who knows what they're going to get. That's where the pressure has to come from the outside agencies. The pressure has to come from the people that live in these communities and say, hey, there's not enough. And you got to put the pressure on the district attorney's office, because they're the ones that are prosecuting the cases. And they're the ones who could put, you know, a state jail felony charge. And sometimes due to prison population, they may only serve 3 months and come back out. So all your other registrants are lifetime. So, and it breaks it down. It's a huge list, and I couldn't go one by one because there's the what if factor. What if this, what if that, what if. Well, we can what if everything to death. But on a general rule, say a common, a guy and a girl, not a Romeo and Juliet, the 3-year deal, but let's say a 21-year-old has sex with a 12-year-old. Well, he's going to get convicted of indecency with a child or child sexual assault or aggravated sexual assault of a child. And then he's going to wind up being, once he serves his time in prison, when he gets out of prison, he will be a lifetime registrant for the rest of his life. The registrar know they're in the city they move to. If they travel more than 3 days, they have to let somebody know. The rules are stiff and they're hard and they're difficult. If they change phones, if they move within the city from one street to the next, they have to let us know. And it's a pain, but we want that to be a pain for them. We don't want it to be convenient. And they're like dealing with little kids. They're the most high maintenance individuals you've ever met in your life. And everybody's out to get them, and it's somebody else's fault. But that's just because they are the predator. They are the predator. We have all the human trafficking, but we slowly get rid of the predators and make it so difficult after the fact. Maybe it's not as elusive. Who knows? But most of your annual registrants, they're second degree. Now, let's say you have a human trafficker that has finally been convicted of compelling prostitution, and he has multiple cases. Well, that's still not enough to make it a higher annual deal. So you're going to have to get with your legislators and enforce that issue, because human trafficking isn't the same as sexual assault of a child, even though it is. It's all in how they're, I just went blank on the word I was looking for. It's all in how they're after they've been charged and they've gone to prison. Yeah, anyway, okay, it'll come back to me. How their conviction, that's the word I was looking for, how their conviction reads. If their conviction says it was sexual assault of a child on 3 accounts, then they're a 90-day registrant. They have to come and see their registrar every 90 days. So it's very difficult on them for a reason. However, and I can tell you in Lubbock County, we have a ton of sex offenders. So I don't know how many exactly are in the county because I didn't run their numbers, but on average, they have about 200 that live in the county. The city limits of Lubbock alone have 755 registered sex offenders. And about 10 of those are classified as homeless. Now that number stays a pretty constant, and it doesn't go up or doesn't go down by much, but it is a constant number, I assure you. And so there's only 2 people in charge of all of them at this time. I was one of them. I've moved out of that environment and moved into a different division. However, there's still only 2 people doing it. And it's a full-time job for one man to answer the phone and deal with every sex offender. If you look on this link, I don't know if you'll have access to click on it later on, but if this child safety zone map in Lubbock, if you can click on that, if it's interactive, or if you want to take a copy of that, you can type your address in and you'll see if you're in what's called a child safety zone. Let me tell you something about this map, okay? It is interactive, but it's a child safety zone map. It is not a sex offender free zone, Okay, you can still be a sex offender and live in a child safety zone. So if you type in an address on this, you're gonna see all these little blue bubbles pop up. That blue bubble is a child safety zone. So what that means is if there's a sex offender that has a child victim living in that deal, it's a city ordinance violation and a city ordinance violation only. So it's a ticketable offense. And there's a lot of stuff that goes into that. However, there's no such thing as a sex offender free zone. You can have maybe an HOA that says that. They tried that once over at like 34th in Milwaukee. I don't think it went very well. But that is a good map. And I'll tell you right now, that same map is the same thing as a drug-free zone. They're one and the same. Anything within 1,000 feet of a daycare, anything within 1,000 feet where children commonly gather, anything within 1,000 feet of a school. But some of these guys are such professional criminals. One guy goes, that's an LISD warehouse. I can live there. There's no children. And he's right. So we had to take that bubble out of there. So the other thing that I think nurses and nursing staff in the nursing world miss out on is this DPS sex offender website. This is probably one of the most useful websites you'll ever see. And I think, and I only say this for your knowledge and your knowledge only, because if you have a child, if you have a patient and names start popping up and you start wondering, and you're like, how can I do anything with this? Well, you can notify people. You can go this is all public information. You can go to the sex offender registry. You can type in an address in Lubbock and it'll show you how many sex offenders live near that address. They put a pin mark everywhere go. You've always heard of the postcard notification. That's antiquated. They still make them do it because the great state of Texas still is behind in the times and thinks snail mail is a good idea. But it's not. This website's much more effective. And I think if it was publicly shamed more, which it should be, it would be a better deal. And I probably should have said this at the start of this, I'm not representing the Lubbock Police Department on this topic. These are my opinions and my experiences through dealing with these cases. I don't have quite the case studies that Davila has, but I have investigated numerous cases involving child sex assault and adult sex assaults. And so even as an adult victim, you can still become a sex offender. I want to throw that out there as well, just so everybody understands anything that involves a sex crime does make that person eligible to become a sex offender later on. I know that was a quick rush overview, but I think we've missed the mark. And I think everybody in the healthcare industry needs to know about the sex offenders and how to report them and just say, hey, something's going on. And it starts here because the victims show up here first, and it's all interconnected. I promise you. The sex offenders that we deal with in Lubbock are all the way from the true pedophile all the way up to the sex trafficking pimp. So, and then there's a handful of everything in between. So I'll open that up for any questions if there's any.
I had a question. I read in the news, I believe it was about a year ago, about a family, I think in the Dallas area, that was trying to advocate for getting education related to sex trafficking when you renew your driver's license, or maybe when you receive your driver's license the first time. Have y'all heard anything about that, or was that just a wish?
I don't know anything about that.
Are you talking about mandates of classes you have to take to get your license? So I know that that's been discussed. Last I checked, there is mandatory video training that you have to take now as a first-time driver, but it's basically the heads-up distracted driver training. You have to watch a video and you have to complete that and show that certificate before you get your license. But yeah, they have brought up, mandating certain training like that for first time, but I don't know where that stands right now.
Okay, I don't believe we have any other questions. So thank you all so much, Trey and Davila. We really appreciate that. We want to thank all of the participants for attending the conference today, or if you're going to be attending at a later time. An all-day virtual conference discussing abused and neglected children can be a little bit difficult. So we really appreciate everyone's attention and dedication. A few clarification points. The video video on demand function will be available next week. So there will be a link sent out for that. And then it will be available through June 8th to watch and continue claiming your continuing education credits. Remember that you must complete and submit the evaluations, and then you will receive an email with your CE or attendance certificate. So while I'm finishing up here, we're going to have these two ways to do your evaluation on the screen. One is for live event, the people that are participating today, and then the other one is for the ones that will be watching it virtually. So we would like to thank Covenant Children, South Plains Coalition for Child Abuse Prevention for sponsoring this event. We did want to mention we've had several requests for the slides. Due to the content on the slides, we are going to be working on putting that on a secure site. Davila was not able to share hers due to the DPS regulations, and we completely understand that. But we will be, again, sharing those as soon as we can get a secure site set up for those. Thank you again for attending and having the passion to care for our vulnerable children. We hope to see you in person next year.